respected chairperson, delegates, and faculty. So coming to the first talk, that is on MRI and arthroscopic anatomy of the knee, I will cover a little bit about the tear of the meniscus and ACL, how to identify that in MRI and how does that look in arthroscopic view. So we all know that what is the basic difference between MRI and arthroscopy is that we can see both the intra-articular and extra-articular structures through the MRI, whereas arthroscopy can only evaluates the intra-articular structures. So we cannot comment about the pes anserinus, the superficial MCL, popliteal cyst, what are the changes they are inside the bone, and if there is any synovial based lesions like posterior to the PCL or those lesions which are there confined to the popliteus tendon, it cannot be revealed through the arthroscopy. So that is the major disadvantage of arthroscopy. It can only tell about the intra-articular part, mainly the articular surface, ACL, PCL, MCL, and a few other structures in the posterolateral column. So what lacks in MRI then what is the problem with MRI is that it lacks dynamicity. So if there is any partial tear there in the ACL or any ligament, or if there is a lesion there in the meniscus, we cannot say that whether that particular lesion needs intervention or not, because there is a lack of dynamicity in that. So lacking of dynamicity is the major problem with MRI, although dynamic MRI is nowadays available, but it has certain limitations. So these are the techniques that we normally adopt for MRI evaluations of the knee joint. And we need to obtain all the cut section, particularly the coronal, sagittal, and axial cut sections, as well as fat suppressed images. And this is how it looks, the basic pulse sequence for all this: T1 weighted image, T2 weighted image, fat suppressed T2 weighted image, gradient echo, and proton density. And if you see how these structures look in this structure, then in a T1 weighted image, we all know that fat is brighter, whereas water is brighter in the T2 weighted image. Likewise, in the gradient echo also, you can see intermediate signals, particularly for all this fat, water, and the proton density also shows gradient echo. So for any basic anatomy, you need to see the T1 weighted image. And once you find any abnormality there in the T1 weighted image, then you go to the T2 weighted. And particularly for if you are dealing with a cartilage problem, you need to see the gradient echo. And if you want to see particularly the problem of the meniscus, you need to go with the proton density. And these are quite easy to see that in the MRI, that what are these echoes, particularly if you look the subcutaneous fat, if it is white, probably you are dealing with the T1 weighted image. If it is the water is bright, that is the T2 weighted image. And if you see intermediate signals there in the fat and quite black or the hypointense in other structures, probably you are dealing with the gradient echo. So this is how we interpret the MRI, particularly for the how to interpret MRI. First, you need to see the pulse sequence, look for the normal anatomy in the T1 weighted sequence. And if you find any abnormality, any non-homogeneity in any part, then you look for the T2 weighted image. Cartilage lesion, go for gradient echo, and meniscus, you need to see for the proton density. So this is how the normal anatomy looks like in MRI. You need to see the lateral head of gastrocnemius, popliteal artery, quadriceps tendon. You all can see that if you know the anatomy, then you can see these structures. And for the ACL structures, the black band that runs from the intercondylar eminence to the femoral condyle, that is the ACL. PCL is just below the joint line in the tibia and it articles to the femoral condyle. Middle head of gastrocnemius, that all you can see through the MRI. This is how the femoral condyle, fibular head, biceps femoris, ligament of Humphrey, Risberg, all this looks like an MRI. And you can see the ACL and PCL depending on their attachments. And you look particularly at those femoral condyles. This is the axial cut sections where you can see the middle retinaculum, lateral retinaculum, PCL, and the patellar tendon. And the major problem happens particularly for the residents and all these delegates, that how to look for the meniscus, whether it is a lateral meniscus or medial meniscus. If you are dealing with the lateral tibial plateau, it is convex on the upper part. Whereas if it is concave on the upper part, that is the medial meniscus. So if you see here, it is that means it is facing upward like convex, whereas it is concave here in the lateral side. So these are the two basic points by which you can say that this is lateral meniscus or medial meniscus. And then again, you can see the anterior horn, posterior horn. And for the ACL, we all know that ACL is not a straight structure. It is oblique structures. It is 15-degree externally rotated. So when we take a cut section, particularly in the horizon, that is in one plane, like the horizontal plane or the vertical plane or axial plane, we cannot see the images of ACL in all cut sections. For that, you need oblique cut section, oblique around 15-degree, oblique sagittal, and your axial cut section are best to determine the ACL cuts in 10 to 15 sequences. So this is the arthroscopic view of quadriceps tendon. When we go in the subpatellar recess, particularly we go to the suprapatellar pouch, then we see the quadriceps tendon. We come to the lateral side, we see the lateral femoral condyle, the peripheral part of the meniscofemoral junctions, and your populus tendon can be seen. On the medial side, you can see the middle femoral condyle. In the subpatellar recess, what you can see that there is a fold here. If you see such type of fold which comes from the medial capsule and go to the infrapatellar fat pad, these are the medial plica. So sometimes these are visible, and this is how it looks like in MRI. So these are called as medial plica. And if the patient is symptomatic for that, probably you are dealing with a medial plica syndrome. So this is ACL. You can see this is the lateral side, this is the medial side. So this is what the ACL runs here. And this is the arthroscopic image, how it looks. And this is the posterior cruciate ligament that you can see. This is, I have already mentioned that this is a concave upper surface. So there is on this side, this is convex upper surface. So this is medial femoral condyle. And this is the lateral femoral condyle. Now, another maneuver by which you can go to the posterior part, posterior to the PCL, is the Gilchrist maneuver, by which you can negotiate your scope between the posterior cruciate ligament and the middle femoral condyle and see the posterior part of the PCL and look for the ramp lesion, particularly the middle meniscus and at the menisco-capsular junctions. So coming to the knee pathology, how we identify these structures in MRI, I've already mentioned how to identify the lateral meniscus and middle meniscus. Other structures that you can look is the obliquity of the femur, because the femur is bowed towards the lateral side, so that you can see and say also this is the lateral side and the middle side. Another point is you should look for the fibular head. So other than convexity and concavity, these are the other points. Now, how to classify that the meniscal lesion in MRI is based on their lesion size. Suppose if it is a intrameniscus globular lesion, that is type 1 or grade 1 injury. If it's a linear lesion, that is grade 2. And if you see a complete lesion which is articulating to one of the surface, then this is called as grade 3 lesion. So you can classify the meniscal lesion grade 1, 2, 3 based on their MRI findings. So a classical example MRI, how it looks. So this is a globular lesion grade 1, not communicating to the articular surface. This is a linear lesion grade 2. And here you can say it is communicating to the articular surface. So this is grade 3. So this is how you can classify the meniscus. Now coming to the type of or pattern of injury, you can say what is the horizontal injury or vertical injury or complex injury. So I'm not going to tell how it looks or what are the patterns, but here you can see these are the sequence. When you find such a tear, you can see radial tear, 1 or 2 sequence. If shows such type of lesion there in the meniscus, probably you can say that this is a meniscus tear. So, but here it is convex. So this is looking like this. So probably you are dealing with a lateral meniscus radial tear. Now, longitudinal tear, particularly here, you can find on both the cut section, you can find such type of tear and see the image here. This is the lesion, this is the lesion here. And when you see a parrot beak appearance, here you can see it is a little bit oblique and looks like this, particularly the first image. And these are the complex tear where there is a mixture of all these tears. Bucket handle tear, this is the classical MRI picture that you can find when one of the fold of the meniscus is trapped in the intercondylar notch and it is trapped between the postocondyle PCL and the middle femoral condyle. So this is in the coronal cut section, this is the fragment. And here in the sagittal cut section, you can find another fold there just anterior to the PCL, and that is called as double PCL sign. So if you find such things, then you can say it is the bucket handle tear. These are the arthroscopic views, like root tear. You can see the complete radial tear. This is a bucket handle tear where it has come into the notch. This is a meniscal longitudinal tear. And here you can find the horizontal cleavage tear that you can find particularly in the degenerative conditions. And these are all the mixture of the lesions where you can find the complex meniscal tear. So this is how it looks on arthroscopy. These are anterior meniscus. So how to identify the discoid meniscus from MRI? So discoid meniscus are usually when you can find the radial diameter of the meniscus more than 12 millimeters. That means in 3 consequences or 3 sagittal slices, if you find 3 or more cut section, if you find the meniscus, then probably you are dealing with a discoid meniscus. And there is a loss of tapering and it is uniformly thickened. So just see here, it is uniformly thickened. And if you take 3 cut section also, you can find the meniscus. Otherwise, in 1 or 2 cut section only, you will find the meniscus. So this is how the meniscus looks like. You can see the MRI pictures, parameniscal cyst here on both the conditions. Pseudomeniscal tears are sometimes you can find a cleavage or the particularly that is called as a Risberg rib. We all know that PCL on the anterior side, there is a ligament of Humphrey. On the back side, there is a ligament of Risberg. And it is very close to the posterior horn of the lateral meniscus. So sometimes a fluid cleavage can be seen between the ligament of Risberg and the posterior horn of the lateral meniscus. And that can give rise to a false sense of meniscal tear. That is called a pseudomeniscal tear. Similarly, on the anterior side, you can find that between the medial meniscus anterior horn and the transverse genicular ligament or the transverse meniscal ligament, you can find a cleavage that is called a pseudomeniscal tear. So when there is a gross effusion in the knee joints, you can find such false filling of meniscal tear, and these are called a pseudomeniscal sign. So this is the overall sensitivity of the MRI in diagnosing medial meniscus tear. It has a very sensitivity in diagnosing medial meniscus tear, whereas it is a very sensitivity in lateral meniscus tear identifications. And now coming to the ACL, what you should look for the ACL in MRI is the obliquity of the ACL, how it is coming from the anterior part of the tibial eminence and going to the femoral condyle. So this you see in the sagittal cut section, coronal cut section, as well as the axial cut sections, and look how it is attached. And what are the primary signs? If you know the primary signs and secondary signs of ACL tear that you can see in the MRI. One is non-visualization of the ligament. You cannot see anything in the MRI pictures. Second is complete disruptions. Third is abnormal signal within the ligament. Sometimes there may be tear and it has healed through the mucoid degeneration, all these things. And there may be a thickened ACL that you can find giving like to a celery stalk appearance or mucoid degeneration or myxomatous degeneration of the ACL. Alteration of the normal linear configuration of the ligament and alteration of normal ligament orientation. So it is not oblique. Sometimes it may fall. So the acute angulation of the ACL will be there. These are the primary signs of the ACL. And these are the secondary signs of ACL, where you can find bone contusions, deepening of the lateral femoral, or this is called as deep terminalis sulcus sign, anterior translation of the tibia more than 5 millimeter, buckling of PCL, or the posterior displacement of posterior horn of lateral meniscus. These are all the secondary signs of ACL tear. Now just see how it looks. So this is how the ACL coming from the lateral intercondylar eminence. And if you see on the MRI, it arises between the 2 eminences, the medial and lateral tibial spine. This is the ACL fossa, and then it goes to the middle part of the lateral femoral condyle. This is the ACL orientations. And there are 2 bundles. We all know that anteromedial and posterolateral bundle. So this is all based on the tibial attachment side. The medial one is the anteromedial bundle, and the PL bundle is the lateral one here in the fossa. So this is how you can identify whether it is a anteromedial bundle or posterolateral bundle. And here you can see there is a webbiness or buckling of the PCL here in particularly in this. So this is buckling PCL or webby PCL, indirect sign of ACL injury. This is how the ruptured AM bundle will look. This is how the ruptured PL bundle will look. And this is how sometimes you can find a cyclop type of lesion in the ACL. And here, sometimes it is completely detached from the femoral attachment side also. So these are all the arthroscopic views. Now ACL avulsion, you can find one bony fragment there. The mid substance tear, this is one of the proximal ACL tear where it is completely detached from the femoral attachment side. Interstitial tear, these are the chronic ACL tears showing. This is the stump of the ACL, it is scar to the PCL. So it is going and attached to the PCL here, and here is a buckling PCL here. So this is how you can see, this is the PCL segment. So these are all the findings of ACL tear. And coming to this, sometimes it may heal with a ganglion cyst also. And isolated, how to identify the isolated tear? There are 2 signs. One is called as gap sign, and second one is the footprint sign. So when you find one sign here, particularly look for the between the 2 eminences. If there is a whitening structure on the lateral side, probably you are dealing with a PL bundle. This is called as footprint sign. Here, medial side, this is anteromedial bundle is intact. Here on the lateral side, this is the PL bundle. Here it is whitening is seen. So this is called as footprint sign. And this is called as gap sign. When you find a linear white structures from the lateral femoral condyle and the ACL, this is the white structure. This is called as gap sign. If you find such things, then probably you are dealing with isolated PL bundle. So PCL injury is less common associated with other injuries. You can see for the PCL because it is very clearly identified. It is a vertical structures. You can find a partial PCL tear, complete PCL tear. Here it is completely seen. PCL avulsion also you can identify easily from the MRI. You can see here is a bone fragments. And this is the sensitivity and specificity of MRI imaging in identifying the ACL tear. It is almost more than 95%. So final request that you should know the anatomy of the knee properly to look for that in MRI. What the mind doesn't know, the eyes cannot see, and MR interpretation may be wrong even after years of training. But remember that every time one should go for the arthroscopic correlation, and follow-ups are of great help to improve the diagnostic accuracy. So what you are seeing in the MRI, you just correlate with the arthroscopic finding. So at the last, this is the, I would say, we request everyone for support to Bhubaneswar for IOCON 2025. Thank you.
Thank you, Sujit. Excellent presentation. We'll have the questions at the end of the session if we have time. Now I invite the next speaker, Dr. Sandeep Lenka. The topic is portal placement and diagnostic arthroscopy. Sandeep.
Good morning to everyone. So the topic of discussion is portal placement and diagnostic arthroscopy. So we know that knee arthroscopy is most common arthroscopy procedure required for an orthopedic surgeon. It has its own diagnostic and therapeutic tool. So what are the indications of knee arthroscopy? The indications are, first one is the diagnostic scopy, then irrigation and debridement, ligament reconstruction, meniscus repair and dissection, partial or complete meniscectomy, loose body removal, synovial biopsy or synovectomy, chondroplasty and microfracture. So before our portal placement and diagnostic scopy, first thing is the OT setup. So we should be aware of the patient position. Where is the anesthesia station? Where will be our tower 1, tower 2? I will explain further. And what are the positions of the surgeon, assistant, scrub nurse, and our trolley? So the instruments setups are along with our general instruments, the towers. What the towers contain? The towers contain the saver system, light source, camera, the monitor, the pump system, and the radio frequency ablation system. So these constitutes the tower system. So scopy is instrument related surgery. So without proper instrumentation, proper scopy can't be possible. So first is patient selection, second is arrangement of instruments, then third one is the surgical part. So what are the patient positioning? Supine position is most commonly we are using, and before surgery always try to examine under anesthesia the varus, valgus, whatever routine examination we are doing in our routine OPD checkup. Again, we have to confirm after anesthesia and before surgery. And proper tourniquet placement is the most important thing. You know, knee scopy is a bloodless surgery, so if proper tourniquet positioning and proper tourniquet application is there, then we can proceed for a good vision and good surgery. And we can use the leg holder or lateral post. So there are different leg position. We can keep the leg in extension, in normal flexion, just like we use the TKR position, or hyperflexion. So the surface anatomy. In the surface anatomy, first we have to, with the marker pen, we have to mark the patella, the outer surface of the patella, the ligamentum patelli, the tibial tuberosity, the border of the femoral and the tibial joint line. So surface marking is the primary thing to proceed before our portal placement. And the knee portals, there are 4 standard portals and multiple accessory portals. So most common and the universal portal is the anterolateral portal, then anteromedial, posterolateral, and superolateral portal. Different accessory portals are posterolateral, proximal mid-patellar, far medial and far lateral, and central transpatellar portal. So anterolateral portal is the standard viewing portal, and the scope is first inserted through it. and it is the most versatile portal. So the point is 1 centimeter lateral to the patellar tendon, 1 centimeter inferior to the inferior pole of patella, and almost all structures are visualized through the anterolateral portal except the tibial insertion of the PCL and some anterior horn structures. So regarding the portal, the anterolateral, we have to remember before giving portal placement. It is 1 centimeter above the joint line and 1 centimeter lateral to the edge of patellar tendon. You have to remember. Then anteromedial is 1 centimeter above the medial joint line and 1 centimeter medial to the edge of the patellar tendon. The posterior medial portal is the triangular short spot between the posterior medial edge of the femoral condyle and the tibial condyle. And the superolateral portal, it's passed through the quadriceps tendon. It's 1 inch or 2.5 centimeters superolateral to the corner of the patella. So anteromedial portal is 1 centimeter, as I told before, is 1 centimeter above the medial joint line and 1 centimeter inferior to the tip of the patella. Superolateral portal, we have to mark a point 2.5 centimeter proximal and lateral to the pole of the patella, superolateral pole of the patella, and we have to make it. Posteromedial portal, which is most commonly we are using for PCL and ram tear or any posterior medial or posterolateral structure tear. It's a triangular short spot between the posteromedial femoral condyle and the tibia, 1 centimeter above the posteromedial joint line. And the knee should be flexed at 90 degrees for posteromedial portal. Different accessory portals are posterolateral portal is there. Then another one is the proximal mid-patellar medial and lateral portal. And another interesting portal is our central transpatellar portal. It passes through the patella and it is 1 centimeter inferior to the lower pole of patella, and along with anterolateral and anteromedial portal, transpatellar portal is used mostly in case of meniscus resection, meniscus repair, and other portals are the positions. So how to proceed for the diagnosticoscopy? So first, the universal or most versatile portal is the anterolateral portal. After anterolateral portal, we have to enter inside the knee joint. So first, what we have to see is our suprapatellar pouch. So suprapatellar pouch, you must be aware day-to-day OPD practice, you are giving injection or doing aspirations of any knee collection through the suprapatellar pouch. So without any fear, we should proceed towards the suprapatellar pouch. Then sequence is, you have to go to the medial gutter, lateral compartment of the knee, medial compartment of knee, intercondylar notch. Then we have to proceed for the posteromedial and the posterolateral compartments. So this is the sequence, and you have to diagnose the disorders like meniscal, synovial, ligamentous disorder, articular pathology, and loose bodies. So what are the things we have to observe? In suprapatellar pouch area, first thing is loose bodies, plica, or any loose body from the control. So first thing is triangulation and holding the scope. Then after superolateral, anterolateral portal, we have to proceed for anteromedial portal. So these are the different structures like patella, trochlear groove, femur, tibia condyle, ACL. In the diagnosticoscopy, the right side image is the meniscus and the left side is the patella articulating over the trochlea of the femur. So these are the different compartments. These are the lateral gutter, medial gutter structures, medial compartment of the knee. Then we have to examine. We have to examine the medial meniscus. We have to examine the lateral meniscus. We have to examine the ACL, PCL, the fibers, how much fibers are there, whether they are turned or not, the articular cartilage, any damage is there or not. So ACL, PCL, these structures should be identified. This is the video. think it's not working. Okay. So on completion of the scopy, we should check regarding the swelling of the knee joint, swelling of the leg and the thigh, and we have to remove the extra fluid and to close with suture material. So thank you, and seeking all of your support for IOCON 25th. The venue should be at Bhubaneswar. So kindly support.
Thank you, Dr. Lenka. So the next speaker is our guest faculty, a dynamic lady, all the way from Nagpur. She has come all the way from Nagpur, Dr. Neha Godgate. She will be speaking on graft options and fixation methods in ACL reconstruction. Dr. Neha, please. I think she is the woman representative from IAS. Dr. Birari. Okay, thank you. Thank you.
Is the president of Women Knowing IAS.
Good morning, everyone. First of all, I would like to thank Indian Arthroscopy Society and Odisha Arthroscopy Society for giving me this opportunity to present in front of you all. I'm Dr. Neha Godgate. I work in Nagpur. Today, I'll be presenting on graft choices and types of fixation in ACL reconstruction. So if you think of ACL, we all aim to reconstruct that ACL according to the native ACL. So we have these various graft types, autografts, allografts, and augmentation. In autografts, we have various options: BTB, hamstrings, Peroneus, and Quadriceps tendon. So in next few sessions, our eminent faculties will be giving the video techniques of all the graft harvesting. So what is perfect? Perfect is corresponding to an ideal standard. So a perfect autograft is equivalent to the cell morphology of that autograft should be equivalent to that of native ACL. The biomechanical strength should be equal or maybe stronger than the native ACL. The dimensions should be almost equal to the native ACL. It should suit all the ages. It should have a low morbidity at the harvest site, and it should be easy or fast to harvest. So let's see these biomechanical properties of various grafts. So if we see, quadruple hamstring tendon has got ultimate load to failure and stiffness, which is almost double the native ACL. And the quadriceps tendon has got the highest cross-sectional area. Though quadruple hamstring tendon has got lower cross-sectional area than quadriceps tendon, it is bigger than the native ACL. So in India, the preferred tendon is generally quadruple hamstring tendon graft. So is the length sufficient? Yes. The generally soft tissue grafts have got better lengths. In that, the Peroneus tendon has got a good length in general. So ease of harvesting is better with soft tissue grafts. But in case of patella BTB graft, we need more skills to harvest the BTB graft. The healing potential of soft tissue grafts is soft tissue grafts are more vulnerable. So generally they heal at the aperture healing. So during that time of healing, the soft tissue grafts heal little late. So during that time of healing, we need to protect those grafts. We need to protect the patient from wet bearing till the graft heals properly. But this is not the case in BTB because it is bone-to-bone healing. So the short-term healing is faster in BTB rather than soft tissue grafts. However, if we see that most of the BTB graft harvest site have got more morbidity because most of the patients will complain of anterior knee pain, especially while kneeling down. This is not the case in case of soft tissue harvest. So morbidity at soft tissue harvest is less than BTB. There are these synthetic grafts have been newly launched in India. They claim that biomechanical properties are almost like native ACL. However, the long-term follow-up is yet to be, the efficacy of that synthetic graft is yet to be confirmed by long-term follow-ups. So to summarize the graft choice, the biomechanically quadrupled hamstring is, it has got highest ultimate load to failure. The Peroneus has higher length. BTB has got better healing. Extra articular augmentation helps reduce re-rupture of and residual pivot shift. So this was a paper, it was a systemic meta-analysis. It was a systemic analysis by Macaulay. It gave the clinical recommendation and showed that long-term stability seemed equivalent. There is no difference in passive ROM and ability to return to sports, and graft type did not influence patient satisfaction. So now coming to graft fixation. Why is it important? This was a landmark paper by Kurosaka in 1987, and they studied various fixation methods and their relation with the graft failures. And they concluded that the weakest point of failure is at fixation site. So this fixation device should support the graft till it heals at the aperture site. So the graft fixation options are suspensory fixation and aperture fixation. So this paper by Krum showed that the suspensory fixation and aperture fixation in both femoral and tibial tunnels are equally efficacious based on clinical outcome data. So let's see interference screw. This is a widely accepted method of fixation in tibial tunnel because it has got direct fixation in the tibial tunnel where it pushes the graft to the wall of the tibial tunnel. It also has got less graft elongation and less tunnel dilatation. However, we find these disadvantages. The most feared disadvantage is graft abrasion or graft laceration, because of which there might be suboptimal loss of fixation strength. So this Teng et al. In his in vitro study, they showed that after insertion of interference screw, there was a microscopic damage to the graft. So these are the factors which are influencing the interference screw fixation. They are screw related, technique related, and patient related. So longer the screw, better is the fixation. The diameter of the screw should be at least 1 mm more than the tunnel diameter. The torque of the screw insertion is important. More is the resistance to insertion, better is the fixity of that interference screw. And divergence of the screw more than 20 degrees, especially in femoral tunnel, which used to be there in cases of transtibial fixation, it will cause decreased tensile strength. And definitely the bone quality of patient has to have effect on the screw fixation. The graft fixation options are of interference screws are metallic screws, PEEK screws, bioabsorbable screws. Metallic screws are less expensive and they are more proven. However, bioabsorbable screws have advantages that there is no disturbance in post-op MRI. There is less graft laceration and it is comparatively easy for revision. So these are the suspensory fixation. On femoral side, the suspensory fixation are closed loop or adjustable loop, and on tibial side, it is suture disc. So suspensory fixation, first generation was closed loop and second generation was adjustable loop. So there are so many options, which one to choose. So these all meta-analysis showed that in long-term follow-up scores are equivalent in various fixation methods, and re-rupture rates are insignificant. There is insignificant difference. And there is no difference in ROM and return to sports. So basically, the graft choice and fixation choice should be it varies person to person. It should be done whichever good is in your hand. So, thank you.
Thank you, Dr. Gadgate. The session is now open to questions. We will, you please stay here. Can I request the other speakers, Dr. Sujit Tripathi and
Can I ask a
Lenka?
question?
Yeah.
Neha, I just wanted to learn that what is the indication of the BTB graft? As you told very correctly, it is a very difficult or maybe needs a little more skill to harvest the graft and more complication to the entire knee pain or something. So what are the indications? Nowadays, most of the people are using the soft tissue graft.
Yes, sir.
So what are the indications left for the BTB?
So in my knowledge, only two indications I would say they are left in BTB. One is a sports person with hyperlax knee. There we can use BTB graft, which is stiffer. And second thing is a young lady with hyperlax knee. And the second one is the contact sports person, where they want to join the sports as early as possible, because the tunnel healing or the graft healing is faster in BTB.
I think, thank you very much. Very nice. Sujit, are you here? Yeah. So I have a question for you also. That is there any advancement of the MRI now for the differentiating from the chronic and the acute meniscus or meniscus root tear?
See, many people are using the 3 Tesla MRI is better because it gives more contrast. Second, if you want to see the pathology there in the meniscus, you should ask the person, that is the radiologist, to give the proton density sequence. Those are very essential for the meniscal lesion. And we don't want to go into details of the technique and how they do that. But the proton densities are very good for the meniscal pathology. And nowadays in Western country, they are using the 7 Tesla. So in acute setting, when there is a gross hemorrhage there inside, the hemarthrosis is there, in that condition, it is very difficult to identify certain meniscal tear because of this effusion. It may mislead us that there is a meniscal tear. But with the 7 Tesla, they are saying that you can identify even in the acute setting some of the meniscal tear. But those are not available in our country, but we can still go.
Yeah, it's not available, I think.
3 Tesla, we can go.
Yeah, so very difficult, I think, to say differentiate between the acute and the chronic scenario by MRI, I think.
It's very difficult. So MRI will be, the sensitivity and specificity will increase, particularly specificity will increase if you do it after 6 weeks.
Sandeep, are you here? Lenka.
Paresh, can I ask further your questions? Sujit, I wanted to know whether by doing a contrast MRI, would you be able to differentiate that?
No,
Paresh?
sir.
Yeah.
Contrast also, again, it will be taken by the fluid. That means it will be seeped into the joint. And it is, again, very difficult to differentiate whether it is a tear or because of the effusion. So
Okay.
I don't think that contrast will solve that.
Okay.
So I just wanted to clarify this. Another question for this Sandeep is not here, I think. He told that the anterolateral portal, which is the viewing portal or the first portal, that is the at the level or at the 1 centimeter above the joint line, and it should be 1 centimeter below the lower pole of patella. So I just wanted to clarify, Sandeep. So anterolateral portal, I'm just asking for you this question.
Sir.
This anterolateral portal you have mentioned, it should be the 1 centimeter lower to the lower pole of patella.
Yes, sir.
Or just I wanted to learn from the guest faculty, learned faculty here, this national faculties. It should be at the lower pole of the patella at the line, or it should be lower to that lower pole of patella.
Sir, actually, we can give it high or we can give it in a normal position.
What
Suppose
should be the standard for the learner? I'm asking that question. It should be very clear
the
from the.
standard point should be the soft spot, sir. The soft
Is
spot.
okay, soft spot at the line of the lower patella, or it should be lower to the lower end of patella.
Lower to the lower end of patella, sir.
Rajiv, are you here? Are you listening to it?
Yeah, so I always prefer high portal for both my ACL and PCL to avoid the fat pad. And most of the time it's just medial or lateral to the patellar tendon. So always that palpate the bone, the medial and lateral patellar, the patellar tendon, and my standard anteromedial and anterolateral portals are very close and high up.
Yeah, mostly PCL, we are using the high
Yeah,
level.
and
high level.
Vikram?
The higher, the better for an anterolateral portal, because ultimately when you're doing your tibial footprint, when you're drilling through your tibial, you should be able to look down. So for me, actually, it's much higher than the lower pole of the patella also. Just along the margin, the lateral facet of the patella, that's where I like to put my portal for ACL reconstruction.
Okay.
For PCL, you can be lower. It doesn't matter. Lower actually is better because you can go through the notch. It's easier to go through the notch at the end.
What happened when you are doing PCL, you have to put your scope through the notch and to reach the posteromedial compartment. So I think if you are a bit lower for that, that will help you out.
Even for root repairs and the posterior part of meniscus, the portal should be little lower side.
Yes, Neha, agreed.
So in my practice, the first portal is always whatever surgery I am doing for the knee, high anterolateral portal, that is constant. But depending upon root, PCL or ACL, the anteromedial portal varies. So for root and PCL, it is very closer to the patellar tendon. And for ACL reconstruction, it is little more medial. And my medial anteromedial portal is decided not for the ACL, but for the meniscus repair. So I always put my needle and see the trajectory where it is reaching. If I'm able to go up to the meniscus tear, so that's where I take the portal. And if patient has got ACL as well, then I might take accessory medial portal.
So, sir, you used to always try to make the anteromedial portal after making the anterolateral portal through the needle, or you have to mark it before making the anterolateral portals, and again we have to clarify that whether we have to go through the same point, or so by the needle only you are.
Okay. So anterolateral portal is taken, my scope is in. So first I see the trans illumination when I taking anteromedial portal. Second, I tap with my finger, and third, I pass the needle. So that's how I go about it. For the medial portal.
Okay.
So thank you, Sandeep.
Thank you. Thank you, all the
Thank you, sir.
speakers, Dr. Sujit, Dr. Sandeep, and Dr. Neha. I think we should conclude here the first session. Thank you. Thank you, the organizers.
Ranjit Pranil.
I will go for our first live surgery. So this is the patient, Satyaranjan Swami, 23-year-old male, who had a twisting injury to his right knee around 1 month back while playing football. Patient had on examination had an anterior drawer latchman positive. McMurray positive for lateral meniscus, pivot negative, and varus valgus stress tests were negative. These are the MRI pictures.
আমার মাইক্রোফোন অন
Also
করে
see bony contusion in the femur and
মাইক্রোফোন অন করিও
lateral side.
আমার মাইক্রোফোন অন করে
MRI report showed a high grade partial thickness of ACL along with an partial horizontal tear of the lateral meniscus.
কি বিক্রম স্যার শুভনীয় হ্যালো 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 ডক্টর তাপ্পান হ্যালো হ্যালো ডক্টর তাপ্পান হ্যালো জীবনী প্রেজেন্টেশন তো সর জীবনী Hello, hello. Vikram, can you hear us? Hello. We are not able to hear anything from the audio. Vikram, can you hear us?
माइक्रोफोन चेंज कर को माइक्रोफोन चेंज कर
We'll start our live surgery session.
Yeah, Dr. Vikram.
Chelsea.
Dr. Vikram, Dr. Sandeep Biraris.
Yes,
Can you hear me?
very well, very well.
Okay, so you have seen the case profile of this patient. It's a 23-year male guy with history of twist injury 1 month back and having Latchman positive and pivot shift grade 2 positive. And the patient is having McMurray stage positive and little bit posterolateral joint line tenderness. So we were suspecting a ACL tear with lateral meniscus tear. So MRI showed complete tear of ACL with lateral meniscus plus minus. So the plan in this case is all inside ACL reconstruction using biotech implants plus and minus lateral meniscus repair. Now we will start our graft harvesting because in this case, because we are doing all inside, so we will harvest only semi-T graft. Over to Dr. Asutosh for graft harvest. He will be harvesting the semi-T graft. Good morning, sir. Am I audible?
Good morning.
Am I audible?
Yes, yes.
Yes. I am planning to harvest the semi-T because we have planned the all inside. So the incision basically, close up please, 2 centimeter below, 2 finger length below and 2 finger length medial. So it is the point, and I have given an oblique incision. I have cut the skin and deep fossa.
Any particular advantage of the oblique incision?
Yeah, oblique incision is better to avoid that superficial nerve injury, saphenous nerve injury, and the paresthesia. And the incision is given in the direction of the tendon. So for the tendon identification and the harvest, it will be beneficial. After the deep fossa is cut, we are over the sartorius fossa, the whitish structure. We have to mop it down and clean little bit. Retraction, please. By rolling down the finger, the first circular tendinous structure, most probably it is a gracilis. So we have to give an incision obliquely over the fossa, sartorius fossa. I have to clear the fossa, and the tendon is lying just beneath it. Right angle, please. This is the tendon. I am not sure whether it is gracilis or semi-T. We have to look for any fascial attachment. Just hold it. I have to mobilize the tendon. See for any attachment.
So the two tendons here, the upper one is gracilis and the lower one is semity. We are only harvesting the semity, the deep structure below the tendon. This is the MCL. So we have to be very careful while harvesting this tendon. Attachment, okay.
Somebody is coming on the way.
Yeah, yes. Is it visible, sir?
Yeah, now it's okay.
That is the play of the tendon. Well, now-
Ashutosh, can I just disturb a few
Yes.
seconds? Show us the MCL.
MCL is here. This one, whitish.
Okay.
And this is the semity and this is gracilis.
Yeah, clear. Now it is okay.
Yes, sir. I'm just searching for the fascial attachment. It's the tendon play is very good, but this is the attachment deep. I have to cut this for the premature amputation of the tendon to prevent the premature amputation. Now it is clear. Now I will strip it from the peristeal attachment, preserving the gracilis insertion. And while stripping, be careful, don't go deep. Otherwise, you will damage the MCL. And maximum periosteal sleeve, these are all strong enough. If you can harvest, it will be better. Hold the graft. Give the tendon stripper, please. Hold it. For gentle push. Gentle push, 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 push. And this is the fine tendon. Come out. So we'll harvest only semity. Now it's over to Dr. Ranjit Panigrai for the graft preparation.
Yeah, Vikram, can you see our graft?
Yes, sir. So what is the ideal length that you're looking at for an all inside ACL?
For an all inside ACL, I usually prefer to get 6.1 centimeter of the total length. So I'll have to get at least 24.4 or 5 centimeter of the total length of the graft. So whenever we are creating the graft link, so it will come to around 6.1 centimeter. So first we'll clear all the muscle attachment, and then we will restrict the cut the at the length of 24.4, so that the graft link will be around 6.1 centimeter.
Length kate.
Focus. Light. So are you able to see the graph? Vikram,
Yeah, sir.
are you able to see my graph?
Absolutely.
Okay, so these are two button fix adjustable loop from the Biotech, two button fix implants. So we have mounted two button fix implant, and we are passing the graft through the button fix implants. So
Please
the most important thing is to create a graft link. So one limb is shorter and one limb is longer, and I'll take this longer limb through this button fix implant. And then I will attach these two limbs together. Okay, so two ends I will attach together with the help of a zero biofiber.
Perfect. So the adjusting the two ends of the graft board can be done after you suture these two ends. Huh?
Yeah.
The effective length.
Effective length, yes. So you can take a simple stitch or you can take mattress sutures also, just to tie up the ends together. So you can take 1 or 2 stitches on either side.
And this is 2-0 non-absorbable suture.
This is 0-0 biofiber,
Non-absorbable.
non-absorbable suture. Light.
Can you, yeah, any tips and tricks of getting to the edge of the two ends of the limbs of the arm that, I mean, of the graft that you've got together?
So you can take one limb on one end and you can bring the other end to the same end and you can hold together with the help of Alice or artery forceps and then tie your nuts. And you can see we are keeping the nut inside. Okay, so we are not keeping it outside, otherwise your graft, it will affect the graft diameter. Okay, and further we want to strengthen our repair or strengthen our stitch at the two ends. So we will put 2 stitches where we are keeping this stitch. Okay, so this will be on the tibial side, this will be on the femoral side. I'll take 18 millimeter into the femoral side and 18 millimeter into the tibial side. So this is 18 millimeter mark and this is 9 and 18 on tibial side. Okay, you're able to see?
Yes. Yes.
So I'll take this suture first from the cleavage, through the 2 tendons and then back through all the 4 limbs of the tendon.
So can we just explain to the audience how you decided on 18 millimeters through the tibial and femoral tunnel?
Sorry.
Or can we just explain to the audience the calculations behind a all inside ACL? That means how much intra-articular, how much in the femur, how much in the tibia?
Okay. So my total graft length will be 6.1 centimeter. Okay. So I'll keep 18 millimeter of my graft on the femoral side, 18 millimeter of my graft on the tibial side, and 2.5 centimeter intra-articular. The total is 6.1 centimeter. Got it? Vikram?
Yes, perfect.
So I'll take 3 circular sutures. And then bring out my suture in the cleavage itself. Okay, so I am bringing out through the cleavage itself. And I am putting nuts over there. So now I will bury this nut inside this tendon. So I will take it inside to the opposite side. And then pull it on the opposite side. So the nut is buried. Can you see that?
Yes.
And I'll cut on the other side. So this is my first stitch and my assistant will put other 2 stitches. Okay, so in the meantime, I will show you the implants for the all inside. Okay, can you see this table?
No, not yet. Not, yeah.
Yeah.
Yes.
So this is the all inside tibial jig and this is the bullet. Okay, so this is the footprint jig. All inside tibial jig, footprint jig from Biotech, and this is the bullet. Then we'll pass the bead pin. Then the very important part is the stepped sleeve. You can see the stepped sleeve. So,
Yes.
so this is 8 millimeter, and this step part is 6 millimeter, and the length of this step part is 8 millimeter. So what happens when you hammer it inside? It will go inside the bone 8 millimeter. So it will prevent the inadvertent through and through tunnel when you are doing a all inside socket. Okay, and this insert sleeve will centralize over the guide wire. So this is the step sleeve. Then we'll take out this insert sleeve. Then we will put the 4.7 mm rimmer. So we will drill it, and then we'll go for this Biotech or AI rimmer. You can see the Biotech AI rimmer. This is a traumatic one. If you can see the end, it is very blunt. Are you able to see?
Please zoom in, please.
Zoom in, zoom in.
Yes. Yeah.
So the end is blunt over here, and there is a flap, this cutting flap. Okay. So this is the blunt end. This is the cutting flap. When you move it forward, the cutting flap will open up. Okay. So this is the blunt end. This is the cutting flap. When you move it forward, the cutting flap will open up. So these are of different diameters, say 7 mm, 8 mm, 9 mm, 10 mm. The amount of or the diameter of the socket you want to create, you can use that that AI rimmer from the Biotech. Now on the distal part, there are calibrations. So at 2 millimeter, 2 millimeter, 2 millimeter calibrations are there. So when you are creating the socket, you can see the grommet, white color grommet is over here. So from the grommet, you can mark what is the socket length. Can you get that?
Yes.
Are you able to get that? So you can measure your socket length from the grommet outside. So if it is staying at 24 after your socket creation, that means you have created the socket of 24 millimeter. So this is the AI rimmer from the Biotech. And then we will pass the leading suture and will retrieve and pass the suture. Then we will go directly for the scopy itself.
So have you already diagnostic arthroscopy?
Yeah, I have already done the diagnostic arthroscopy, and we have found a horizontal tear of the lateral meniscus and complete tear of ACL. So can you see that? So this is a complete tear of ACL and horizontal tear of lateral meniscus. Extend. Can you see that? Can you appreciate, Bikram?
Yes, it looks actually like a vertical tear, sir. Inferior surface.
Yeah, because if I can see over here, if you probe it, probe then. Probe.
Outside picture also, please.
Probe the outside picture smaller and inside picture bigger.
Yes. Yeah. Very well.
Perfect.
Okay.
And zoom in,
Extend,
zoom
extend, little bit extend, Lani. Okay, now you can see it's a kind of oblique tear, not horizontal, not vertical. It's a kind of slicing off of the superior flap from the inferior flap. So it's almost like that. Can you see that?
Yes.
Okay.
And it's
so
quite a vascular area also.
So we'll go for repair of that meniscus after we finish of the femoral tunnel. I always do my femoral tunnel first, then I do the meniscus repair. Then I go for doing the tibial tunnel. So
Any particular reason, sir, for this sequence?
Because for creating the femoral tunnel, we require hyperflexion. So it will affect my repair of the meniscus, whatever it may be. So by principle, I am doing the femoral tunnel first, and then repair, and then tibial tunnel. If I am using outside in jig for the femur, Then I am using, then I am doing meniscus repair first, and then femoral, and then tibial tunnel. So this is the femoral footprint. So you can find it out in 3 to 4 ways: behind the residence ridge, or you can come out with the center of the femoral footprint or femoral remnant, or you can use a offset jig keeping 2 to 3 millimeter, or you can mark at the 40% of the depth from the shallow articular cartilage to deep articular cartilage. So this is around 40% mark. So either way you can mark your femoral footprint but I always use offset jig for my femoral tunnel creation. So I am using this offset jig. So what is the diameter of the tendon? Graft link. So our diameter of this graft link is 8 mm. So I am using 6 mm offset jig so that I will have 2 millimeter of posterior cortex intact.
Right. So what is the
Guide
position of your, is it hanging or TKR position?
Hanging position.
Okay.
Always I do all my scopies in hanging position. Flex. Go. Go, fatafat. Okay, so I pass my guide wire, then I will go with my 4.7 mm endo button rimmer through and through. Jaldi do yaar. Through and through.
Can we zoom in outside camera?
Outside picture. Outside
Zoom.
picture.
Zoom in.
Outside picture. Okay, then I will go for measuring my depth of my tunnel, femoral tunnel, with the depth gauge. So it will coming around 38. Okay, can you see that?
Yes.
It's almost 38, 37. So I'll take 8 mm reamer and will do up to 25 or 24 millimeter. Okay, why I am doing 24 or 25 millimeter? Because I have kept 18 millimeter on the femoral side marking. So I want to take 18 millimeter of my graft. So for the safety side, I keep 5 to 6 millimeter extra on the femoral side. Then I am passing my sutures through the femoral tunnel retriever. No, retriever on this. So I'll retrieve this through my high entro. I am going with the 3-portal technique. So I am retrieving it on the high entromedial portal. And then I'll take my scope through the accessory entromedial portal, and you can see the socket inside the tunnel inside the socket. Can you see that?
Yes, very clearly.
Can you see that socket inside the tunnel?
Yes, and a very nice back wall also.
And back wall also. Okay. Then I'll go for this lateral meniscus repair. Scope.
Can you ask outside camera to zoom in to the knee? Outside camera in the operation theater, zoom in.
Outside camera.
Outside camera, bigger picture.
Zoom in.
Zoom in.
I think he's not there in the operation theater.
Hello. I say big eye quad.
Outside bigger, please.
No, not bigger. Zoom in. No.
Zoom in.
Outside picture को zoom in करो, घुटना दिखाओ. Only घुटना.
And inside picture also, please.
You want inside zoom in or outside zoom in, Sandeep?
No.
Outside regular जैसे था, inside outside को थोड़ा सा zoom करो, घुटना को दिखाओ.
joint.
जूम नहीं होगा सर, ये जूम होगा नहीं तो वो जूम होगा.
नहीं नहीं सर,
नहीं.
you carry
Just
on your work.
focus, just focus to घुटना. Knee.
Okay, okay,
Just
focus
outside
to the
picture,
knee.
knee को focus करो. That's all.
आंटू फोकस करो.
The instruction is for cameraman, not you.
Okay, okay.
Outside picture only, inside picture को disturb मत करो.
तो देखिए वो जूम करो.
Inside picture जैसे ही था ऐसे ही रखो.
हाँ, inside picture
ठीक है.
big,
ठीक.
outside picture small, and you focus
Yes.
the outside picture on the knee itself
Now show PIP outside camera.
and PIP outside camera.
Yes.
Okay.
Yes.
So I'll go for, I have already did the rasping little bit
Show
during
the knee.
diagnostic scopy.
Cameraman, focus on the knee.
Focus on the knee, focus on the knee. अरे knee को focus करे. Okay, so what I have decided, I will go with 2 all inside implants or 1 all inside implants from Biotech, Biosense AI2 for this kind of tear. So I am inserting my sleeve. So you can play with your portals. If you are not comfortable with high anteromedial portal, you can go for a low anteromedial portal also. But for the posterior stitch, I am going through the high anteromedial portal.
So now leg is in figure of 4 position.
Yeah, figure of 4 position, but it's very tight knee lateral compartment. So I have extended the knee a little bit so that I can see my lateral meniscus. I can negotiate my implant through the 2 flaps. So I am inserting this through the 2 flaps. I have kept the depth at 16 millimeter. Okay. So outside camera. So you can see, you just pull your button, pull it and release it. So it will deploy the first implant. Did you see that? Okay, again for the second implant, we will show you again. So I am going for the second implant.
I think we should put the arthroscopic image also. Now we can only see the outside image. It's very nicely seen, but
Okay.
please put this outside image as a PIP with the main screen being the arthroscopic image.
Okay, main skin, arthroscopy,
And outside. also.
PIP outside.
Yes.
Perfect, perfect. Please leave it like this only.
Okay. You were not able to see the arthroscopic image, Bikram?
Sir, for some time it went away. So now we are able to see it perfectly. No problem.
So it is actually very tight knee, not able to open up. So I have extended a little bit just to get some space, so that I insert my. So now you can see from the outside, I am pulling the black button and releasing it, and it is deploying my implant in the meniscus. So I have deployed 2 implants. Then I will pull this. So if you can see, are you able to see the inside picture now?
Perfect, perfect, sir. We can see it nicely.
Okay. So it is nicely reduced, this tear. So I think I will go with the single implant only. I will not go for the second implant. So I will go for the cutting of this suture with nut pusher and cutter. हाँ बाहर काट दिया पागल. Okay, it was cut outside, so I will take a punch and grasper and I will cut it. Give me grasper.
So I think the take home with this kind of tear is these are reasonably stable tears,
Stable tear,
very
but
vascular zones, and they usually heal very well.
yeah. So if it is less than 1 centimeter, so I would have left it alone for the healing. But as it was more than 1 centimeter, so I had to apply 1 implant for this meniscus. Second one.
Perfect.
Hold this. Small cutter. Narrow cut. narrow pons.
Yeah, doctor.
Holding that? Okay. Just open up little bit. Bring this suture, this side, this side. No, this side. Ulta bottle roko. Cut it. Okay, done. So my lateral meniscus repair is done. Then I will go for the tibial tunnel preparation. So again, for the tibial tunnel marking, there are four landmarks for the your tibial tunnel. The number one is posterior border of anterior horn of lateral meniscus. As you can see, this is my lateral meniscus. This is the posterior border. In the line of posterior border of anterior horn of lateral meniscus, in the posterior half of your remnant. So I have some remnant. So this is the posterior half of the remnant. 7 millimeter anterior to the leading edge of PCL and on the lateral slope of this medial tibial spine. So this is my isometric point, or this is my tibial footprint. So I am marking with the RF so that I want to bring my guide wire over here. RF to काम करूँगी. Okay, give me the jig. Okay, then outside picture, can you focus on the jig? So from the jig,
Very
you can,
goldy.
yeah, from the jig you can assess the length of the bone, or the entire total length of the bone. So it is coming around 42 millimeter, or how much? 42. Okay.
So measurement is on
42
the plate.
millimeter. So 4.2 centimeter. So I'll pass my guide wire right now.
Yeah, very well. Very good.
Take it off. So I'll hold it with the help of a hemostat, and then you can see outside picture. Zoom in. Outside picture larger. Can you see the outside picture, Vikram?
Perfect,
yes.
perfect, sir.
Okay, so this is the step slip. I am hammering inside the bone. Hammer it inside. Hammer it inside.
Now please keep only outside image. We don't need to see arthroscopic. till this is
Yeah.
done.
Okay, keep the outside image. Okay, now it is inside the bone. The 8 millimeter depth has gone inside. Now I am taking 4.7 mm rimmer. So I am doing this rimming through and through. And this rimming is done just to pass the blunt AI rimmer. Go in. Okay. Take out. Okay, now I'll pass my AI rimmer.
So the AI reamer is not cannulated, right?
Not cannulated. Right.
So we can see everything very perfectly. Please don't changes. Must compliment
Yeah,
the
yeah,
camera person.
Pass the AI rimmer. 8 mm AI rimmer he is passing. Okay. Now, can you see the laser mark? Inside picture big.
Yes, no. Don't disturb.
Okay,
Everything
don't disturb. Can you see the laser mark?
Yes.
Perfect.
Till the time you are seeing the laser mark, you have to take it inside, and then you start moving forward. Rotate.
Okay.
You can see the flap is opening up.
Yes.
Can you see? It's 8 mm cutting flap, which is opening up. Okay, now I'll move it forward and give a reverse force. That means withdrawing the flip cutter, I'll move it forward. So I'll move it forward, withdrawing the flip cutter to create the socket. Do that. And see my socket length from the white mark. Okay.
Perfect visualization, perfect.
Okay. So this is 24 mm. Okay, because I have kept 8 mm, so this is 24 mm. Okay, so I will take it inside in the reverse mode so that the flap will be closed, and I will take out the implant, take out the reamer, take it out, and then I will pass the bead pin with suture. Okay, done. And what I will do now, I will do retrieve both these sutures, this femoral leading suture and the tibial leading suture in one suture retriever. Why I am doing so? Just to prevent the soft tissue entanglement if you are doing separate retrieval, because you will come out separately and you will have a soft tissue breach and you will end up in problem. So I am retrieving it in the single suture retriever. Can you see that?
Yeah, you're creating a virtual cannula.
Virtual cannula, right. And I'll park the tibial leading suture for the time being. And then graft link now. And load my graft link on the femoral leading suture. Now I will mark on my graft link at 35 mm or 32 mm because my total tunnel length is 32 mm. So I will mark at 32 mm on my graft link on the femoral side. And then I'll load all the sutures on the femoral side and pull it inside. Okay, can you see that? So I'll pull it. Now I'll pull both the white sutures because I am having green sutures, tiger sutures, and white sutures. First, I'll pull the white suture to make this endo button vertical. So this will go inside the socket. Pull it, the white suture. Okay. And once it is at the mouth, I'll shift my portal to high anteromedial portal. Okay, just to see how the button is passing and how the button is flipping. Other way, if you are going up to the mark also, the same thing will happen. But I want a direct visualization of my button passing through my socket and the tunnel and flipping. Pull it, pull the white, pull the white, pull the white, pull the white.
Can we make inside picture bigger now?
Pressure.
Yes.
Inside picture bigger.
Yeah.
Pull the white. Okay, now it is going outside. Now I'll pull the green suture just to flip the button. White and green. Take the green suture. Take the green suture. Okay, then I'll counter pull this just to be ascertain that the button has flipped. And once the button has flipped, you can see the mark. The mark is just at the mouth. So if you are not able to see directly also, if you mark it also, if you go up to the mark, the button will flip definitely. Okay, now I will pull the tiger sutures. I will cinch my tiger suture to take the tendon up to the femoral tunnel. Take it, cinch it. And once it is at the mouth, I will switch my portal. Cinch it.
I think very nice that you have shown that you should visualize the tunnel end as well as mark on the sutures so that it flips onto the bone and not on the IT band.
This flow. Okay. And then I'll keep this just short of my mark so that I'll pull my tendon little bit more later on. So now I'll load all my sutures on the tibial side. On the tibial side, green suture is not required. So I have taken out the green suture. So loaded the other sutures. One second, one second, one second. So in the meantime, I'll take my saver through the high anteromedial portal and will clear the mouth. If you will not clear the mouth in all inside technique, the graft may stuck at the mouth and it will not go inside. Okay, because it's the snugly fitting graft, 8 mm socket and 8 mm graft. So if you are not clearing this mouth, then it will not go inside the socket. So the very important step just to clear the mouth before passing the graft. So now I'll pull my sutures and outside picture.
Some,
Okay, so over the artery, you can just slide your
other
graft
camera.
and
Outside,
just
yeah.
give a sudden thrust to take it inside the tibial tunnel. Okay, so once you do that,
Inside picture now, please.
straight artery. Pro. So you can negotiate a little bit if it is not going in one shot. One second. Pull it. Okay. Okay. Pro. RF system. So I'll little bit debulk. Always take out this extra tendon part so that it will go in. Don't keep it in. Pro. Rest. One second. Take it out. Take this inside. Door out. Turn. One second. It should go in one go, but if you keep this bulky on one side and if you will not trim on this side, then some part may stay inside the joint. One second. So majority of the part has gone just at the mark of the suture.
I think once you fix it at the other end, this
At the other
part
end,
which is
that will
formed, the
go
bunching
inside.
will be
Yeah.
debulked.
But
Yeah.
we want to take it little bit more so that.
But the good thing is it is going into the tunnel and it's
Yeah,
becoming taut. So
Yeah.
You can use grasper.
Okay. Okay. I'll take one grasper. I'll hold it this part. Just pull it. Slide little. Pull it. Okay. We'll trim this part because it has gone up to the mark on this side. Okay. So this part we can trim it out or we can use the RF later on after doing the cycling and femoral side cinching. Do the cycling. So I'll do the cycling up to the 90° because I have repaired the meniscus. I will not go beyond 90°. Okay, 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 okay. Leave it, leave it. Okay, done. Done, done. Okay, then I will come to the tibial side.
Outside picture bigger, please.
Outside picture bigger.
Yes.
Outside picture bigger. Light, light. So I'll take all this soft tissue. Focus, zoom in, outside picture, zoom in. Okay, so I have taken out all the soft tissue from the mouth, and I will have to take this button up to the bone. Okay, so it will sit horizontally on the bone, not on the soft tissue. If you will keep this on the soft tissue, the button, focus korcho. If you are keeping this button on the soft tissue, there will be 1 to 2 millimeter of play later on, and that will lead to laxity. So take out all the soft tissue.
So what position have you kept the knee in, sir, while doing this tightening?
No, when I am touching the button up to the bone, no
Mhm.
position of the knee is recommended. You can do in any position. But when you are cinching, now I am cinching the tibial side and the femoral side. I'll keep it in 0-degree extension or 10-degree of flexion. So now I am simultaneously cinching on the tibial and the femoral side, and keeping posterior drawer force little bit, so that the graft will be tensioned and tightened, and we will have a good tensioned graft inside. So you can do this tensioning even after checking your graft that it is not of adequate tension. Then further you can come out and do the tensioning again. So this is the beauty of all inside technique, that even after fixation also you can tighten your graft and tension your graft. So we'll go inside the knee joint again. And we'll check the tension of the graft. So you can see the tension of the graft.
Yes, yes.
Okay. Is the nicely tensioned graft
Yeah, fantastic, fantastic.
without any impingement, without any PCL impingement, and this is the final position of the graft. Okay. So any questions?
Yes.
Any questions from the delegate? No, I think there are no questions. It was a very beautiful demonstration. So delegates got to see meniscus repair.
Thank you, Dr.
graft
Ranajit.
harvest.
Wonderful
Thank you.
presentation. Great.
Dr. Ranjit
So
and
you have a
Dr.
big round of applause in the auditorium.
Okay. Thank you all
Thank
the
you.
delegates.
Thank you all.
Thanks to wonderful moderators, my colleague Dr. Asutosh Mahapatra, and the entire OT team and the anesthetist of SCB Medical College Hospital Orthopedic Department. Thank you all. I am signing off. Thank you.
Thank you.
ସବୁବେଳେ ତୁ ସେଟା ସେ କାହିଁକି ଟ୍ରିମ୍ ଆଉଟ୍ କରି କେବେ ବି କଥା ଦେଇଦେଲେ ସେ
So I think we have next section, video techniques session. So I would like to invite Dr. Debabrata Padhi sir, Dr. Sunil Kumar Dash to moderate the session. Thank you.
Thank you, sir. For our next session, Dr. Debabrata Padhi and Sunil Das, I think haven't arrived yet. I would like to request Dr. PC De and Dr. Sujit Tripathi sir to moderate the session. Thank you, sir.
So the first speaker is Dr. Tapas Panigrahi, and he will be speaking on hamstring graft harvest.
Good morning, respected chairpersons, seniors, and dear colleagues. After a beautiful demonstration of hamstring graft harvesting technique by your live surgery, my talk looks redundant. Still, for the completion's sake, I would reiterate certain red flags issues like nerve injury, graft slippage, inadvertent ligament injuries, and graft amputations, and tips and tricks to avoid such issues in the graft harvesting technique. Now, coming to the anatomy, all of you know the hamstring tendons consist of three muscles: sartorius, gracilis, and semitendinosus, origin from the ischial tuberosity and gets inserted on the proximal medial side of the tibia. In a fanned out manner, the sartorius on the top side, underneath it, gracilis and semitendinosus from proximal to distal. They are lying just very close to the MCL tendon, MCL ligament here. And second point pertinent to the anatomical aspect is the infrapatellar branch of the saphenous nerve, which lies close to the incision site usually and runs parallel to the semitendinous course. Third pertinent point is the semitendinous muscle is attached to the medial head of the gastrocnemius by two number of vinculi. These three important points we must keep in mind while discussing the harvesting technique. Now the steps, these are the steps we will be following. Now the special instruments are, along with retractors, two pieces of right angled artery forceps. These are the tendon harvesters, either open or close one, 6 or 7 millimeter, sharp scissor, and preferably one S-mark bandage. Now the positioning, either position you can do. Surface markings, usually it is the one thumb down and medial to the tibial tuberosity as shown here. Now the incision, so it depends on the surgeon's preference. Either you can go for a vertical incision or an oblique incision, which claim to avoid the injury to the infrapatellar branch of the saphenous nerve. So this is the video demonstration I would discuss just. This is the incision. Oblique incision I am putting. Now dissect carefully, ensure hemostasis. Now here you can see this is the sartorius fascia, glistening structure. Underneath you can roll over both the tendons, proximally the gracilis and inferiorly the semitendinosus. Now nick the sartorius fascia very carefully, extend the incision. Sorry. Here sartorius fascia is incised underneath the now with the help of an right angled artery forceps, try to lift up the tendons. Here you have to be very careful because if you will not be careful, we may lift up the MCL along with the tendon. So before lifting up the semitendinosus, we have to be very gentle, superficial, and keep in mind that MCL is lying underneath this one. So now another thing is shit. I'll not pause, just go on. Here I've lifted the tendons. I would show the vinculi attached to the tendon. Here you can see. You have to make sure that by this point, we can identify, ensure that this is the semitendinosus tendon. Now you have to cut this vinculi. Otherwise, there is chance of graft laceration and difficulty in harvesting. This is the MCL I am showing. These are both the tendons. and make sure the gliding of the smooth gliding of the tendons by filling the translation from the posteromedial side. Now here you have to hold the graft like this and exercise the attachment with a periosteal flap. Now, here one issue is that slippage of the graft. For that reason, you have to use this atri forceps and grasp the end of the tendon always, or else you can take some stitches like this if you are not confident enough. Otherwise, sometimes what happens while harvesting, the graft slips into inside and very difficult to retrieve it upon. Now, this is the tendon harvester. Here one important point I would reiterate, always keep the harvester parallel to the axis of the graft and aim towards the ischial tuberosity. Do not apply force. Always ensure the smooth gliding of the harvester over the tendon. If any problem you are facing, difficulty, resistance you are facing, take out the harvester, make sure that the tendon is freed from its attachments, again reinsert. Otherwise, there is chance of graft laceration in this case. So this is the technique. If you follow these steps, keep in mind while harvesting, very likely you will land up in harvesting a good tendon. So this is the complete. This is, I am just for 1 minute, 1 second. This is the open harvester tendon I will use to harvest the gracilis tendon. And the rest of the procedure is same. Just once this is inserted. Okay. Now, so while lifting of the tendons and make the tendons free of all attachments to harvest a good and good quality tendon. Thank you.
So now it's open for the question to Tapas. Any question, please? I have a question, Tapas. While harvesting the semitendinous tendon, when you are just open up the pes anserinus and you feel and roll over that gracilis, after that you put a incision, oblique incision, and inferior to that oblique incision, you try to catch that semitendinous tendon. While during any doubt, are you having any doubt to see that gracilis or gracilis like this demonstration case? Asutosh was showing that he has isolated the gracilis, take the tie of the gracilis, then identify both tendon.
No, that is not required, sir. First thing is while we are rolling over, the most prominent structure is the gracilis. Usually, the semitendinous lies distal to that. And secondly, as I demonstrated you, once I isolated the tendon, I will make sure that it is because of its vincula attachment. By that technique, I can ensure that my tendon is the semitendinous tendon.
So I think most of the time it is not necessary to isolate the gracilis,
Not necessary.
as it is a superior structure and you just pull and feel it, roll it, and then give the incision obliquely below the gracilis tendon, and then you take out the semitendinous tendon. So what precautions you are taking to avoid the premature amputation? Already you have told, just repeat it for this.
The precautions are that first I told you the tendon, we have to excise the vinculi attachments. We have to ensure smooth translation of the tendon. Number one. Number two, we have to, as I told you, we have to pass the harvester parallel to the axis of the tendon as much as possible and aim towards the ischial tuberosity and never apply any force. If we are facing any resistance, there may be a possibility that there are some aberrant attachments with the tendon or some soft tissue is obstructing. So we have to make free the tendon, then we harvest. By these two techniques, we can avoid premature amputation.
Say one more question for you for this. Previously used to, even today also I am doing that after the taking out the graft. we are putting on two or maybe one or stitches to the sartorius fascia to avoid that debris to go inside to the pes area. And sometimes it leads to a balloon-like bulge due to debris. So what I heard that most of the newcomers, they are not doing any stitching to the sartorius fascia. Is there any difference if you are not put the
It
stitches?
is always ideal to stitch the sartorius fascia. It is ideal if you can preserve the sartorius fascia after the completion of our procedure. But many times what happens, the sartorius fascia gets distorted. So it's very difficult to catch hold of both the ends. If it is possible, we should stitch it. That will be more anatomical and better.
Okay, thank you.
Thank you, sir.
And we.
It's always damaged. I think if you have noticed.
Yeah, sir.
It's always there.
It's a very tiny and
60 to 70% of my cases at least. It happens. So how to prevent and how to take care of that?
Sir, we have to keep in mind. First thing is, I have to keep in mind that I am not going to injure the infrapatellar branch. Otherwise, there is every possibility. Second thing, we have to keep ourselves aware throughout the incision, and we have to be very delicate. Try to isolate the infrapatellar branch. If not possible, as I told you, give an oblique incision. Usually that prevents injury to the subpatellar nerve. Practically, I have never isolated it.
That's what I'm asking. I think what is the practical approach to how to do that?
Go for an oblique incision. In that case also, you are not sure of the will 100% will prevent injury to that nerve, but there is high likely chance that
there is small blood vessels near that. Twig of small blood vessels. That's what I do.
Small.
And give an incision just along that line. Keep it almost not perpendicular. It's bit of in the same line, and use the blunt scissor, dissect it down, and then try to catch hold of the tendon going below and just pick it up.
Thank you,
That's
sir.
what I do. I mean, that's what I wanted to say.
Thank you.
Thank you.
So the next speaker is Dr. Gunjar Jain. He will be speaking on BPTV graft harvest.
So good morning, everyone. My topic is BPTV graft harvesting technique. Next slide. So can I change the slide? So the patient positioning is standard only with the supine position with the leg holder. Knee is flexed to 90 degrees. So this is the surgical video. So a vertical longitudinal incision about 8 centimeter long is made from the lower pole of patella to about 2 to 3 centimeter below the tibial tuberosity. The patellar, the paratendon is exposed. A nick is given with a 15 number knife, and it's separated longitudinally with metronome scissors and separated from the underlying patellar tendon. Then the medial lateral border of the patellar tendon is exposed. With the help of a ruler, it is measured, and central 1/3 of the tendon is marked and incised. The incision is carried both proximally and distally along the collagen fibers of the tendon and up to the tibial tuberosity and the tip of patella. Then the tibial tuberosity is measured and the tibial bone plug is measured 2 cm long, 1 cm wide, and with the help of a oscillating saw, the bone plug is created, keeping the saw about 30-degree oblique to the bone plug. At the end, the horizontal arm is sawed, and then with the help of gentle taps over the osteodome, it is separated. The patellar tendon is separated from the underlying patellar pad with the help of a metronome scissor. The knee is extended, and the patellar bone is pushed inside the wound to expose it. Similarly, the patellar bone is marked, and it is the saw is applied to prepare the patellar bone plug. With gentle taps using an osteodome, the patellar bone plug is then harvested. Any remaining soft tissue attachment is cleared with the help of a metronome scissor. So at the end of the procedure, the graft after preparing the bone plugs is inserted inside the defects of the patella, particularly in the patella, and the paratendon is closed with the help of a number 10 phakial sutures. So graft preparation, the graft which is harvested is prepared with the help of either a scissor or a nibbler to make bullet shaped bone plugs. The bone plugs is then size is measured and 1 or 2 drill holes are made with the help of a guide wire, 2M guide wire or K wire to pass the passing sutures for the passing the graft inside the joint. So the most common complication which is encountered is the graft tunnel mismatch. The overall incidence may be as high as 20%. So the graft can be either long or short. If long, then the bone-to-bone fixation is lost. And if short, the screw pushes the graft inside the joint, making the decreasing the tension of the graft. So patients with anterior knee pain, maybe because of Osgood-Schalter disease or because of any other pathology, are more prone for this mismatch. Preoperative radiography is suggested in this case. So one you can see here, if there is patella alta, there is more chances of graft lengthening. And Graft et al. Have given a 10+10 rule. N is the length of the tendinous portion of the graft plus 10. This should be the length of the tibial tunnel. So the bailout procedure is either twisting the graft onto itself, so decreasing the size of the graft, or we can separate the bone plug if a lengthy graft is harvested. So anterior knee pain, it's also very commonly affected. It's more common with BPTB graft. It may be because of the scarring of the patellar tendon or neuromas of the infrapatellar branch of saphenous nerve. So grafting of the patellar bone defect decreases this knee pain. Patellar tendon rupture, it's though very rare complication, but it's very dared complication. So it is mostly reported in the early postoperative period. So to prevent it, we must leave at least 10 mm of the intact tendon medially intact. So typically it is seen in the medial proximal and the lateral distal scenario. To prevent it, we must measure the medial third of the tendon, expose the medial lateral borders, and then dissect it along the fibers of the collagen fibers of the tendon. So transverse fracture of the patella, again, it's very uncommon, but it's full complication. Usually transverse, but may also be comminuted fracture may also occur. The patellar bone defects, it should not increase the size of 10 mm depth, maximum 20 mm length should be there. Also, the bone cuts is made, it's not insertic, it leaves stress sizer in the patella. It should be like this to make the corners not exceeding beyond the required amount. The saw is advised to run in oblique fashion. Aggressive rehabilitation should also be avoided, and precautions should be taken to avoid trauma in the early postoperative period. Then the tibial plateau fracture, it is also a very rare complication, but it may occur, particularly in the early postoperative period. Use of biaxial screws and osteoporosis increase the chances. Other precautions like the graft may, while preparation may got cut out or may got shattered, which is also very difficult to bail out. So precautions must be taken. So take home message, at least 10 mm of the native patellar tendon must be left inside in the medial side. And the corners of the bone plug should be sawed at a 45-degree angle. The bone defect should be grafted with the help of bone chip taken out from bone plugs. Mallet should be used very gently to avoid iatrogenic patellar fracture. And mismatch should be avoided with the help of good preoperative workup and intraoperative adjustments. Thank you.
So any question to Gunjar for BTB graft? I think it definitely is a technically demanding. Most of the people are nowadays happy with the soft tissue graft. Or sometime if there is any problem, you can go think about the quads or the Peroneus. Any question to Gunjar? Devasis?
I think I have got, I like this particular graft. So the reason being, I think it's one of the oldest graft I started my career with this only when Paris and all these guys, they were all with the hamstrings. Probably I was the only one was quite vocal about, the BTB, even as of now also probably still it is, 10 to 20% of my practice. I still am do that. Always the revision is always the topmost priority. I think all these cases, I always do this. Failure rates are very, very minimal, I can say. I mean, you can take it as nil in my cases, some of my, I mean, all my cases probably, I don't see any kind of failures in those cases. But the biggest problem is, the passing the graft into the femoral tendon. So how do you handle that?
So to pass the graft, usually to prepare it is very important. There should not be any sharp edges on the bone plug. The bone plug must be very much smooth. And to help in preparation, the notching and the preparing the femoral tunnel is also important. We have to smoothen it out. And there is a dilator equipment which we use to dilate the femoral tunnel to the exact size. And the notcher is also available so that we create a separate notch site to pass the guide wire.
I agree. I fully agree. I mean, what's your graft size? Normal.
Normal guide size.
Bone plug.
Sir, it's 9 or 10, sir.
Yeah, if it is 10, you can imagine you have to dilate about to 11. That's a bit of a, larger size.
Yes, sir.
Once you dilate,
yes,
and the angle, do you go for transtibial or you go for transportal or outside in? What technique do you adopt to get the femoral draining done? What sort of technique do you adopt?
Sir, we are passing the graft to the portal only, sir.
Yeah, if you are passing to
transportal.
Transportal.
Sir.
Okay, so I've never done that. Probably transtibial seems to be a bit easier.
Yes, sir.
Because if you do it bit wider diameter and angulate it about 120 degrees, you can pass the graft straight away.
Sir.
What I do is a bit different. I keep my angle about 110 degrees.
Sir.
Okay, and bit of notch you said, just anterior part, I just take out bit of a bone by either by bore or even with the score where the saver also I can smoothen it, and at the same time also can pass the graft from the tibial, transtibial into the femur. Problem is, getting into the femoral sometimes is a little bit tough and tricky. I use two switches, one on the pulling, the other one is to control. Two switches, they are a little bit in angle so that you can control the rotation as well. Okay. Twist it a little bit so that you can bring it into the line of the femoral tunnel. So that's the technique I adopt. And fixation, how do you adopt? I mean, from the outside in or from the inside out?
Inside out, sir. Inside out.
Have you not seen any blown out or anything like that?
Sir, it is very difficult to apply the sutures. We have seen once a blowout had happened. So then we twisted the graft upside down.
I have got a simple solution for that. You go from outside in. I saw it, one of the Italian surgeons performing that way. So from that day onwards, it's all from outside in. I never doing from inside out. Because it's first of all, it's difficult. You may not be able to see the screw. You may not be able to see the graft. It's a little bit difficult and clumsy also.
Sir.
Okay. So what I adapt is outside in. It's very easy. You can fix it very nicely. Only thing is that your graft length and it has to be a little bit, matching.
Sir.
So otherwise, graft will be a little bit small or maybe longer also. It may get into the.
There is also a confusion. Maybe in some doctor's hand, it may be inside out or maybe all in that outside. That also depends how you are approaching, or that in your hand maybe it is comfortable.
That's what I wanted to say. I mean, I tried both the ways. Probably it's easier. I mean, both the ways.
Okay.
I think okay. Thank you.
Thank you. Next.
So we'll go to the next talk, that is by Dr. Atanu Mahanti on Peroneus graft harvest.
Good morning, all. So I'll be presenting my topic on Peroneus graft. Peroneus lumbus graft. So as you know, the Peroneus lumbus is a very strong and a big muscle which passes on the lateral compartment of the leg. So a Peroneus lumbus takes origin from the upper lateral fibular head, and it attaches to the medial cuneiform and the first metatarsal. Peroneus brevis, which passes just behind it, it rises from the lower two-thirds of the lateral fibula and attached to the base of the fifth metatarsal bone. And both of them passes below the peroneal retinaculum, just behind the lateral.
Sound थोड़ा बढ़ाइए. Sound.
So this is the photo of the ankle, just on the ankle joint. One must know how the peroneus brevis passes and how the peroneus longus passes. Peroneus longus passes anterior and superior, Peroneus brevis passes posterior and inferior. And the identification here is very important that you are not cutting Peroneus brevis by mistake instead of Peroneus longus. There are 2 points which I always see. First one is that Peroneus longus has, at that area has got a big long tendon and muscle belly is not seen. And Peroneus brevis is just the reverse. You will find some muscle attachment at that area and the tendon seems to be little shorter. This is number one. Number two is that if you move the tendon and you try to move the foot, you will find that in Peroneus longus, the whole foot will move, but in brevis, it is attached to the base of the fifth metatarsal. So only the ankylous point will be the base of the fifth metatarsal. So this is how you harvest. You put the incision. You are usually 3 to 4 centimeter long, just 1 centimeter behind the lateral malleolus. And behind that, you will find the peroneal retinaculum. Just below that passes the sural nerve. You have to be careful not to damage the sural nerve. Inside the peroneal retinaculum, and then identify both Peroneus longus and Peroneus brevis. So this is how the upper one is the Peroneus longus tendon. We confirm that is Peroneus longus tendon, no muscle attachment, and the whole foot moves with that. So that is how you know it is a Peroneus longus. And then you can move the foot. You can see how much, once you invert the foot, you can find that the Peroneus longus tendon is been lifted up. So you can cut that. The best thing of this is that this tendon never retracts. You will be not afraid of retracting back. So you need not hold it with a suture so that you are afraid that it will be retracted back and I cannot find it inside. So you can pass the tendon stripper. And this is how you pass the tendon stripper. And the tendon stripper is going high up at just at the neck of the fibula. And this is the length you get. The average length you get is a big one. It is usually 30 centimeters in length. And if you double it, the diameter will become 8 to 10 millimeters. So this tendon which I am showing is 30 centimeters. And you see, if you double it, it is becoming 15 centimeters. So you are never worried of that your tendon will fall short. You have to take gracilis or something else to augment it. And the average thickness of the double graft is about 8 millimeters. And you can see once you are going for aperture fixation, so big length of tendon is coming out. So the advantages is that the length is around 30 centimeter, diameter is 8 millimeter when it is doubled. There is osmotic scar both over the knee and the ankle. It is a simple and fast harvesting technique with short learning curve. When used for ACL reconstruction instead of hamstring, it provides better post-op rehabilitation by preserving the hamstring function. So coming to disadvantage, chances of sural nerve palsy, yes, it is there, but if you are careful, sural nerve may come on the way, may not come on the way, but if you are careful, you put your incision little anterior to the sural nerve, just say you can put your incision over the fibula, lateral malleolus and go down, then you will never damage the sural nerve. Then the question of post-op foot and ankle disabilities, for that we have done some work. So we have seen that the foot and ankle disability index score, which was 99.3 at 6 months follow-up, improved to preoperative value of 100 at 1 year follow-up. The same occurred at AOFS score, which was 97.76 month follow-up, improved to preoperative value of 100 at 1 year of follow-up. Then loss of plantar arch, to know whether there's actually loss of plantar arch or not, we did a footprint study and we found that there's hardly any loss of plantar arch. And then is there any injury to pes uncinus? So we did a MRI 6 months and we saw that the pes uncinus was also intact. So now it has been used for multiligamentous injury, PCL reconstruction and revision ACL surgery. My question is why not for primary ACL reconstruction? So take up message that Peroneus longus is a long, thick, strong tendon with ease of harvest without much donor cell morbidity and which is now used mainly for multiligamentous injury and revision ACL surgery. Its use for primary ACL reconstruction is likely to be increased in the future. So now I will show a short video on a video of just 1 minute. Video done. So this is how we put the incision. usually 4 centimeter incision, 3 to 4 centimeter. Then dissect out the longus and the brevis, confirm which is longus and which is brevis. Then cut the longus. There's no chance of retraction here. You don't be afraid that it might tendon will slip off. Then pass the tendon stripper. Chances of amputations are very less. And that's the length of the tendon you get. Usually 30 centimeter. Thank you.
Excuse me, respected Autumn sir. Sir, you are one of the surgeon who is having, I think, the longest series, means largest series of peroneus longus tendon harvest since last 9 to 10 years, since our postgraduate days. So my question is, sir, after 5 to 10 years, have you faced any complaint from the patients of ankle pain or foot pain
No, till
after
now I am
long-term
satisfied.
follow-up, means more than 5 to 10 year follow-up?
Since 2014, so we're completing 9-10 years. And that is my first choice for ACL reconstruction. I'm very satisfied with that. So no, I have hardly any patients have complained of any problem in the ankle and foot.
So means before 10 years, 8 years, nobody preferred to directly jump to peroneus longus
But I
harvest.
once you take peroneus longus, you're so happy with the graft that you will not think of any graft. Nowadays, people are taking half of the peroneus longus also, if you want to preserve the function. But it is a very strong, stout tendon. Length is never an issue. The diameter is never an issue. You get a good diameter tendon. And foot and ankle disability, I have never faced yet.
So even after 5 to 10 years, no such major complaint.
No much, not much.
Thank you, sir.
Thank you, sir.
Thank
So we'll move to the next talk by Dr. Rajiv Raman about quad tendon graft harvest.
Thank you, Odisha Orthopedic Arthroscopic Society, Orthopedic Association, and IAS for the opportunity. So I will be talking on quadriceps, the forgotten graft, and why I call it forgotten graft, because earlier we were using the quadriceps tendon graft, the central strip of the quadriceps, and this was used, I think, for 10-15 years back. We were using it routinely, and suddenly we stopped using quadriceps graft because of loss of extension mechanism, some amount of extension lag, and that was there because we were harvesting the full thickness of quadriceps graft. So why quadriceps and why we are intended to use quadriceps graft? First thing is this superficial quadriceps graft has a less graft harvest morbidity, and it a direct fiber to the ACL and have a large cross-sectional area. I will show you in the surgical video, we can have a very large cross-sectional area when you could do your PCL also with this superficial quadriceps graft. And there is a myth that disruption of extension mechanism. I can assure you, superficial quadriceps graft with good rehabilitation does not affect the extension mechanism. But it's not a primary graft choice for me. It's ideally for revision scenario, or sometime when the hamstring tendon is not available, I use superficial quadriceps graft. Even if you see, if you use the superficial part of the tendon, your extension mechanism is intact, the deep part of the quadriceps is intact. And if you see the recent trends, 10 to 20% of the surgeon, orthopedic surgeon, is using quadriceps graft as a primary graft for ACL reconstruction. The only good thing is that you should have a good preoperative planning. See for the sagittal section of the MRI and see for the cross-sectional section, and see the minimum thickness should be 8 to 14 millimeter, because you were taking 6 to 7 millimeter of superficial quadriceps. So in lean and thin person, try to avoid taking of superficial quadriceps. Go for alternative option, either a Peroneus or a graft from the other limb. So this thickness is important to harvest superficial quadriceps. This is a small surgical video. Just I will show you, and we have published it in arthroscopy technique also. You can get it online. So I do it in leg holding position, mark superior pole of the patella, the lateral and the medial side, and try to make a 2.5 centimeter vertical skin over lateral to the midline. This is very important. Your incision should be at the junction of medial and lateral third, because we have more tendinous part in the lateral part of the quadriceps than on the medial part. You know, vastus medialis muscular on the medial side. And you can just harvest with 2.5 centimeter incision. So try to make a skin incision over the skin marking, and it should touch over the superior pole of the patella. So by layer dissection. This is very important because we don't want disruption of the quadriceps mechanism. Excise the paratendon and try to dissect the paratendon with your sharp scissor. And this is very important, and try to dissect it proximally because at the end of the procedure, you have to repair it. Use the 8-inch right angle artery forceps, and you can see the normal length is, the curvature is 8 millimeter. So you can take and mark your width and depth of the first incision is over the midline, over the lateral border of your right angle artery forceps, and second incision is close to your tip. So it's like you can see 6 to 7 or 7 to 8 millimeter of thickness. So this you can measure with the tip of your right angle artery forceps. Now the depth, this is very important. Normally you see the depth should be less than 8 millimeters so that you are taking superficial quadriceps. So try to put your right angle artery forceps, keep 1 or 2 millimeter outside and then reverse it so that you are superficial to the quadriceps. This is very important. And you can see once you have taken the superficial part of the quadriceps, go for a dissection over the superior pole of the patella. So this is very important, and try to dissect the whole of this tendon from the superior pole of the patella. Sometimes you can get a bone, you can harvest with the bone plug also. I don't harvest with a bone plug. I just take the tendinous part. And with the 11 number blade, try to detach the superficial part of the quadriceps. And now you can see your distal stump is there. One very important tip is that try to take whip stitch, at least 5 to 6 whip stitches there with the 5 number ethibond. Quadriceps is a very thick tendon, very dense tendon and very strong tendon. So you need enough of good amount of force also to harvest this tendon, and try to dissect the tendon proximally. Again, at this step, you can increase the depth, you can increase the breadth also by dissecting in medially and laterally, and try to dissect at least 5 to 6 centimeter proximally. And you can see the deep part of the quadriceps is intact. This is very important. The whole of the deep part of the quadriceps is intact. And you can see here, whole of the deep part of the quadriceps is intact. And this is very important for having a good extension mechanism post-operatively. And now take your closed tendon stripper, which is there in your ACL set, and try to push it. And as you see, when you are pushing it proximally, gradually extend the knee. At that time, your quadriceps get laxed. This is very important. In 30-degree of flexion, you go proximally and you are through the central strip of the quadriceps tendon. And you can see the long quadriceps tendon which comes out. Normally, you get length ranging from 25 to 30 centimeter, which is good enough for your ACL, for PCL, for revision ACL reconstruction. So you can see this long central part of the quadriceps tendon strip is coming out, and it's superficial also. And here you can see the length is close to 32 centimeter, and you can plan for your PCL reconstruction. You can plan for your ACL reconstruction with the superficial quadriceps. And this is very important. And second important thing is that your tendon is a dense tendon, very strong tendon. And here you can see once after graft harvesting, your deep part of the quadriceps is intact. You can see whole of the deep part of the quadriceps, intact quadriceps. You have now violated the suprapatellar pole. The closure is also important. Try to close the paratendon with the absorbable suture because you want a good movement of the quadriceps tendon. And you can see with this 2.5 centimeter incision, we can harvest this long graft. This graft, you can see it's a 9 millimeter thick graft, 11 millimeter in length. You can use this for your PCL reconstruction. You can use it for your ACL reconstruction. You can use it for your revision ACL reconstruction. So again, I will come back to the point, why superficial quadriceps? Because it causes less weakness. You are not disrupting the extension mechanism. Early rehabilitation is possible. Most of these patients will have a good early rehabilitation because your deep part of the quadriceps is intact and there is no extension lag. Below me, we have done more than 50 cases of superficial quadriceps tendon harvesting, and none of them has any extension lag in due course of follow-up. Thank you so much.
So any question to Raman? I have two. Yes,
Sandeep.
Sir, how is it better than semitendinosus graft, if it is better?
Yes, so very good question. So superficial quadriceps is not my primary graft of choice. So most of the time, my semity and gracilis is a primary graft of choice. Sometime in revision scenario for PCL, or you have a patient where you have a very thin hamstring or semity and gracilis. In this patient only, I use superficial quadriceps. It's never a primary graft of choice for me.
Yes, Sandeep.
Sir, any kind of post-op
pain means during
Yeah.
quadriceps movement or stiffness have you ever seen in case of especially females or sedentary patients? So
Sandeep, very good question. So if you harvest a hamstring graft also, you see there is soreness in the hamstring fossa. Most of these patients have some amount of blue or blackish demarcation in the hamstring tunnel. So that soreness will be there in superficial part of the quadriceps. So in this patient, they will complain of an anterior knee pain for 5 to 7 days. Because anywhere you are putting your tendon stripper, either with for a hamstring or a peroneus, that soreness will be there. So that is there for 5 to 7 days. After 14 days, the whole of the tunnel gets fibrosis starts, and start them on quadriceps exercise, active quadriceps exercise from next day of only, because your deep part of the quadriceps is intact, and the proximal part, in the distal part, you have repaired the superficial part also. So you can use, you can ask them to go for a rehabilitation from the next early morning only, and that will prevent stiffness of the or adhesion of the paratendon to the quadriceps also.
sir, but when we have repaired any bucket handle tear or root or posterior horn PCL, where we have to keep immobilization little bit longer, is it advisable to use the security in case of meniscus repair?
If you are apprehensive in meniscus repair, 30° of flexion is not abandoned. You can do 30° of knee flexion, and quadriceps drill you can allow them any day, because quadriceps drill will not affect. So if you ask the patient to contract and release the quadriceps, that will prevent adhesion between the paratendon and quadriceps.
Thank you, sir.
So one just maybe compliment to the Raman.
Sir,
that,
Sir Subhranshu here.
Yes, Subhranshu.
Yeah.
Sir, I think for that quadriceps tendon, you need that right angle of 8 mm. That one is very much needed for.
That is there on the ACL set, na, for.
Yeah, that is there. But when you are taking it distally, that 8 mm is maintained. When you are taking that that graft from the proximal side, that length, that diameter is maintained whole through the length.
Yeah,
of
that corresponds with your diameter of your tendon stripper.
Tendon stripper. Okay. And we are only stitching that paratendon in the distal part only. So
Proximal part. So
part.
we have done a cadaveric study. You can go through that article. It is there in arthroscopy technique, in Arthroscopy Association of North America Journal. It's open access article. So we have done a cadaveric dissection. So we have explored whole of the tunnel of the quadriceps tunnel, and we have seen there the whole of the extension mechanism is intact, thick proximal part.
Okay.
Yeah. So right now we can see that those cadaveric pictures are there.
Yeah. So there is also more chance of adhesions of.
So for that, it is important you start this patient on quadriceps drill. Whenever you are taking quadriceps graft, ask them to
quadriceps drill from day one.
Day one, or after spinal anesthesia is over, or next day.
Okay.
Day one post-operative day.
Okay. Thank you, sir.
Sir, the graft is taken from vastus lateralis or?
So in distal part, it's like all of the, there is no demarcation. All right. So you are just keeping the deep part intact. So try to be towards the lateral part, because you have more tendon on the lateral side. Medially, you will have a very short length, because your central strip is more towards the lateral side. You see vastus medialis is coming like a muscle over the medial part. So try to go a bit lateral to the midline. So you will be through the central strip of the quadriceps tendon.
I have taken about 6 cases. Last was, I think, 2 weeks before for my revision case. I'm very happy that I would like to thank Raman that he has taught me this technique.
Thank you, sir.
And the length of the graft is very good, 300. Only 2 things I learned from him today, that you extend the knee while taking the graft or pushing in the last shot. That is the extend the knee, that one thing you learn. And the second one is the early quadriceps exercise.
Yes.
Thank you, Raman.
Thank you, sir.
So with this, we are closing this session. Thank you.
Thank you. Thank you, sir.
Thank all the speakers.
Thank you, sir. Now we shall be moving towards our next session, which is the meniscus basic session. I request Professor Dr. N.C. Mahapatra and Professor Dr. Chandrasekhar Pradhan sir to come onto the dais to chair the session. Thank you, sir.
Good morning. Welcome to this session on the meniscus, about the meniscus. So meniscus, as you know, is very important structure which provides stability for our knee and also cushioning, prevents arthritis. And patients come more for meniscus injury than ACL injury to us. So now I request Dr. Arvind Das to speak on meniscus, vascularity and tear patterns.
Thank you, sir. So my topic is meniscus vascularity and the tear patterns. So meniscus, as you all know, it's a C-shaped fibrocartilaginous structure, and it is attached to the tibia, which depends its articular surface and distributes the impact forces evenly. It also provides stability, lubrication, and proprioception through its insertional attachments. And it is attached by the anterior and posterior horns, as well as the medial collateral ligament, the meniscofemoral ligaments, anterior intermeniscal and popliteus tendon. So while flexion, the menisci, they translate outwards and posteriorly. And the lateral meniscus is more mobile, and its anterior horn can displace up to 9.5 millimeter posteriorly. And medial meniscus, it being less mobile, is more frequently injured at a ratio of 2:1. So this is a fiber orientation of a menisci. They are wedge-shaped on cross-section, and they have different layers of fibers. The superficial fiber are randomly oriented. They mimic the hyaline cartilage, which lowers friction between the menisci, tibia, and femur. And underneath this, 1/3 of the fibers are distributed in a radial pattern, and 2/3 are distributed in a circumferential pattern. And this orientation, it dictates how the meniscus will distribute forces, and therefore how the fibers can be compromised. So coming to blood supply of the meniscus, it originates from the medial and lateral genicular arteries. The outer 1/3 of meniscus is vascular, so it will heal if repaired. And the inner 1/3 of the vascular is not vascular and is nourished by the synovial fluid. So the middle third is the red-white zone, and it is relatively avascular. So this is further illustrated in this picture. The red zone is vascularized by the perimeniscal capillary plexus. It contains fibroblast-like cells and can heal on tear. And red-white zone, it is at the border of the vascular area. It contains chondrocyte-like cells and has thus got a limited capacity to heal. And the white zone, it is avascular. It receives nourishment from the synovial fluid and it cannot heal. The meniscus is not as adaptable as other tissue in the body, but when healthy, it has the capacity to remodel, which is known as mechanotransduction. So this is the cellular structure of the meniscus, and the inner 2/3 are more deformable than the outer third. The main role of the meniscus is to evenly distribute the impact forces known as shock absorption, and it absorbs approximately 70 to 99% of the joint's load. So there are the various sources of stress. There can be a tension stress, compression stress, a strain or shear stress, acute loading like a traumatic injury, hydrostatic pressure, fluid flow, fluid pressure, or chronic loading with the time and age. And meniscus reacts like this to various force distribution. For a compression or axial load, it is subjected to hoop stress. For a rotational force, it is subjected to radial and tensile stress. And for deceleration, it is subjected to shear stress. So when the tissue loading is more than tissue tolerance, there is tissue failure. And the mechanism of injury is usually due to twisting or turning quickly, which can result in either a partial thickness or a full thickness tear. So there are the various types of meniscus tears. Either the tear can be a longitudinal or a vertical one, or a radial one, or a horizontal tear. So longitudinal tear can progress to a bucket handle tear if the inner part is flipped inside a joint. Radial tear, it can progress to a parrot beak tear pattern, and a horizontal tear, it can progress to a flap tear. So there are certain arthroscopic videos and examples. So this is an example of a horizontal tear, and it has also got a concomitant longitudinal tear component, which is in the red zone or zone 1. So when the inside part of the longitudinal tear is flipped and caught in the joint in between the medial femoral and tibial condyle, it may give rise to a bucket handle tear, and it has resulted in locking of the locking symptoms. So this is an example of a bucket handle tear. So this is managed by partial meniscectomy, and which revealed a further horizontal tear component. and which was subsequently repaired. So radial tear, this pattern is very difficult to repair, generally considered difficult to repair. So while performing diagnostic arthroscopy, once you see there is no tear of the meniscus, but one should not forget to examine the posterior aspect of the knee joint. So this is the posterior part of the meniscus. Examination reveals a menisco-capsular separation, which is also known as a ramp lesion. So by putting a posteromedial portal and probing it, it reveals the extent of the lesion. So this is a classification of the ramp lesion. Now in osteoarthritic knees or in elderly patients, one should be careful to not miss a root tear. So this is an example of a root tear, a posterior root tear of the medial meniscus, which is avulsed from the tibial attachment, posterior tibial attachment. It is being caught hold by a fiber wire. So root tears, they produce ghost sign on MRI, and it can be repaired by help of a transtibial technique. So imaging has got a major role in diagnosing the meniscus pathologies, and grade 1 is an intra-substance globular appearing signal which is not extending to the articular surface. Grade 2 is a linear increased signal pattern, but it is not extending to the articular surface. And grade 3 tears, they usually extend to the articular surface. So treatment options can be either, which will be further elaborated by the subsequent speakers, can be non-surgical, either a meniscus repair or a meniscectomy or a meniscus transplant. And rehabilitation also plays an important role. Thank you.
Thank you, Dr. Arvind. Now any questions for him? May I ask one question? When a meniscus heals, whether in red zones and red-white junctions, how does it heals actually? Or in white zone?
So
does it form cartilage, or is it scar tissue, or something else?
So meniscus was earlier thought to be a remnant of a cartilage, actually. So since there are fibroblasts in the red zones, so if there is injury to the red zone, so it generally heals by forming a type of hyaline cartilage. Okay. So that union is good actually. But in the inner aspect or in the white zone, if there is tear, so the healing is like more akin to the fibrocartilage, which is not that good.
Okay, thank you. Any questions for him? Okay, thank you, Dr. Arvind. Now I have to make one announcement. Dr. Sachin Tapaswi is not here. But he has just sent a video. His topic is on why save the meniscus. I'll ask Dr. Udit to share his video.
Today's topic is why should you save the meniscus? And if you look at the meniscus, you will see that there are two lovely menisci, the medial meniscus, which is attached at the anterior and the posterior root, which is very mobile and wider posteriorly. And on the other hand, you have the lateral meniscus, which is of similar anteroposterior width, but it covers a greater articular surface. The medial root on the posterior side is closely attached to the PCL, and the lateral is closely attached and in relation to the ACL. The anterior root attaches for a far distance in a variable location proximal to the ACL, which is what must be kept in mind. The menisci serve many important biomechanical functions. The medial meniscus carries about 50% of the load in the medial compartment. The lateral meniscus carries about 70% load in the lateral compartment. And if you look at the ACL injured knee, which is a fairly common injury that we see in our clinical practice, you would find that a third of all ACL injured knees will have a medial meniscus, and a third of them will not be repairable. On the same hand, you'll find that almost about 40% of all ACL ruptures will have a lateral meniscus tear, and only 10% are non-repairable, which means that we have to go all out and try and get to these injuries early to save the meniscus. The main biomechanical functions of the meniscus are those of load transmission, which is the main role. The menisci allowed to transmit load from the femur to the tibia, and they convert the axial loading to circumferential hoop stresses. The roots of the meniscus play an important role. They help dissipate the force to the subchondral bone area, and hence the meniscus root is now recognized to be an extremely important reason for getting back the stability of the knee joint. When you perform a meniscectomy, there is increased peak contact pressure on the articular cartilage, and the amount of meniscus that you remove will be the most important predictor for development of osteoarthritis. So the more meniscus you remove, the higher are the chances that you will get to osteoarthritis, because there is increase in the contact forces. This is more important on the lateral side than on the medial side, because on the lateral side, you have a convex on convex articulation, which makes the role of the meniscus so far more important. Meniscus tears can be classified on the basis of the tear depth, location with respect to the zones of the menisci, the pattern of the tear, and the quality of the tissue. But on a broader aspect, you can classify them into traumatic tears, which are essentially seen in young athletic individuals, which are usually associated with an ACL or some cruciate tear, and they're usually of a peripheral longitudinal type and are amenable to repair. On the contrary, you have degenerative tears, which are seen usually in patients above the age of 40-45. They will occur with a trivial injury, and you would find that there are pre-existing degenerative changes in the cartilage, and the meniscus may not also be of normal quality. These may not have the same healing capacity as that of a traumatic tear, and these are usually of complex tear patterns, and repair may or may not be possible. It was way back almost 100 years ago that the meniscus was found to be capable of healing if the tear had access to a synovial blood supply. And Warren and Ornoxy about 40 years ago did show us that the peripheral capillary plexus, which originates from the synovium and the capsule, richly innervates and supplies vascularity to the periphery of the meniscus. So based on the same, you can classify tears of the meniscus as zone 0, 1, 2, and 3, based on whether it is at the level of the capillary plexus or with decreasing vascularity towards the central area. You could also classify them based on the configuration, as we discussed, whether it is a radial tear or a flat or a horizontal cleavage tear or a longitudinal vertical tear, which is what we need to look into in proper details. On the basis of chronicity, a chronic tear is less likely to heal, and which is why we must look at this aspect very critically, because a tear which has been out for a very long time may not heal properly at all. And of course, you need to look at the age of the patient. Older the patient, less the chances to heal, and a non-compliant patient is someone that you should stay away from. An unstable knee needs to be corrected before you perform any form of meniscus surgery, and this becomes critical because if you leave a knee that is unstable, the meniscus repair is bound to fail. If you look at surgical techniques, the meniscus can be repaired with an outside-in, inside-out, or an all-inside technique based on the zone or the area of the meniscus. And we now have better devices of all of these three techniques, which allow us to repair more and more of meniscus zones with increasing ease. If you look at the repair principles, we understand that we should perform divergent superior and inferior vertical mattress sutures, something which will be highlighted by my next speakers. Why is it important and critical to repair? It is important to repair because if your meniscus repair tides over the first 24 months after the repair, then there is a good chance that it will survive for more than 10 years, which is very important. And this happens because 20% of the meniscus repairs will fail, and probably they could be as a result of a wrong indication or a poor technique or a meniscus which did not have good biology. Another important critical aspect is that if you remove the meniscus at the first go, then you will perform a meniscectomy, which is 85% more than what would be if your repair failed at a later date. Also, this study showed that you will have a 50% higher chance of landing up with a chondral lesion if you perform a primary meniscectomy. The association between anatomical healing and clinical results has also been demonstrated that with improved meniscal healing, there is improved clinical outcomes. Also, is very critical to understand that if you perform a meniscus repair, you are more likely to not get osteoarthritis and you are more likely to return to the pre-injury levels. So which are the factors to consider? I think consider tears which are in zone 0 and zone 1 and some selective tears in zone 2. Definitely repair all the lateral meniscus tears as much as possible. They stand a lower risk of failure than the medial tears. Repair the smaller tears for sure. If you have a longer tear, then it may lead to a poorer prognosis because the healing rates may be lower. But please understand that if you perform a large meniscectomy, you are definitely going to get a poor result, which is why you should try and repair as much as possible. It's also important to understand that partial meniscectomy will lead to lower reoperation rates than meniscus repair. And this is more so on the lateral than on the medial side. But what is important and critical to understand is that we need to do a good combined repair if we want to ensure that we want to have good stability and good outcomes. The Lishom scores and the amount of chondral degeneration is definitely going to be more when you perform a meniscus repair, and that holds true for osteoarthritis as well. So to conclude, to save meniscus tissue is of prime importance. It prevents osteoarthritis and restores normal biomechanics. You need to be aware of the various different methods of meniscus repair, including those for hidden lesions, which are the ramp and the root tears. Thank you very much for your kind attention, and I hope to meet all of you soon in person.
As you know, meniscus is one of the important structure in the knee joint. Dr. Sandeep Biraris will present on a decision making in meniscus dissection or meniscus repair.
Good morning. Thank you, Odisha Arthroscopy Society and Odisha Orthopedic Association for conducting this IAS Con. I would like to apologize on behalf of Dr. Sachin Tapasvi. He couldn't make it because of medical reasons in the family. So he has conveyed his apologies. So I'll be speaking on decision making in meniscus tear. So we saw the excellent talk by Dr. Sachin Tapasvi. So greetings from Indian Arthroscopy Society. Do join Indian Arthroscopy Society. Okay, so I have nothing to disclose. So when we look at the meniscus tears, so in orthopedic injuries, meniscus injuries are the very most common injuries. And arthroscopic partial meniscectomy is one of the most common surgery, which is being performed by the arthroscopy surgeons. So when we look at the pathanatomy of the meniscus, it is a crescent-shaped structure, and all the it is arranged in a triangular. It looks triangular in a cross section, and fibers are arranged in a circumferential orientation. And there are two roots attachments of either of the meniscus. So lateral meniscus covers almost 84% of the condylar surface, while medial covers up to 64% of the condylar surface. So vascularity of the meniscus is mainly by genicular arteries, and there are 3 vascular zones which are very well covered in earlier talk by Dr. Sachin Tapasvi. So because of this collagen organization into circumferential radial fibers and fine superficial layer around the outside of the meniscus, so meniscus gives function as a load sharing, and also it increases the congruity of the joint. So that's why it is helpful in providing the stability of the knee joint. And it also helps in the lubrication of the knee joints. So when we look at the biomechanics of the meniscus, in extension, almost 50% of the load is absorbed by the meniscus. But when you flex the knee at 90 degrees of flexion, the load is up to 90%. And beyond 90%, all the forces predominate through the posterior horns of the meniscus or through the root. So that's the reason root or posterior horn is equally important, and it gets torn very commonly. So when you remove the meniscus or when you do meniscectomy, then it can lead to almost 2 to 3 times increase in the contact stress. And if you remove only inner 1/3, then there is only 10% reduction in contact area and 65 increase in the stress. So why it is important? Because depending upon that, we need to take the decision about to remove or repair the meniscus. And if roots are not treated or not repaired, then that meniscus behave or that knee behaves as if there is a complete meniscectomy. So various tears and zones, I'm not going to go into it through it. So when you about the diagnosis of the meniscus, the most common diagnosis we can do with the various tests, McMurray's, Apley's, then Thessaly's test, and MRI is the gold standard for the meniscus. So when we decide to do MRI, if you are suspecting meniscus tear in the patient, then earliest is always better because you don't want to miss any trapped meniscus. And if the MRI is delayed, then plan of the management might change, like the meniscus which you have planned for repairing, you might have to do resection. So how do we decide about the management? There are two important factors which you need to consider when you are tackling the meniscus, the patient-related factors and meniscus-related factors. So any of the fresh injury of the knee, the main treatment line is RISE treatment. It is for generally elderly patients, patients who has got a mild arthritis, grade 1 or grade 2 meniscus tear, patients who are less motivated, patients who have opted for non-surgical management, the tears which are stable or longitudinal tear less than 10 mm width and less than 3 mm displacement can be treated conservatively. Also less than 3 mm of radial tears and stable tears. These all are the indications of the conservative management. When you look at this chart, when you see the tears in the red zone, tears in the red zone, which mentioned in the top. So if you repair, then results are very good. But as you go down, so like if there are longitudinal or chronic tears, then repairability increases. So as to the location where they are located. So white zone, the repairability is very poor. So they need to be resected. So partial meniscectomy is usually for the radial type of or flap or horizontal and complex tears and tears in the white zones. So in partial meniscectomy, goal is always to debride and leave the stable peripheral rim. You do not resect complete meniscus. Try and leave as much as possible. Whatever you preserve is ideal. And studies have shown 80% satisfactory result at the end of 5 years. And if you debride the lateral meniscus or resect the lateral meniscus, the studies have shown that there is faster degeneration. So try and preserve lateral meniscus as long as possible. So in partial meniscectomy, as I said, the goal is to debride and leave the stable rim. So the positive predictors of the positive results of this meniscectomy are, less than 40 years of age, normal alignment, very mild arthritis, and single fragment tear. So if you do meniscectomy of these patients, the results can be better. So criteria for meniscal repair versus partial meniscectomy, how you decide? So there are these 5 different criterias, like distance from the rim. So if it is less than 3 mm distance, stable, a recent tear, and return to play is later, and age of patient is younger, then you can consider repair of these patients. But if the distance from the rim is more than 3 mm, it is a mobile type of tear, chronic tear, and patients, they want to return to play sooner, and patients are relatively older or more than 40 years of age, then you can consider partial meniscectomy for such patient. So what are the indications for repair? A tear between 1 to 4 centimeters. Then red zone tears, vertical tears, patient less than 40 years of age, there is no malalignment, no varus or valgus, acute tears, and if you are planning concurrent ACL reconstruction, then those also can be treated. So relative contraindications for the repair being advanced osteoarthritis, complex tears, poor tissue quality, and patient has a ACL deficient knee. Then in that case, the only meniscus repair is not going to help. There might be need for some other procedure. So when you are deciding about repair, which type of stitch need to be taken? So either vertical mattress or horizontal mattress. So because if you take vertical mattress, so it gives good compression of the collagen fibers because they are attached in a horizontal fashion as compared to horizontal mattress. And how to choose type of repair? So whatever the marked in the red is all inside, can be managed very well with all inside. Whatever mentioned in this blue zone is inside out, and the anterior most by outside in technique. So all inside repair reduces surgical time, no external approaches or incisions. We can access the far posterior part of the meniscus. We may have to use the costly devices of various companies. I'm going to skip this video. As we have seen very well in the live surgery. Then other one is the inside out repair, where you pass the thread from outside and take the bite into the inside and take bite, bring it out and take a safety incision onto the knee and tie the knots. So threads are getting passed from the inside, they are brought outside the capsule, and then knots are tied down over the capsule. It is very helpful for the posterior horn repairs. Then outside in is for anterior horn tears mainly, or even mid-anterior, mid-thirds, radial tears, even for complex tears, and sometimes for reduction of bucket handle tears. So this is the one video from Tim Spalding where he has shown outside in repair on the model of the meniscus with a very cost-effective and cheaper technique. So with the 18 mm cannula, the loop has come outside. It is very cheapest. We can use non-absorbable sutures. Then with the second needle, again, he's passing the loop. So whenever you are repairing either inside out or outside in, rule is to take one stitch at every 5 mm of the tear. And the studies have shown that these stitches are very much durable than these all inside devices. Outside in also, you can manage very well with various devices commercially available, or even 18 mm cannulas or needles as shown in the video. So when you rehabilitate of this tear, so how you decide if you do meniscus repair? So patient must be allowed to wear brace and do be partial weight bearing for 2 weeks. Then sedentary workers can return back to work in 1 week, and laborers usually 6 to 8 weeks, and athletes usually 3 to 4 months. And studies have shown good results at the end of 10 years. But then for the meniscus repair and partial meniscectomy recovery, sedentary workers can be back to their work in 1 week, laborers in 2 to 4 weeks, athletes in 2 to 6 weeks. And at 15 years, there have been very good results. But you need to have a proper indication for either of the technique. So take home message: degenerative changes develop more frequently, meniscectomized knee. Longitudinal tears heal more readily than the radial tears. Peripheral tears heal usually faster. And if you repair both meniscus and ligaments, it improves the outcome. Thank you very much. And I would like to invite you all for the IAS Con Bangalore. Registration is open. Early bird offer is going on. Do register. It is there on 12th to 14th September 2024. Thank you.
Thank you, Dr. Sandeep, for nice presentation. Any questions? Bye.
Sir, suppose a patient of age between 15 to 30 in the second or third decade of life, and we are treating ACL, doing ACL reconstruction, along with long-standing means more than 6 months old of bucket handle tear of lateral or medial meniscus, whether it is in red or red-white zone. So what is your opinion, sir?
Okay, patient is between third decade, 30 to 40 years.
Between sir 16, 17 to 30.
Okay.
So second or third decade, sir.
And long-standing meniscus tear.
5 to 6 months old.
Okay, so based on this, my plan will be to ACL reconstruction and repair of the meniscus. Now, when we go intraoperatively, so even though it is chronic tear for the second or third decade, you cannot plan about meniscectomy. So meniscectomy of that patient will be my intraoperative decision, because if I go inside and see if tear is in the red zone, stable, then I'm going to repair it. But it is a complex tear or radial tear or flap tear, then there is no point in repairing that. We are just adding unnecessary time for that patient and also cost. So better to resect, leave peripheral rim, and do the ACL reconstruction.
So better, even if it is more than 6 months old, better to repair than to resect.
Of course, because so location of the tear is more important rather than chronicity. So it has to be, if it is a red zone and more than 6 months, then still we have to give chance for the repair. We just need to put it back where it is.
Thank you, sir.
So you just wanted to say that there is no time bar for the meniscus repair. If it is the tissue inside the, if arthroscopically you are found is a good tissue, you can repair. That is the message you want like to give?
If tissue is good, yes, you should repair.
So there is no time bound for the injury. Suppose it is a more than 9 months or 1 year also you can.
No, sir.
Right, okay.
Tissue and the location, very important.
Tissue and the location.
Yes.
The arthroscopically you found that, okay, this is a very good tissue and in more than 9 months also, no issue. We can repair that.
What Dr. Vikram and Dr. Ranjit, what's your opinion?
So for me, there are two types of tears. Tears that are waiting to heal and tears that don't heal normally easily. Vertical tears like bucket handle tears, which are quite peripheral, are waiting to heal. So time limit for me doesn't matter as long as the meniscus quality is good and my preparation of the meniscus bed is good enough. Number two, root tears, and in that category come radial tears also. They are a type of, root tears are a type of radial tears. Remember, there is a biomechanical factor influencing its healing, usually alignment, usually some kind of degenerative changes that have started in the knee. So be very circumspect at only repairing the meniscus because it may just be the tip of the iceberg.
Yeah, for me, the same thing. Time is not a factor as long as your tissue quality is good and your preparation for the meniscal repair is good and you are maintaining the biology. Time is not a factor.
Thank you, sir.
Thank you, Dr. Sandeep. I thank all delegates for taking part in the lively discussion, and our session is over. Now I request the other chairmen to come over. Thank you.
Hello.
Our next session will be meniscus repair techniques. It is a video session. For this, I request Professor Dr. Tanmay Mahanti and Dr. Damodar Panda sir to chair the session. Dr. Damodar Panda has not arrived yet. I request Dr. Devasis Mishra sir to become the chairperson for this session.
It's time to start the program. Probably the first video demonstration will be done by Dr. Asutosh. May I request Dr. Asutosh to start his presentation? Yeah, please.
Thank you. I'll be talking on the video techniques regarding the all inside meniscus repair. As you all know, the previous Sandeep sir already told regarding the zone where we repair the techniques for the all inside, the posterior medial or posterior lateral part of the meniscus is prepared. For the middle, inside out, and for the anterior, outside in. So in the medial meniscus, mostly in the posterior part, and lateral meniscus, mostly in the posterolateral part, we'll do the meniscus all inside technique repair. So this is a video demonstration taken from Arthrex. Actually, this is a tear, horizontal tear in the posteromedial aspect. So first we measure the depth. Then we pass the needle and first bite was taken. Then we come out gradually. Then this is a horizontal mattress. Take the second bite. Then fire. Release the second one. Then pull out. And we pull the loop with a probe. And gradually tighten. So the tear is reduced, and with a knot pusher, we tighten the knot and cut the suture. So the posterior aspect, two knots are there in the capsule, and here the horizontal mattress was taken. Coming to a video presentation of a bucket handle tear of lateral meniscus. The condyle is a young patient, the condyle is very good. The medial meniscus was intact. ACL was intact. And this is the flip bucket handle tear of the lateral meniscus. So first we try the reducibility of the bucket handle tear. We try to reduce the tear. After reduction, we have to prepare the meniscal bed for nice sealing. So before the repair, we have to prepare the bed. So with a carved bar, the posterior aspect of the meniscus and the capsule is nicely curated to till the fresh bleeding edges are seen. And in the middle body of the meniscus, we have planned for a horizontal repair. We fire the first one till you hear a click and the adequate distance is covered. Then release withdrawn the needle. And the second side, we again fire after passing. Now, after pulling the suture, the knot is tightened. So the bucket handle tear at the body, it has reduced. Tighten the knot and cut the suture with a knot pusher cum cutter. Here we have to change the portal from anteromedial to anterolateral, and we are targeting the posterolateral aspect. Posterolateral aspect. Here again the same horizontal matrix technique is followed. Ideally, we kept the distance up to 18 millimeters. The similar steps are followed. And another knot is given at the anterior side, antero middle part of the body. So after the 3 knots, this is again it is playing. Can you forward it? Is not showing. The last step. Okay. Establish second declaration. Okay. This is the final repair, and the stability is checked. It has nicely been reduced. So with all inside technique, we can access the posteromedial and posterolateral aspect, and the time is very minimal. But the disadvantage is it is expensive to than the inside out or all inside or outside intake. Thank you.
Hello. One question here. Minimum, how many stitches can be given in between that tear, and what is the distance between those two stitches? Minimum, what is the distance between the 2 stitches?
Here we are planning for the horizontal matrix.
Yeah, horizontal.
So the minimum is 5 to 6 millimeter.
Between 2 stitches.
2. If the bite is too close, when you pull the bite will be merged. So there will be no reduction of the tear.
Okay. I think means here the distance was looking bit more in between the 2 stitches, which is because that was a long tear.
You are seeing it is in a zoom view.
Okay. So minimum 5 to 6 mm.
5 to 6 millimeter is ideal.
Okay. Thank you, sir. And what is the point of entry from the tear side when you fire it?
Before you take a bite to the meniscus, you have to plan your trajectory.
Okay.
In which direction you have to go.
Yeah,
So
yeah.
you have to make the portal accordingly. So
Okay.
the first bite I have taken in the anteromedial portal.
Yeah,
The
anteromedial.
second and second bite I have taken in the lateral portal.
And lateral portal.
So that I can access the posterior part.
Okay.
So,
So-
first you have to maintain your trajectory, right?
Yeah.
Then you, otherwise you can make accessories portal.
Yeah, trajectory is made. So when firing, from what distance from the tear side we have to fire? Means distance from the tears while firing that
I couldn't got the
means you are having that longitudinal tear. One inner side, one part is there in the outer part. While you are firing from the inner part, means how much distance from the tear we have to fire that one?
First, you have to access the meniscal tissue structure. If it is
Yeah.
good, you have to you have to put something like 4 to 5 millimeter below the tear. If it is close to the tear, when you pull, it is bypass the tear. So no meaning of putting the suture there.
Okay. Okay, thank you, sir.
Live surgery is ready.
Yeah, live surgery is already ready. So we'll move on to the live surgery. Sorry for the interruption. I think it's from the management side. Anyone from the audiovisual team who can coordinate with the OT?
Okay.
We got a phone call. Please just verify, I think, brother. Otherwise, we'll carry on with the same talks. Got a phone.
Am I audible? जा रही है वहाँ? Transmission on है?
For this session, I think myself is there, and Dr. Rajiv, may I request you to please come on stage, and Satya, Dr. Satya.
Devashish sir, you can. Hello. Can we audible from in the OT?
Am I
Hello.
audible?
Yes. Hello.
Yeah.
Hello.
Hello, am I audible?
Dr. Joshi.
Yes, am I audible?
Dr. Deepak.
Yes, I am audible.
Are we audible to you?
Yeah, you are audible to me. Am I audible?
Yes, Dr. Deepak. We are, I am Dr. Satya, Dr. Rajiv is here, Dr. Devashish is here.
Yeah,
Waiting for you.
yeah, I have just entered inside the joint. I have taken this, I think whether the history is talked. He's a young guy in the fire service. He got twisted while playing basketball, I think. So it's a 3 months old injury. So the knee was locked and he was walking on that. If you look at the MRI, I think whether the slides have been shown to you regarding the MRI.
No, not yet.
So you can focus on that MRI. Udhar focus karo. So if you can look at the picture, if I show you, if you go there, so this patient has a complete. You can see the ACL is torn. यहाँ पे focus करो. Here. यहाँ पे कर रहे हो? Can you see this thing in the MRI?
Yes.
So it's a classical, it's a buckling of the PCL is there, and we can see the double PCL sign. A case of bucket handle tear along with an ACL injury. So he has a pivot shift positive.
Tear of the medial meniscus.
Yeah. So it's a
3 months. 3 months duration.
3 months old. So the plan was to repair, but when I entered the joint, I have already harvested the hamstring tendon. I think the previous surgery already it was shown to you. And this is the meniscus that what I have got. And it has also rubbed because he was walking on to it. A defect in the cartilage here in the weight bearing zone. Okay. So it's around 6 into 6 millimeter. But look at the quality of the meniscus. It has multiple tears. So you can see how it looks like. Let me reduce it. So that's how I have reduced. It's coming back again. Pair pakad lo. So that's how it's reduced. It's again coming back. So so from my side, if you look at the anterior horn, I don't think this is probably a repairable meniscus. Anyone in the auditorium who thinks that this meniscus should be repaired?
No, I think it's a very poor quality.
Very
and
poor quality.
Millimeters, not reducible. I think
And
not.
it is you can see multiple tears here. If I
Yeah.
reduce it, I'll just show you.
I think balancing is the best option.
So that's, you can see the tear is also here. Okay, it's a multiple, one tear is here, one tear is here. So much of a bad tissue. So it's always feel pain to do a meniscectomy in a young patient, but so these are the tears. You can see one more tear here, tear in a tear. So the tissue is very poor, already rubbed the cartilage. I think, I don't think it's a repairable meniscus. So I'm going to remove it.
If at all you decide to operate, this is devices. If at all you decide to operate, I mean, any chance of, what will be your chance of having a reoperation rate?
In this case, it will be, I think, normal. It's around 35%, 40% re-tear rate is there whenever we repair the meniscus. It's of a bucket handle type. So we have still 65 to 70% of a success. But if I repair this, it's going to be threads all around. You can see we don't have a tissue. We don't have a very good tissue anteriorly, and I don't think this meniscus is going to heal.
Dr.
Deepak, very low potential. I cannot say the percentage, but very low potential.
Dr. Deepak, may I have a very basic question for the beginners here?
Yeah.
What portal you are using, and what is your tips and tricks to see the whole meniscus while you are scoping?
Okay, I have made a very standard portal. Okay, that is the viewing portal is just at the level of the tip of the patella. So I go laterally and feel the short spot. So that's a standard, little higher portal. It is not a standard that is described in the book, 1 centimeter below and 1 centimeter medial to lateral to the patellar tendon. It is at the level of the tip of the patella. So whatever I am seeing from the above. So I can see the entire structure thing. The other thing is always when we do make a portal, whenever we make a medial portal. So you can see this portal is quite almost touching the tendon, patellar tendon. Okay. So I have to be my needle. I can put the needle from here. You can see. So that is for trajectory for the ACL. So I can put needle from here. So it is more medial. Since I was planning for a repair of a meniscus. My working portal is very, very close to midline. So here I would be putting my all inside cinches. All inside implant will go from here, and this is how it's going to repair. Okay. And so that's how is there. So if we are planning to repair such big meniscus, so we should know how to. Sometimes the knee is very tight. This is a big guy and the knee is quite opening here, but sometimes the knee doesn't open. So if the knee doesn't open, so we should not be afraid of actually doing the pie crusting of the MCL posteriorly at the level of the joint line. Okay. So you can see good valgus, and you can see the entire meniscus. That's here on.
Can we have a look at the position of your knee from outside?
Yeah, you can see. Would not dikhao. Just put so either you can put a support or somebody is holding the thigh here, and with my thigh I am giving the entire valgus. Okay, so knee is about 30-degree your flexion, the lateral extension. Okay, and I'm seeing the entire of your this thing. You can see
great.
That's the posterior horn, that's the middle part, that's the anterior horn. So I would have loved to really do the oats in this, probably the osteochondral grafting here. But I think I don't have that thing, so I am going to do a simple microfracture here. Okay.
So your plan is meniscal balancing, microfracture, and ACL.
Yeah.
Reconstruction. Yeah.
So that's the meniscus. So straightforward. So we always tend to feel these are the days of meniscus repair. We should repair each and everything, but we should know to judge what is repairable and what is not repairable. It is sometimes a clinical decision, and seeing the quality of tissue very important. Don't repair something which is not repairable, because you may cause more damage to the structures.
The most of the time it's intraoperative decision. So whatever you
Most of the
say,
time,
yeah,
if we
so
always go with the
we get ready.
mind, it's
Yeah.
an open mind. We always go for the repair. That's
Yes,
what
yes.
we tell our patients also. We always go with an open mind that we're going to repair. This is the era of meniscus repair. So we always feel bad whenever we have थोड़ा सा पतला वाला वो दे दो blade. So we always feel bad whenever we do it. So I should have cut it. पतला shaver है? So that's how दे दो. So you can see sometimes it's very difficult to enter your instrument may not enter the चलाना shaver चला दो बीच वाला. So this is I am working from you can see now the knee is in the varus position, it's not in the valgus. So sometimes the posterior horn is not visible it is not accessible in the valgus position. So putting an instrument is difficult. You can see this is how the meniscus part has come here. So that's a varus and little internal rotation along the thigh. You can see the posterior horn here like this. Okay. So let's see, that's all with the meniscus. So, and let's extend the knee. So it is for the beginners, you see the anterior joint opens in flexion, that's 90-degree flexion. So as we go posteriorly, the posterior joint is closed. So we have to extend the knee. So we have to put the scope strategically at a position and slowly extend the knee. थोड़ा उठाओ. You can see now the posterior joint opens and the anterior joint, the scope is strategically placed. So that's how the field. So this is just a flap here. This is all stable. I am not going to do anything for this. Okay. So lateral meniscus is figured for 4 position. So that's a particle of the medial meniscus. It has come anteriorly. So that's gone. So that's the lateral meniscus. So the popliteus, everything fine, no loose body, nothing here. So it's classical ACL, transcoltal, screw on tibial side, and if the tunnel length is fine, then I'm going to put a fixed loop on this thing. Try to preserve as much of stump as possible, though there was not much of a stump here. So I go posteriorly. So that's a ridge. That's a ridge, and the ACL is placed always in the stump. So here, since the stump is not that much visible, the ACL is to be put in the lower 50% of the notch below the ridge, below and behind the ridge. So that's a ridge here. Can you see? Can you make out? That's a ridge. That's I'm going posteriorly. That's the over the top position. So I just try to debride a bit so that I just can see the clear view of my posterior wall. So once I'm going for the tibial tunnel. So once I elbow point, this is elbow. So that's the elbow jig. So the points for the tibial side is you can see the posterior border of the anterior horn of the lateral meniscus. So I go parallel in the stump, in the center of the stump. So that's the elbow jig. So this is where my bit should exit. So since the stump is not that good here, otherwise, my landmark is if you have the meniscus is gone, you see the entire stump, divide into anterior and posterior half and place it in the center or maybe a little bit anterior to the center. If you have anything, then the classical thing that we used to do long back, we used to take reference the PCL 7 millimeter in front of the PCL. So these are the 3 landmarks that we use. Now these days we are using I think most of the surgeons are using the anterior horn of the lateral meniscus as the highest point of the tibial spine. Okay. So any questions? I think.
Would you shave off any part of this remnant?
No, I generally don't. There is no remnant at all. Somehow I don't know why in 3 months time, just the remnant has disappeared. But I would have loved to save everything, whatever is available, both on femur as well as tibial side. So that gives good proprioception. That's the jig here. It's coming. Let me see whether it is little anterior or not. So I will just do the extension and see.
Hello. Yeah, Deepak.
To be little impinging. So I'll use
Hello?
a 5mm reamer. First. So it looks little anterior to me because it is just, if I extend it, maybe just impinging onto the roof. So either I can remove it and drill it again. So or else I will use a 4mm reamer and 5mm reamer, and then I will push it a little bit posteriorly. So
Dr. Deepak, what graft you are using?
I am using both semitendinosus and gracilis. I have quadrupled it. The graft diameter is snugly fitting 8mm. So I am not going to do anything. So I always take the graft 8mm as a landmark. If it is 8mm, it is less than 8mm, then I always make it 5 strand or 6 strand. Otherwise, 8mm is acceptable as quadrupled hamstrings and gracilis.
Do you think that he's a basketball player? I think your hamstring graft will be adequate, or you want to have some different opinion to that?
Actually at our center we do lots of players, so lots of so even gymnasts and all this basketball. There used to be, we used to feel long back this question again. I think somebody had asked us that whether using hamstrings and again, but I think all the players do well. The hamstring graft is good. I think we don't have any problem with that. We have the BTV and the quadriceps tendon only for the revision cases. So I am sorry, while I was talking, what I had done, so that I had pushed the drill bit backwards, and my assistant had reamed with an 8mm reamer. Okay, anything?
No, just a question.
Yeah. So, yeah. So you can see that's a ridge here, and it is a bob. So whatever I am making, I am going to make in the lower 50% of the notch. So I have taken an offset. So
Outside picture is blocked by somebody.
देखो कोई आगे आ गया क्या? यहाँ पे देखो सर पे.
Outside picture, please.
अभी आ रही है.
Focus. Somebody is, yeah, better.
So I use.
Dr. Deepak, please show us exactly where you are placing your jig.
Okay, so if you can see, if I'm seeing from the standard portal, if you give me the probe. So that's the ridge here. So
yes,
that's the intercondylar ridge. Okay, so we'll make everything behind and below. So whatever we make in the lower 50% of the notch. Here the stump somehow was not there. Otherwise, there is always lots of stump. So make it in the center of the stump somewhere here. Okay. So
okay.
This is how we used to, when we started doing arthroscopy, this was our position. This is how we used to look. So then the resident ridge or the intercondylar ridge used to be transtibial way when we used to do. Used to be anterior, and we used to go posterior and make it. But as our orientation over the year has changed, so we now have started looking like this. So the ridge is superior and anterior, and the graft is posterior. Sorry, the ACL is posterior and inferior. That's how it is. That's the over the top position or the back of the knee joint. So I'm going to use an offset. I always use an offset because it gives me freedom to place my jig anywhere where I want to put. So I go posteriorly. You can see
offset, you can make it up or down. Yes.
Yeah, I can make it up, down, anterior,
yes.
posterior, wherever I want to go. So all the control is in my hand then. So I have gone posterior. You can see now I'll ask my assistant to flex the knee. It's right now little extended. So when we flex, you can see as the condyle comes, it always seats.
Yes.
On the posterior wall. Okay. And where I had made the thing raw, that was the ridge above. So my little bit actually coming here, and I see the trajectory where it is coming. It is coming on the lateral aspect of the femur. Okay. So that's a spade wire I'm using here. I think Many people are coming.
Dr. Deepak, how much flexion at the knee you are trying to achieve, and can we see it from outside?
Yeah, you can see here, it is just above 90 degree, maybe it is 95 to 100 degree. Okay, not the hyperflexion that we used to do long back, because we have to make the trajectory of the tunnel is such that the graft doesn't take a bend, so that we don't have any stresses onto the graft. When we do double bundle, we still do double bundle in some patients, then we make the two tunnels at differential position. So we make the anteromedial at 90 degree and the posterolateral at around 100 more than hyperflex position. Any difference of opinion on that?
No, I think all of us do it in a hyperflexion. Only thing is that whenever footprint is there, I try to put my between with the 4 millimeter jig over the center of the footprint.
If the center, yeah, if the footprint is there, then we just manipulate so that we go in the center of the footprint. We can really mark that area where exactly we want to put. So that's how it is. The wire has gone in. I am going to pull it back.
Deepak, yeah, hello.
Yeah.
Do you have any opinion about the outside in technique?
Well, outside in technique we generally use when we do the revisions. So when we have made our own, it's when our own patients come and we have done a normal transporter technique and the tunnels are normal, then only we use an outside in technique. Otherwise, I don't have any experience as such with the outside in technique. Okay.
Yeah.
So that's also good, but I may be wrong, but I personally feel पानी देखो क्यों नहीं आ रहा, पंप कर दो थोड़ा सा, शेवर दे देना. So I personally feel that if we do an outside in technique, the graft suddenly changes direction. But it may be my perception. It is not, I'm not against that thing. So many people are doing that. I'm just do little shaver. So we feel that the graft changes. We have to make the graft so that it has minimal stresses on it. It don't take changes too much of direction. So that is 4. So I am just pulling back. So it is 35. Okay, 35 from the cortex. So I had used the spade one. I'm pulling it. It is stuck against the cortex. So the length of the distance from this point, footprint point, to the far cortex of the lateral femoral condyle is 35. So 35 is the condition where we can easily use the fixed loop. If you use a 15 millimeter of fixed loop implant, we have a graft around 20 millimeter inside and a 15 millimeter hanging from the cortex. Okay.
You are using a fixed loop.
Yeah, I'm using a fixed loop. So most of the time, if the tunnels are longer or good, I use fixed loop. In females, the tunnels are smaller. There I use the
35 tunnel, how much you will ream?
Okay. So since I will have a 15 millimeter, so 20 millimeter is the graft that will be inside. So I'm going to ream till 20. And I will ream another 7 to 8 millimeter to allow the endo button to go up and flip. Okay.
So you have 7 millimeter of lateral wall still intact.
Yeah, still intact.
And 6 to 8 is good enough for players also.
Yeah. थोड़ा सा और, थोड़ा सा और, थोड़ा सा और, थोड़ा सा पास. Okay. 4 mm चाहिए होगा. 4 mm दे दो. It's wonderful to be here. I have come to Odisha, Bhubaneswar, second time. Earlier also Dr. Ranajit had invited me. It was always pleasure, and I really thank the IAS Indian Arthroscopy Society and the Odisha Arthroscopy Society for inviting me here. And
we are also proud to have you here.
Thank you so much.
What diameter you are reaming now?
4 millimeter. So 4 millimeter is to allow the button to cross the tunnel. Okay, so that's how much millimeter that we ream. ऐसे खींच के रखो, ठीक, पुल कर लो. So नहीं, वो निकल गया. वो क्लोज लूप वाली नहीं है, वो निकल गया. धागा वो निकल गया इसमें से, शार्प था, है ना? क्लोज लूप वाला नहीं है ये बीट पिन जो हमारे पास नहीं। हाँ, ये दे। So I think the thread didn't come, so I will just go again.
Yeah, you have to change it, I think, with I between
With the I1.
because this is for all inside, I think, the between they have provided.
So yes, pull. So that's how it looks like. I'll just show you how the tunnel is. So I now straighten it. So retriever दे दो. Retract कर लो, जरा दिखा दो tunnel. Okay. So let me show you how the femoral tunnel looks like. I'm going from the medial portal. Lots of debris. So that's how the tunnel looks like. पानी देखना, पानी खत्म हो गया है, हवा आ रही है, नहीं अभी रुक जा. So that's how the tunnel looks like from the medial portal. You can see around 2 to 3 millimeter wall behind. I am that center. I am below the ridge. Okay. So that's how here I wanted to make
Nice view there.
You can see the far cortex also there. Okay. So I'm going through the standard portal. So you can see from here also. And wash cannula de do.
Outside
wash
picture is
everything.
most of the time. Please
So,
focus the outside picture also.
बाहर की पिक्चर दिखा दो साथ में. आगे सर जो यार, बाहर की पिक्चर दिखा दो, उसको मार्क करने दो, कोई बात नहीं, है ना? I show you the graph how it is marked. It is very simple. So remove all the debris always lie here. So remove all the debris. So some people, we believe that we have seen also, we have done a study also that the wash is very important and remove all the bone particles which are lying here. It prevents the postoperative synovitis and swelling in some subset of patient that we see. So you can see it's all in the stump. It's all in the stump. Whatever it is anatomical. So it's all, you can see how we are marking here. पकड़ लो, लो दिखा दो, कोई बात नहीं, ऐसे दिखाओ. So you can see the tendon here.
You can enlarge the outside picture. Cameraman, yeah.
ये पकड़ लो, खींच लो, है ना?
Make the outside picture. Yes.
That's a fixed loop. That's 15 millimeter. You can see. So that's a 15 millimeter from here. You can see the focus. It is focus enlarged. Okay. So that's 15 millimeter, and that's the graft on mark on the graft is 20 millimeters. So I have some people make 2 marks for allowing for flip, but generally I generally make only 1 mark, that is 35 millimeter from the center of the this button to the graft. So the graft has to travel this much before it flips, then it comes back. Okay, and the 20 millimeter of the graft will remain inside. So this is how the threads work. Just hold. So this is how it will work inside for the beginners, again for the PG students.
What is the total length of your graft?
Total length of the graft is 10 centimeter.
Okay.
So that's how it is. Okay, it will go like this. I'll pull, just खींच के रखो. So then we will flip like this. Okay, so it will go up and it will bypass the tunnel, the cortex, and then we will do like this. It will flip and then we'll pull and it will be stuck on that. This is again for the beginners or the postgraduate students. So we are putting the graft here. बड़ी अंदर की पिक्चर बड़ी कर दो, खींच लो. हाँ, मैंने पकड़ा है, खींच लो. हाँ. ओके, बस मैंने पकड़ लिया, खींच करो. So that's how it is. So what is, I have reached the area. So I'll pull the tiger. So give me bandage. So we always take a bandage. So so that we don't cut our hard and we just pull hard. Counter de do. So it is quite snugly fitting. टूटेगा तो नहीं चलो खींचो जोर से हाँ so that's how the graft has gone. So just remove the slack. So I pulled it so that my assistant has now removed the slack. Now the graft will go inside till the mark. करो अभी mark आया नहीं. So once it has reached the mark, okay, and take a bandage. इधर focus करो हाथों पे डॉक्टर साहब के इधर. So the graft has gone inside. Now look at the outside picture. So my assistant is doing this. So he keep pulling this and he's just pulling this and flip. So it's not a toggle movement. What? Okay. Let's do a little bit of cycling then. ओहो पानी ही बहुत है पकड़ो इसको लो I'll take हो गया okay. So I'm taking the reins from him. Not feeling the good thing. So somebody do the cycling so that the graft will go a little bit more. वो हो गया था क्या? So this is the most tricky part. थोड़ा सा नीचे खींचो. I think it has flipped. So the thread has broken, but I think it has flipped. So we sometimes this thing happen, then we have to see in the image. You have an image? नहीं है? CM है? It has not flipped. हाँ जी क्या लगा रहे हो हाँ लगाओ लगाओ So I'll put another thread. गांठ लगा लो So these are the things that can happen.
Yeah, this is quite common in operative review. So it's always better to check.
Yeah.
Yeah. So go for cyclic loading. If it has not flipped, it has come down. It's good.
Yeah, you have to cycle it very hard. So
Yeah, hard. Yeah, and that's good that it has come down in operating table. Yeah.
yes. मोटी वायर डाल दो कोई फाइबर वायर डाल दो जो बची थी ना निकली थी.
Yes.
फाइबर वायर नहीं थी. Okay. Here we go again. Try again. If it doesn't flip one, then I have to ream maybe 1 or 2 millimeter. ना वो करना है करो सीधा करो. Okay. So here I go again. So these things doesn't come in. नहीं पहले और खींचो पूरा खींचो. नहीं करो. नहीं पकड़ो इसको पकड़ो सारे धागे पूरे खींचो. हाँ चलो खींचो. Yes. Okay. थोड़ा खींचो. We have to remove the slack. Okay.
Yeah.
Slack कम करो. हाँ. Again slack कम करो.
That's going in. Yes.
So slack.
Perfect. Yeah.
Go again.
The marking is at 20, na? So I think you should go 8 millimeter more. You can pull more.
Yeah.
After also.
It is 35 millimeter. I think I'll just put.
So I think this is 20 mark. It will go in.
No, this mark is on 35 from the button.
All right.
So mark is 35 from the button.
I think now.
Let's go. Teacher.
Now it should flip.
Let's see. Finger crossed.
So there were only 4 threads. You don't have flipping thread there? One pulling,
One pulling and one flipping.
flipping, yes.
Hmm.
So your green one is flipping.
Cycling करो ये पानी
Yeah.
से हुआ हुआ है. डालो इसको. We'll just do cycling maybe. टूट जाएगा आर्टरी से ना. ओके. चलो. हो जाएगा अब.
I think now it's okay.
Yeah.
Not coming, yeah.
ला मुझे दो. Give it to me.
Or Deepak, you can go.
I dream little more अगर नहीं होता तो. ला. So I'll one more try. If it breaks, then I will just ream maybe 2 or 3 millimeter more.
And that is the issue with 35 tunnel fixed loop, 28
Yeah.
something. It's there at the edge only. So very
Yeah,
difficult.
it's at the
But at the edge only, yeah. Yeah, edge only. So
yeah.
done.
No, it's broken again. So I'll do the reaming. धागा नहीं है इनका.
I think ream 2 millimeter more, that will
Yeah,
be
I'll ream 2 millimeter more.
yeah, 2 millimeter 30, I think.
Oh, guide wire दे दो. Normal का. Reamer ले लो.
Even the loop size also varies from company to company. That time you have to.
Yeah, that can also occur. The
The loop
flipping and
size-
everything, the fibers and all the things.
It's a ethibond, no? Ethibond?
It's an ethibond on one side.
Yeah,
so
that
it won't
normally
break.
happens, no? If the
Hey,
local,
वो मोट.
yeah, that usually ruptures.
Flex. Oh, this can happen. हाँ, कम करना. मेरे को दो. क्या कह रहे हैं? नहीं किया था क्या? हाँ, फिर से कर लेते हैं. पानी कम. पानी नहीं आ रहा है. पानी नहीं आ रहा है. रुक जाओ, मेरे को देखने दो पहले. So ACL, one of the most simplest surgery. This can happen even in the best of the people. Yes. Wait to me. पकड़ के रखो रेलवे को. करो. We'll check again whether we have done with the 4 mm again or not. चलो. ला. We'll recheck with the 4 mm. See myself now.
You can use 4.5, I think, Deepak, for this fixed loop.
This is 4.5, I think I have taken.
Yeah, 4.5, yeah.
What are you doing? ज़्यादा थोड़ा कितना था? ज़्यादा थोड़ा कितना था? Yeah, okay. रुक जाओ, 1 मिनट रुक जाओ. Just careful. So hopefully everything should be fine now.
Dr. Deepak, please tell us again what did you did actually?
I have
what did-
reamed around with a with a normal reamer, 8 millimeter reamer for about 2 or 3 millimeter. So I did it myself to feel that I am not breaching the cortex. Okay. So I felt that I am not reaming the cortex. I was just at the cortex, and I reamed with a 4.5 also. Okay.
You enlarged your aperture also.
Aperture also, so that the button is getting stuck somewhere.
Yeah, yeah.
Okay. I'm going again. So that's all. So remove flag, come karo. और नहीं जाएगा. देखो flip करके एक बार देखते हैं. Yeah, now it's so it was a story of just 2 millimeter. You can see it's slipping very well.
That happens usually. So, yeah. Fantastic. Yeah, because 35 tunnel fixed loop, no, it's always a.
Yeah.
It's a very interesting learning experience for all of us.
Yes.
Outside picture is blocked most of the time.
आगे से आ जाओ. Outside picture दिखा दो भाई, blur हो रही है. Focus दे दो कुछ. So I am going to do microfracture on that hole. I would have loved to do OATS or the osteochondral autograft transfer in that particular, because it's a very small lesion. 8 millimeter would have been very good. But since I am not having that, so I am going to do a microfracture, which will give the fibrocartilage. And also I will do a lots of sound. Okay, sit.
Dr. Deepak, what type of screw you are using?
I am using it's 8 millimeter. I am using 930 bio screw. Okay, you're giving bio or peak. So we have both bio and peak here. I prefer to use a bio screw if possible. 930. So I have rotated, you can see. So I am putting the graft posteriorly. Okay, so I have rotated it like this, and somebody is pulling it up, and somebody is pushing the tibia backwards at 30 degree.
Cameraman, please zoom in.
Cameraman, zoom karo is pe. You can see the screw is being put posteriorly. So what happened? It pushes the graft little anteriorly. That make it more anatomical, maybe. That's what I feel. The other thing is, if we put the screw anteriorly, that I have seen sometimes. If the anterior tunnel is generally, anterior half tunnel is generally little smaller than the posterior half. Okay. So
Somebody is in front of the camera. Somebody is in front of the camera. Yeah.
So you can see how it is.
Yes.
I
Okay.
have rotated it. I have put the wire posteriorly. I felt it is totally free into the joint. It is not stucking into any bone. If it is stucking onto the bone, then it means the screw will go in divergence then. Okay. So I am totally posterior. So he is just rotated and he is pulling up, and I am just throwing.
Someone is standing in front of the camera.
ये तो मेरा ही आ रही होगी आग.
So this is HA screw by Biotech. Yeah.
This is HA screw Biotech, and I
Yeah.
use the fixed Biotech and the button.
What is the length of this screw?
30.
30. All right. Good.
Your position again, Dr. Deepak, your position of the knee.
You see it, it's around 20 degree. It will 10 to 20 degree
Okay.
flexion. Okay, and totally neutral. He is my assistant, Dr. Bhavani. He's pushing the tibia backwards, and the person he has rolled the graft and pulling it forward. Okay. So
Great.
when I remove the wire, it is not bent and it is not cut. So we should always be sure, look at the wire again for the postgraduate student.
That ensures the trajectory.
Yeah, and the track is also right. If the wire comes out easily, it means your track of the screw was right. Okay, so this is the final picture. This is how it looks like. Little bit of
Inside batao, inside.
you can see.
Inside picture, please.
अंदर की पिक्चर दिखा दो. Okay. So that's how the graph looks like.
Yeah, perfect.
Perfect. Making
Perfect
sure
aligned
I-
graft, no impingement.
No
Yeah.
impingement. I extend.
Fantastic.
There's no impingement. Full extension.
Excellent, excellent. Fair.
I'm going to do microfracture here.
Oh.
Okay. सीधा वाला नहीं है कुछ. सीधा वाला नहीं है, थोड़ा बहुत टेढ़ा है. चलो मारो.
Yeah. So Deepak, I think we will go. Hello.
Yeah.
Deepak, thank you for excellent demonstration. So
Thank you.
we'll come
Thank
back
you
to the
very much.
lecture. And thank you.
Thank you, my assistant, Dr.
Wonderful
Bhavani,
work.
Dr.
Thank you to the whole team also.
And anesthetist and sister,
Well said.
everyone. I'm thankful to everyone for assisting me.
Big round of applause. Deepak, you can hear the round of applause from the floor.
Thank you, dear. Thank you so much.
Yeah. A good couple of, can I move on to the talks, please?
Chalo.
We have got 2 more talks to go. Dr. Akshay Sahu, is he ready here? Yeah. Yeah, please sit down. I'm alone here.
ठीक है, 2 होल हो गए ना. लो, microfracture हो गया.
And Dr. Akshay, I think you have got a technique for the inside out meniscus repair. So please, if your slides are ready, you can start.
चलो.
So to continue the meniscal repair, I will talk about the inside out meniscal repair.
Actually,
Special implants and
Still the
instruments for
incorporation हमारे
inside
हाथ
out
में नहीं है ना.
meniscus. There will be a 10-inch long needle with attached 20 fiber wire or needle with eye on which we can put 2 simple beaded sutures, fiber wires to suture it. Along with, we have jigs for different zones. For anterior aspect, it will be more curved than central part of the body. Then on the posterior aspect, that may be single lumen or double lumen. Depending upon our requirement, you can use that. This is the demonstration of the knee with a meniscal injury. This is on the lateral aspect. Popliteus tendon is visible. This is the meniscus. This is the diagnostic part. After diagnosis, we can go for rasping of the area for the vascularity to come out. Then debride the extra tissues, which is above that, for the clean and for the suturing. We have to give incision for the come out of the needles. It is on the lateral aspect. Most important is the biceps tendon along with the Peroneus nerve, common peroneal nerve. So we have to give an incision on the fibular head to femoral side. It should be the posterior to the LCL. When you will inside remove the skin, you can go for the biceps tendon posteriorly and IT band anteriorly. Give the incision just posterior to the IT band, then retract it. So you can go and visualize the lateral head of the gastrocnemius. Then release it and put a spoon or a retractor, whatever is possible. We put a spoon there so that it will protect the biceps tendon along with the peroneal nerve posteriorly. So whenever we put the needle from the inside to out, it will not injure any neurovascular structures or entangle any tissue. This is the incision I have given, then can remove. This is posterior to the IT band, and you can put a spoon there inside so that you can protect the posterior structures. Then you can start putting the needles on the meniscus, on the capsular aspect, and on the meniscus. Then on the in figure of 4 position, you can give pressure to make it more virus, and the assistant can put the needle. One needle already came out. This is the jig on which it is a double lumen cannula. So I'm putting one more needle there. So it will come and hit the protecting structure or the spoon, what way I put. So the assistant can take out the needle from that side. Just hold the needle above the spoon and it will come out. So that it will not hit any neurovascular structures. Then we can tie one by one. So similarly, as many as possible, you can put the sutures as per our requirement, as we have discussed, 5 to 6 millimeter distance. You can put stitches on the superior surface and if possible also on the inferior aspect to decrease the tilting of the meniscus. On the inferior side also you can put stitches. This is one more case, similar. Forward, no forward. So I'm forwarding it. One more. This is on the medial side, bucket handle tear. This is on the medial aspect. We have done the lateral aspect. Now it is on the medial aspect. This is a young guy with a very small tear with a ACL injury. So after reduction, this is on the medial aspect. Medial aspect also we can give the incision on the posterior aspect of the MCL and retract the semity or gracilis if it is present. If you have taken for the graft, it will be not there. Otherwise, protect the saphenous nerve also on the other side. And release the medial head of the gastrocnemius so that you will be directly on the posterior capsule on the medial aspect. And put the spoon, then we can protect again on the medial side. This is a small tear with a tight knee on the medial aspect. So you just put 2 stitches there. So on the medial side, you can tie the knots now. It should not be, the knot should not be more distance. It should be close to each other and directly on the capsule. And most of the time you should suture it in the extension position. In the lateral aspect, it has no importance much, but in the medial aspect, if you will put it in flexion, sometimes there will be flexion contracture or will be difficult in extension. Thank you.
Do you have any questions for him? Or we move on to the next talk. Just one question, I think, really, before we move on. The lateral compartment is a bit tight. Then how
Yes,
do you
sir.
handle it?
We'll give you virus force. Then it will open up. Most of the time, if it is the associated with the ACL or something, it will, most of the time it will open up. So no need to release anything.
Okay, but you don't release anything at all. I mean,
Yes,
we
sir. Yes,
also
sir.
don't release
Most of the time it will open up with
Do-
virus force.
Do you think it is ideal to, have a look at the peroneal nerve? The safe incision on the lateral side.
Whether it is required.
That's what I'm asking.
Yes, it's required. We may, because of the, depending on the needle position, it may puncture that.
So postoperatively.
Sometimes it will catch hold the biceps also.
That's what I'm telling. So most of the times in the post-op, you don't know if you at all have any. Did you have any, tingling sensation of the peroneal nerve or anything like that? I mean, that's what I'm asking. It was a small incision, no? So exposure to the nerve, is it necessary or not?
That's necessary. Sometimes the suture may entangle the nerve or the tendon. Then with movement, it will be difficult. It will pull the meniscus outside or it will be loose lateral.
So
it should be on the capsule. So I think we should separate it from the suturing area.
Absolutely. Correct. Yeah. So thank you. Okay. I think it's a nice talk because the inside out technique is one of the cost-effective techniques. I move on to next outside. Yeah, meniscus. Let me know, please. Just a second. You can take this.
Hello. So now I'm going to talk about the meniscus repair outside in technique. So these are the zones which my previous speakers all have already said about. That is the all inside out and outside in. Mostly the outside in technique is mostly used in anterior horn tears or to some extent on the middle third and body tears also. So in this technique is first described by Warren et al. In 1985, ideal for anterior horn tears as allows for adequate access, provides a stable fixation construct, and avoids leaving prominent intra-articular material. Can also be used for tear of middle third of the meniscus. And the indications are longitudinal tear of medial meniscus, irrespective of size, horizontal tears of medial meniscus, tears located in red or red-white zone, and patient younger than 40 years of age, and meniscal tears of stable knees. So longitudinal or horizontal tear of lateral meniscus anterior to the popliteal hiatus. And the contraindications are complex tear of meniscus, tear exclusively in white zone, patients older than 40 years, and meniscal tear with OA changes in the same compartment, and meniscus tear in unstable knees. So advantage is a low cost procedure, and disadvantage relatively larger knot passed through the meniscus may cause injury to meniscus itself, and this technique is reproducible. So the instruments and materials are required. These are standard arthroscopy equipments and an arthroscopic probe, a 18 gauge spinal needle or a 16 gauge needle, number 1 proline or 2,0-ethylone, fiber wire, arthroscopic grasper, and suture cutter. These are the certain instruments which is easily available in OT. Now I am demonstrating a surgical video. This is a young patient having ACL tear and meniscus, as you can see, with the lateral meniscus longitudinal tear. Thorough diagnostic arthroscopy is done. The
meniscus tear is freshened and outside in technique is being charged. Now it's use a 16 gauge needle from outside through the joint line. First of all, you have to probe it and feel out from outside where you can put your needle, or else you can put a scope to where it but guided by the light source, you can put a needle. Now put a ethylon 20 through the needle, and you have to grasp through a grasper and should be taken out from the anteromedial portal. Here, the grasper to hold the is okay. Now it's being taken out. Yes. So I'm having difficulty in holding it. Yeah. And now the fiber wire is tied outside, and it is the needle is pulled along with the fiber wire and it's taken out. You have to pull it slowly. You may find resistance while passing the knot. So it will you will feel a jerk, and when it comes out. So one end of the fiber wire is still outside, and here is one end is passed. Next, the next needle again you have to pass from the other end of the tear. It pierces the tear, and again an ethylon is passed through the needle. And again taken out. Taken out from the anteromedial portal. Now the other end of the fiber wire is tied with the ethylene and pulled, and this. Thank you.
Thank you, Vinod. It's a good demonstration. Since you are running short of time, probably. Do you have any questions for him?
I just want to ask Rajiv one question on this talk that he had mentioned that more than 40 years is a contraindication for the repair of the meniscus or enterohorn.
I've got something in my meniscus session. Probably we can discuss a lot about that.
Yeah, okay.
I have a couple of cases for you also. So, Vinod, just a quick comment on that. I think probably we are making a large bore needle. Do you think, I mean, at this stage, because you have got now new devices to handle that, would you straight prefer to go for the outside in technique, or you want to revise your technique right now? Because we know we have to learn every techniques.
Middle pad can give inside out.
Yeah, now we have got devices now which can handle even the anterior pad as well from the contralateral side if you go and can do that.
Economic.
Although the costs are too much, sometimes to pass the needles it's a bit difficult.
There's a cost effect.
Cost is also equally. Thank you, Vinod, for a nice talk. So we come to the end of this particular session. Thank you. Dr. Arun Mahanti sir and Dr. Sandeep Biswal. I know.
All delegates are requested for the inauguration ceremony. Lunch will be served only after inauguration.
Good afternoon, everyone. Good afternoon, everyone. We welcome you all to today's IAS One CME on Basic Knee Arthroscopy conducted by Orthopedic Department of SC Medical College and Hospital in collaboration with Odisha Arthroscopy Society under the aegis of IOA and OOA. We are blessed to have among us few prominent orthopedic surgeons and national arthroscopy surgeons of the country addressing this gathering. First, I would like to invite chief guest of today's event, IAS Secretary, Dr. Sandeep Birare sir, to come up on stage. I would request Dr. Sandeep Lenka sir to kindly accompany him on stage. Now I would request the guest of honor for today's ceremony, convener, Indian Arthroscopy Society, Dr. Ranjit Panigrahi sir, to kindly come up on stage. I would also like to request OAS President Dr. R.N. Mahanti sir and OAS Secretary Dr. R.J. Ashutosh Mahapatra sir to kindly accompany all our respected dignitaries on the stage. Now I would request, I would like to invite upon stage OAS Secretary Professor Dr. B.K. Behera sir. Now I would like to request upon stage organizing chairman Professor Dr. Nirmal Chandra Mahapatra sir and organizing secretary Dr. Sandeep Lekha sir to kindly be seated among the dignitaries. We would like to start this auspicious ceremony by lighting of lamps to seek divine blessing. Now I would like to request all the respected dignitaries to light the lamps. Thank you, sir. I would now request Professor Dr. N.C. Mahapatra sir to kindly come up on stage and address the gathering.
Good afternoon, esteemed dignitaries on the dais, delegates, professors sitting in the audience, ladies and gentlemen, both national and state faculties. I express a hearty welcome to you all to this IAS One, which is a basic knee arthroscopy session training workshop on behalf of Indian Arthroscopy Society and Odisha Arthroscopy Society under the aegis of Odisha Orthopedic Association. As you know, we are proud that this function is going on by the Department of Orthopedics in SCB Medical College, Cuttack. SCB Medical College is one of the very great institution which we celebrated its platinum jubilee in 2019, but the history goes back to 1875. Our department is also very active, and this is the second live surgery workshop we are conducting this year, and have also conducted many cadaveric workshops. Okay, so we are always in forefront. Now coming to this workshop, I would like to remind that all doctors or professionals, we are lifelong learners. Okay, so whoever the experts sitting over, they were advised one day. So I request you all to imbibe as much as possible from this live workshop so that you improve your capacity building skills, technical skills, and make use of the learning which you imbibe from here for benefit of the patients. And I also request you to actively participate in the discussions. If you don't ask a questions, don't ask a question, you are full for 5 minutes. But if you don't ask questions, you are a fool for life. So I welcome you again to this live workshop. Thank you.
Thank you, sir. Now I would like to invite convener IAS One, Dr. Ranjit Panigrai, sir, to address the gathering.
Respected dignitaries on the dais, our IAS Secretary Dr. Sandeep Biraris, our organizing chairman Dr. Nirmal Mahapatra, OAS Secretary Dr. Vasant Kumar Behra, OAS President Dr. R.N. Mahansi sir, OAS Secretary Dr. Arjim Asutosh Mahapatra, and our organizing secretary Dr. Sandeep Lenka. First of all, I want to thank all the delegates who has made this program a highly successful one. Till now, we have 150 registration, which is the highest till now for the IAS One program. So I thank all the delegates from the bottom of my heart for making it successful. I had a discussion with Dr. Sandeep, and we were planning in the month of June, but because of some familial commitment, I was not able to do this. But again, we had a discussion, and he wanted this program to be done in the twin city of Odisha. But basically, as we are focusing on the education through CMEs, didactic lectures, live surgeries, workshops, to the juniors, to the PGs, to the SRs, and the budding arthroscopy surgeons. So we wanted to do it in a medical college, and SCB Medical College was the best place. I had a discussion with Dr. R.G. Asutosh Mahapatra, and he also suggested that we will give the responsibility to the juniors. And Dr. Sandeep Lenka aptly opted for this opportunity, and he eagerly agreed that he will become the organizing secretary. So we went ahead with this program. So I thank all the organizers for conducting such a wonderful program. And lastly, I thank all the faculties who have come over from all over the country and leaving their busy schedule to spare at least one day with us and with our delegates, with our students, exchanging their knowledge and their skills with our delegates. And so I must be thankful for all the faculties who have come from all over the country to grace this program. Thank you all again, and thanks all the delegates.
Thank you, sir. Now I would request Odisha Arthroscopy Society President Dr. R.N. Mahanti, sir, to kindly address the gathering present here.
At the outset, I thank all of the delegates who have come here and made it a success. Main success story is from actually goes to Dr. Ranjit Panigrai and Asutosh. So they have made it very nice, and every people or every student or every faculties, everyone is actually gathering and focusing on the academic as well as the practical part of it. The audiovisual situation is very nice. The session and everything was lively telecasted, and we enjoyed this. Now again, another surgery is also available in next. So this is a very good and lively workshop, which has been possible due to the OS and members associations collaboration with IAS. Thank you. Thank you, IAS.
Thank you, sir. Now I would request Odisha Arthroscopy Society Secretary, Assistant Professor Dr. R.J. Astasma Bhattar, sir, to kindly address the gathering present here.
Respected dignitaries on the dais, my teachers, friends, and all the outside faculties, juniors, I thank everyone from the core of my heart that you have come, attended, and made this program successful. And Ranjit Bhai told everything, but I want to add two things. We have now two very supportive secretary in Indian Arthroscopy Society. One is running, Sandeep sir. Another is coming, Rajiv Raman sir. So we have to take this opportunity to be a member of Indian Arthroscopy Society. If we are the member of Indian Arthroscopy Society, then we can show our strength in national forum and bring this conference to our state. This is a humble request from my heart. Please, please, please register yourself as the Indian Arthroscopy member, and everything rest is told. You have to enjoy a nice lunch is ready, and another beautiful surgery by Dr. Sandeep sir, and hands-on workshop is there. So let's stay and enjoy this conference. Thank you.
Thank you, sir. Now I would request OOS Secretary, Professor Dr. Basant Kumar Behra, sir, to kindly address the gathering.
Good afternoon to everybody. Respected Secretary Dr. Sandeep, IS, and President Secretary of OS, and all the dignitaries on the dash and of the dash. It is my great pleasure and honor to be here in this August gathering. I, on behalf of Odisha Orthopedic Association, I must thank the organizing team and the OS team that they have organized this beautiful CME on basic knee course. This is mainly done for our PG students and the youngsters. I hope we will have more workshops in future. Thank you very much for inviting me. I hope the conference is a great success because we have 150 delegates and the conference success depends on the number of delegates. So thank you very much again for inviting me.
Thank you, sir. Moving on, now our Department of Orthopedics, SC Medical College and Hospital, and Odisha Arthroscopy Society would like to show our gratitude to our chief guest for today's event and guest of honor by presenting them with a memento, for which I would like to call upon Dr. Sandeep Birari, sir, to kindly come on the stage, and I would request Dr. R.N. Mahanti, sir, to kindly present sir with the memento. I would like to request Dr. Ranjit Panigrai, sir, to kindly come on stage, and would request Dr. R.J. Astasma Bhattar, sir, to kindly present sir with a memento. And I would like to request Dr. Basant Kumar Behra sir on stage, and I would also like to request Professor Dr. Nirmal Mahapatra sir to kindly present him with the memento.
Now we want to felicitate our guest faculties. First of all, I would like to invite Dr. Rajiv Raman, who is the Joint Secretary of Indian Arthroscopy Society, going to the Secretary. So, Dr. Rajiv Raman, please. I would like to invite Dr. R.N. Mahanti, sir, to kindly felicitate Dr. Rajiv Raman. Now I would like to request Dr. Deepak Joshi from New Delhi, and I would like to request Dr. B.K. Behra sir to kindly felicitate Dr. Deepak Joshi. Now I would like to request Dr. Bikram Maskar from New Delhi again. And I would like to request Dr. R.J. Asutosh Mahapatra to felicitate Dr. Vikram Maskar. Now I would like to request Dr. Neha Godgate from Nagpur, who is the chief of the women wing of Indian Arthroscopy Society. I would like to request
Ranjit Bhai will give the prize. Now at last, I request R.N. Mahanti sir to give Kottako Tarakosi Kamo award to Sandeep sir. This is a filigree work, only the filigree work. Filigree. Say the filigree. Jagannath.
Thank you, sir. Now I would request chief guest of today's event, Dr. Sandeep Birare sir, to kindly address the gathering present here.
Thank you very much. First of all, on behalf of Indian Arthroscopy Society President, Dr. Sachin Tapasvi, I would like to thank organizing chairman, Dr. Nirmal Mahapatra sir, head of the SCV Medical College, organizing secretary, Dr. Sandeep Lanka sir, for arranging this conference on such a short notice with the help of our convener and past EC colleague of mine, Dr. Ranjit Panigrahi. And also I would like to extend the thanks to all the office bearer of Odisha Arthroscopy Society, President Dr. R.N. Mohanty sir, Secretary Dr. R.G. Ashutosh Mahapatra sir, and Odisha Orthopedic Association President Dr. K. Saskar Rao sir, who is not here, and Dr. Basant Kumar Behra sir. Thank you very much for arranging this CME on such a short notice. So IAS One Indian Arthroscopy Society is the society of over 4,000 arthroscopy society. It was started in 1983 by 11 members. Now it has grown up to 4,000 members. So Indian Arthroscopy Society has started initiative of IAS One. So IAS One is an initiative which is supported by the industry, and this time biotech was gracious enough to grant the educational support for arranging this CME on a short notice, and also providing free of cost implants for the patients who are undergoing the surgery. So with their help and the other support from other pharma colleagues, we are conducting this. So it is now profit making CME, where it is usually conducted at tier 2 or tier 3 cities of the India, not like in metros, because arthroscopy now each and every place arthroscopy is coming up. So this particular CME today, actually there are two important things that which I would like to mention. So this CME has got over 150 registrations. So that's very remarkable, because this is the highest attendance in IAS One CMEs. And number two is like arthroscopy is not only big for, or because only, means it is not only related to men. So we have a representation from women wing of Indian Arthroscopy Society. So thank you very much to all the organizers for inviting Dr. Neha as a faculty in this CME. And I would like to thank everyone who has attended. And the ones who are not member of Indian Arthroscopy Society, sincere request to become member of Indian Arthroscopy Society. So when Dr. Ranjit Panigrahi, I remember he got elected as a EC member. That time there were only 34 members of IAS. But last year itself, Dr. Ranjit Panigrahi and Dr. Ashutosh Mahapatra made over 60 members in last 1 year from this particular state. Thank you very much. So do continue the support for Indian Arthroscopy Society. Thank you.
Thank you, sir. Now I would request Dr. Sandeep Lanka, sir, to kindly deliver the vote of thanks.
Good afternoon, everyone. Respected dignitaries on the dais, respected teachers, seniors, my friends, and my postgraduates. So it's an honor to be the organizing secretary of IAS One Cuttack 2023. So with immense pleasure, I welcome to all the IAS One CME Odisha. The structure of CME was meticulously designed by our president and secretary, Indian Arthroscopy Society. The aim of this kind of CME is to train our postgraduates and the boarding arthroscopic surgeons in the field of arthroscopy to make the complex surgery as simpler as possible, and starting from diagnostic scopy to ACL reconstruction and complex meniscus repair, everything along with osteotomy of the saw bone and workshops, many things are there. So there is something for everyone. And we have conducted 2 excellent surgical demonstrations by our esteemed faculties, and lots of queries lots of discussion has been done in the first session of our IS1 CME. So the CME is filled with esteemed faculties like Dr. Sandeep Biraris, Secretary, Indian Arthroscopy Society, Dr. Deepak Joshi sir, Dr. Rajiv Raman sir, Dr. Vikram Maskar sir, and Dr. Neha Godgoti madam. So it's a league, they are the league of their own. Hence, it gives me immense pride that all of you assembled together to give wings to IS1 and take it to level of another. We have registered 150 delegates, and I salute all the national faculties, your enthusiasm, you have supported us, you have given your valuable time to teaching the younger generation, to the budding and intellectuals. Dear delegates, participation number have been exceptional and surpassed our previous expectations. So hope you will have a fruitful session so far and wish all of you to learn the best in the next session. Without taking much time, I would like to conclude my address. I would like to call Dr. Rajiv Raman sir to speak few words from the faculties.
So Dr. Rajiv is a joint secretary of Indian Arthroscopy Society, and he has been helping me immensely to deliver me my work. And he is going to be taking over as a secretary from 2025 once I retire.
And contesting for IAS secretary. I also request you, Rajiv is most academically active, and whenever you want, he is there, and he is always dynamic and academic. He is, I think, the fittest person to be IOS secretary, so for which he is competing. So I request all the people, since our meeting is now over, I can at least tell that please vote for him. Okay, it's after a long time from eastern side, somebody, such dynamic person is coming up. Thank you.
Thank you, sir. Thank you, sir. And Odisha is like second home. And today morning I was talking with Vikram and Sandeep that I don't know how many times I have been to this place. Since 2004 as a resident, I have been coming for the postgraduate courses for the first CTB workshop at National Institute of Orthopedic Rehabilitation, SCB Medical College. I have stayed in IM a guest house also. So I think it's more than 20 times I have been to this estate, and it's my second home. Thank you so much for all love and support. Thank you so much.
Thank you, sir, for your kind words. Now we would request everyone to stand up for the national anthem.
Jana Gana Man Adhinayaka Jaya Bharata Bhagya Vidhata Punjab Sindhu Gujarat Maratha Dravida Uttara Banga Vindhya Himachala Yamuna Ganga Uchala Jaladhi Taranga तव शुभ नामे जागे तव शुभ आशीष मांगे दारिद्र्य तव जय गाथा जन गण मंगल दारिद्र्य जय हे भारत भाग्य विधाता जय हे जय हे जय हे Jaya 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 Jaya.
I request now all the delegates and faculties to disperse for lunch. Meeting is over now. Thank you.
Hello.
hello, 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 check, check, hello, 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 check, hello, 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 check, hello, 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 hello. Hello, hello, hello.
Post lunch, we are starting the next session. This is on advanced meniscus session. So I'd like to request Dr. R.N. Mahanti sir, Dr. Tanmay Mahanti sir. Dr. R.N. Mahanti sir and Dr. Tanmay Mahanti sir to chair the session.
Hello.
So we'll start this session. Dr. Deepak Joshi. So he will be talking on the horizontal cleavage tear and radial tear of meniscus.
Thank you. So thank you. Again, I thank the Odisha Arthroscopy Society and the IAS for inviting me. So regarding the meniscal tears, what are the current concepts for the repair techniques for radial and horizontal tears? So what are these radial tears? They are the cleavage tears arising from the central region, which is white to white zone. You can see it goes up to the periphery. So this is what we mean by the radial tear, which all the fibers, longitudinal circumferential fibers are torn from the white zone extending on to the red zone. So the patient complains with basically it's sort of a tire burst effect. Whenever the patient put his foot, he feels pain and sense of locking. So regarding etiology, they can be traumatic or degenerative. Lateral meniscal tear, radial tear, we more frequently see, and they are associated with generally with an ACL injury. Medial radial tear generally are root tears, and mostly they are sometimes they are underdiagnosed, and they are most of the times they are degenerative. So there are various classifications. Basically, it is whether it is in what as far as the clinical effects are seen. We have to see whether it is in white zone or it is extending onto the red zone. Then we decide whether it's a flap tear, whether it's a slip tear, whether it is a degenerative tear. That's how we decide whether we are going to repair or we are going to remove this. Several repair techniques have been developed and tested. They are different. They can be inside out, all inside, outside in, transtibial pull out. So it varies according to the surgeon's preference as well as where the tear exists. So these are the few tears. Actually, this is borrowed from one of the paper. So the type A, where it's a conventional horizontal inside out repair, it's in the green. Then in the blue, it's suture based type B, where you can do it all inside double vertical repair. We can combine both of them. We can do crisscross. So these are all various types of tear, hybrid tears and transtibial. We can put an anchor and we can fix it. Various type of repairs we can do. So for profile technique, you can see here in the video here, either we can use a scorpion or we can use a traditional all inside device where we do side to side repairs. So this is one of the options. So as in today's surgery, the tear was very bad. So it's small radial tear in the white zone. You cannot repair it. No point in repairing that thing that doesn't heal. So you just trim a bit, stabilize, and That's all. So now this radial tear of the lateral meniscus, very big tear, going from the white zone to the red zone. We have to see how we are going to reduce it. So this is the all inside devising being put, one peak anchor goes. We have to very careful because this anchors get dislodged. We have to go deep and then push. And we have to see that we take bite through both the fragments. So now these types of repair should not be meniscectomized because as we time and now everyone say we should always try to repair. We can do the meniscectomy in the second stage. In subset of patient it is needed. So when we do it, we have to reduce. So we reduce here. We are reducing with the knot pusher. Don't pull, otherwise the these all inside devices come out. Now see one more friend. Then we see we can put a probe or something, and we see now what part is unstable. So we can again put a device, a plan. It's a fast fix device that is being put, and you can see a plastic. You can see a plastic at the edge. The plastic. When you push, the plastic actually go behind and it seats onto the meniscus. I think Sandeep had shown very beautifully. And again, very carefully, very slowly. It's a push technique. It is not a pull technique. It's a push and pull. You can see how this radial tears can be easily stabilized. Now, regarding the horizontal tears, the majority of horizontal tears are degenerative. That's we have seen with the poor tissue qualities. Sometimes they are not repairable. We have to see which tears we can repair and which tears we cannot repair. The repairable tears generally have thickened tissues, they have fatty deposition, or they may be a partial flap tear. Occasionally, a large horizontal flap tear is also encountered in the people who are older than 50 years throughout the body. So meniscectomy, I think in the previous talks, the meniscectomy was being covered. The very number of techniques for the treatment of horizontal cleavage tear have been described. However, so these are the days of preservation. We always feel bad whenever we cut something, we remove something tissue. We know the meniscus is not vestigial. So we should, whenever we are doing, we should do conserve. There were a time, I think 2002, when I started doing arthroscopy surgeries. So we used to remove lots and lots of meniscus to make it good C shape and good so that it is stable from around. Now it is the meniscus preservation area. Cut only that amount which cannot be repaired. So the horizontal cleavage tear is carefully probed to undermine anterior and posterior extent. If something is avascular repair, if something is avascular like that was there in the today's live surgery, then you should not try to replace the meniscus with a suture. You are not making a rope out of a meniscus. You have to make a meniscus which takes all the functions. So sometimes the augmentation is very important. We aggressively rasping the tear back and peripheral of the capsule to improve the blood supply is very important. So it is very important to rub the capsule as well as the meniscal areas when we proceed with repairs of these types. So you can see this is how the repair can be done using a scorpion or also using all inside devices where basically you are closing the mouth of the two tears. So this is how the tears looks like. It's an older patient, very old tear, degenerative, flaps and complex tears. Here we have done the meniscectomy of a flap, partial meniscectomy of a flap, which was unstable. So here we felt that this tear will not heal and the tissue is very degenerative. And we just remove the upper part, try to preserve as much as meniscus as possible remaining. And you can see most of the meniscus is now preserved and it is stable when we probe it. So we have to be very careful, just remove the unstable parts. So in a younger patients, we have a flap which is not unstable, not degenerated. So here we are doing, we just debride it and we can, this is lateral side, it is very difficult to use sometimes the inside out technique, though we have done in few of the cases. So here the all inside device is being put. So you can see one device, it is going, one part of the plastic is going on the superior surface of the meniscus and the other part goes beneath the meniscus. So you are actually debriding and closing the mouth of meniscus so that it heals to the lower stable portion in a long run, and we preserve the tissue, you can see, and there are no meniscocapsular cysts, and the cyst formation doesn't occur later also. So this is how about the two tears. The thing is try to preserve as much as possible, and meniscectomize only when you think that it is not worth and the degeneration is too much. Thank you so much.
Any questions? Any questions from the audience? No question. Go, you can go. Let's Dr. Rajiv Raman.
Thank you, Chairpersons. So I will be talking on decision making in discoid meniscus. And as you know, most of the discoid meniscus are there inside the knee, unless in teenage, this patient comes to your clinic with sometimes the locking, click, or a third, audible third. So most of these patient presents with either a click or a third or a locking episode. Sometimes the discord is so much symptomatic, the patient comes with a history of pseudo giving way. So they tell you that it's like a giving way. When you put your scope inside, you see that ACL PCL is intact. It's because of the sudden sliding of the tibia of the femur, patient gives a feeling of giving way, pseudo giving way to these patients. So these three types of complaints are quite common when you are dealing with these patients. Patient is coming to your clinic, and most of these patients are in the age group of 10 to 25 years. Once they are active, you will see this asymptomatic discoid after tear or after getting some amount of degeneration inside the knee becomes symptomatic. And normally when they become symptomatic, they present to your clinic. So discoid meniscus, again, it is of two types, incomplete and complete. So complete discoid, you will see whole of the plateau is filled with the meniscal tissue. And incomplete discoid, you can see the meniscal tissue is crossing the midline of the femoral condyle. So here you can see this is a symptomatic discoid, case of a symptomatic discoid meniscus. And if you can see, there's a complex tear there. So most of this tear, usually our aim is to go for balancing. And it should be a la carte approach, so that go for balancing and see for the instability. And you can see the tear is extending. So try to see the unstable layer. This is very important, and locate the unstable layer. Try to preserve the stable layer. So once you have decided, yes, which one is unstable and which one is stable, you can start your meniscal balancing. Yes, again, after every step of meniscal balancing, you just see which layer is unstable and which layer is unstable. Again, try to remove the unstable layer. The basket punch is the best device to go for meniscal balancing. Normally, you should have the straight right-left curve, and sometimes for discoid, you need a backbiter punch also, so that you can balance all of the meniscus. So start from either posterior to anterior or center to posterior and center to anterior. And gradually, once you balance it, you will see there are some rough end edges there, and see for the stability of the rim. Normally, you can see there are two rim. The vertical rim is still unstable. So again, go for balancing. Again, see for the stability. So don't plan for meniscectomy, complete meniscectomy in this patient. Now you see the upper layer was unstable. To try to debride the upper layer, and the lower layer is stable. And you can see the lower part of the meniscus is unstable. So if you can preserve this stable rim also, that will prevent degenerative changes inside the knee. Because most of these patients are in adolescent age group. They have a very active life ahead. So try to preserve the rim. So symptomatic discoid, start balancing. After every step of balancing, see for the stability. Normally, sometimes you get two layers, superior and inferior. See which layer is unstable. Try to balance the unstable layer and try to preserve the stable layer. The second, sometimes you get a discoid meniscus. After balancing, you see that there is a rim of the meniscus is there, and with a vertical tear. So in these patients, normally what I do, I try to stabilize the unstable discoid rim through the on-inside vertical mattress suture. And normally 3 to 4 vertical mattress suture is good enough. You can use any of the suture passing device and the orthocord to give a vertical mattress suture, so that both of the limbs become stable.
As Dr. Deepak showed in the previous slide, the 4 or 5 stitches are good enough to close the mouth and you have a stable rim there. So try to put your knots toward the capsular side. This is very important. You can use your all inside device. You can use your suture passing device. You can use your Neo Scorpion. You can use your first pass mini. So here I am doing it with the first pass mini and an orthocord. So after 3 or 4 stitches, you see the whole of the meniscus rim is stable. Again, if you can preserve this meniscus rim also, that is good enough for prevention of degeneration inside the knee joint. And you can see from posterior to anterior, we have a very good stable rim now. So try to preserve the stable rim. After balancing of the discoid also, try to see whatever meniscal tissue you can preserve, try to preserve it. So here you have just stabilized the unstable lateral rim of the discoid meniscus. So discoid meniscus, normally we have 2 group of patients, symptomatic and asymptomatic. Asymptomatic patient doesn't present in our clinic. Sometime in routine MRI, routine investigation, you see that there is a discoid meniscus. If you get more than 4 cuts of bow tie appearance in the forecut, it's suggestive of your discoid meniscus. Most of the patient comes in a clinic with a symptomatic discoid. In symptomatic discoid, always plan for balancing with preservation of your outer rim. Thank you so much.
Thank you. Any questions to Dr. Raman?
Normally,
So thank you.
Yeah.
Now we have Dr. Bikram Maskar. He'll be talking on the meniscus root repair. We have a little change in program. Dr. Bhaskar, after this, he'll be also talking about the primary ACL repair, indications and technique. He'll finish both these papers simultaneously.
Respected chairpersons and the Orissa Arthroscopy Society and Orissa Orthopedic Association, many thanks for having me here. And it's an immense honor here to present about certain lesions that were ignored in the past, but there's a renewed interest in them lately. So meniscus root tears. So Jack Houston very appropriately put it across that you may not have seen it, but it's looking at you. It's like a tiger in a jungle. So what is the root? So remember, the meniscus is a C-shaped structure. It's attached to the bone in front and at the back of the tibia, known as its root attachments. There's an anterior and posterior root. The medial meniscus on the posterior aspect is attached more posterior than you think, and the lateral meniscus posterior horn is more anterior than you think. So this is exactly where the medial meniscus posterior horn is attached and the lateral meniscus posterior horn is attached. So the meniscus is quite like a shock absorber. So you can look at it when the shock absorber, like a pillow, is between your butt and the chair, it's adequately cushioning your butt. But the moment the pillow moves away, that is, the meniscus comes off from its attachment on the bone at the back, bone touches against bone, and there can be problems. So what happens when the root tears? So look at this lady sitting on a cushion and another chair below her. This is exactly what happens. There is, enough contact area between her butt and the cushion. The moment the cushion moves, you can see that the contact area is very little. So there are more stresses. The lateral meniscus is quite different from the medial meniscus because the meniscus takes 70% of the load passing through the lateral compartment as compared to the medial side where it's 50-50. So how does the lateral meniscus differ from the medial meniscus? So it's a primary knee stabilizer for internal rotation at higher degrees of flexion. So it's a friend of the ACL. Hence, it should always be repaired along with an ACL tear because of its good vascularity and its propensity to be a good secondary stabilizer. So when the root tears, there's this wonderful article by Robinson, you can see it's been quoted earlier, the amount of stresses. So the areas in green that you can see show higher degrees of forces that are acting on it. So how do you recognize it? So simple slide for the PGs. This is how on a coronal image, extrusion is the first sign. On a sagittal image, T2 image, you'd find that you can't see the posterior horn triangle, also known as the ghost sign. And on an axial image, you can see this truncation. So where the meniscus should be attached, you see a whitish discoloration showing that it's moved away. So how much extrusion is considered bad? So greater than 3 millimeters is associated with greater degenerative changes. So how do you repair it? There are multiple techniques. There's the suture pull-out technique and the suture anchor technique. So the suture pull-out technique involves taking bites to the meniscus and tying it over a disc or an anchor. It could be single tunnel or 2 tunnels for more surface area. Suture anchor involves putting a posteromedial portal, a suture anchor, and tying the meniscus onto it. So this is a little animation of my technique, the way I do it. So you can see this is a classical, sorry, just one. Yeah, so you have a root tear here that you can see. The first thing to do is to nicely clear up the footprint with a curette through the anteromedial portal. Once you've done this, the next step is to introduce a normal ACL jig. You get fancy jigs these days through the anteromedial portal, and you drill from the anteromedial tibia with a guide wire and then a 4.5 mm drill bit. Use a flexible cannula, take bites through the meniscus, one a little bit more lateral, little bit more medial. I like using suture tapes in a simple configuration. I then deliver a ethibond loop through the tunnel. The ethibond loop as well as the suture tapes are delivered through the flexible cannula and are used to shuttle these suture tapes down onto the anteromedial tibia, which is then tied over a suture disc. And I always visualize this through a ultrasound to be sure my meniscus has the extrusion has been much better than what it is. So this is how the real life thing is. You have your root tear, adequately do a meniscus MCL pie crusting to get enough space, introduce your curette, nicely freshen up the footprint of the medial meniscus. You can use a shaver after that to freshen it up even further. Take time, go to the actual footprint. It should be very posterior. If you're anterior, you would not be restoring anatomy. So look at it, it's very posterior. And there's the champagne drop off behind it. So once this is done, you introduce, I like using normal ACL jigs. The elbow ones are great, but you get these fancy jigs these days, low profile. You could use them, put them onto the footprint. And then a guide wire is drilled from the anteromedial tibia. You can see it coming out there. Be a little careful not to penetrate the capsule. Once this is done, keeping it in place, you put in your flexible cannula inside. You get various companies that provide this. A lovely anti-grade suture passer is used to pass these suture tapes or normal non-absorbable fiber wires to shuttle these tapes. The first tape you can see is a little more medial because you want to reduce extrusion at the end of it. So it's little medial, and now you'll see my next bite is going to be a little more towards the center and through the meniscus tissue. That's very important because there are going to be tractional forces acting here. So how do I forward it? Now this is, can you just forward it? Stop. Fast forward. Yeah. This is not giving me a, ये नहीं आ रहा ना इसमें. So the steps are the same. So you basically deliver the loops through that and you tie it over a suture disc. So this is how I do a lateral meniscus repair. The same thing, you can see this is more often than not associated with a ACL tear. The attachment is a little more anterior. So here you can see this is a probe. So see where it sits anatomically. Once this is done, you use your ACL jig again, take bites through it using a suture tape, and these are delivered through the anteromedial tibial tunnel and tied over a suture disc anteromedially. So this is how you do it. You do your ACL reconstruction along with that. So there's a concept of centralization these days. It's done to reduce extrusion. So what do you effectively do? You put suture anchors just behind the MCL on the meniscus to reduce extrusion. Now, this is how I do it. So you've done your root repair, you've taken your bites, you've delivered them anteromedially. You use a liberator, lift off the meniscocapsular junction just behind the MCL. A guided portal is made through a 18 gauge LP needle to introduce an all suture anchor just posterior to the MCL, intra-articularly on the drop off. Once you've got this all suture anchor, these are delivered through flexible cannulas. Bites are taken to the meniscocapsular junction in the meniscus. Once these bites are taken, you deliver these suture tapes or the sutures coming out of the anchor through the flexible cannula. The same thing is repeated just beside the first pass. So you have these two suture tapes here. Now, before you tie your root repair anchors, you tie knots onto these so as to make the meniscus sit onto the tibial condyle, and then you tie your meniscus down. And you can see how beautifully it is reduced. Thank you. So I'll just move on to my next talk. Okay, this is on a new topic, which is ACL repair. It's coming in vogue these days. A lot of people doing it because we've begun to believe that the ACL heals. So not all ACLs are the same. You get a variety of configuration of tears, from avulsions to mid-substance tears, but reconstruction is not the only solution. So when there's a complete double bundle tear, classically we've got the double bundle and single bundle remnant preserving that you do. But this particular classification by Sherman changed everything. So what he did was he classified tears into being in the proximal third, avulsions right off the notch, proximal third of the ACL, mid-substance, or a little lower than them. He further said that these two types of tears, which are avulsion tears and ones in which 2/3 of the ACL is preserved, are good for repair. So how do I do it? So I repair and internally brace if it's these categories, if the patient comes to me in less than 2 months. If it's more than 2 months, then I biologically augment my reconstruction by repairing. It's not a new procedure. Robson first documented it in 1885. However, initial techniques were open and there was a high failure rate, and Fegan and Curl in the 70s almost said this is a stupid procedure and you shouldn't be doing it. However, after falling in disrepute, our arthroscopic techniques improved. We had better training opportunities and we got better at doing what we were. And then came the repair with suture anchors, the dynamic intra-ligamentary suspensory system, and the latest of them all, the Bear technique by Martha Murray and group in the US. How do I do them? This is a little animation I've made on how I do it. So classically drill a 4.5 mm tunnel through my femur. I deliver 2 ethibond loops of different colors, take bites through my ACL in a figure of 8 configuration, use one of these loops to deliver these 2 ends onto my lateral femoral cortex, standard ACL jig, 4.5 mm tunnel, deliver the other loop through the tunnel like an ACL, and pass my tightrope or adjustable suspensory device with an internal brace through it, which is tied over a suture disc. So let's see what I do arthroscopically. So I use standard 3 portals, a high anterolateral viewing portal, anteromedial and low anteromedial working portal. This is a classical kind of tear you have, wherein you've got a soft tissue ACL avulsion. As you can see here, first check for reducibility. Does it go back to where it is? Then identify your footprint, trephinate it adequately well. Once this is done, you've passed it in there, you drill with a 4.5 mm drill bit. Be careful while doing this not to disturb the fibers. The length is 35 mm. You can see me delivering 2 different colored loops through this particular tunnel. Now I start my repair. I want it to anatomically sit. So I rotate it into position, take my bites in the direction of the fibers with 2O fiber wire that's used to shuttle a suture tape through it. One a little lower and one little higher towards the apex of the ACL. Now these help me shuttle my suture tapes in a figure of 8 configuration. Once this is done, it's pulled onto the lateral cortex and you can see how nicely it's tightened. I go ahead and do my internal bracing, as you can see here, with my 4.5 mm drill bit, deliver my ethibond loop and pass my adjustable suspensory device carrying my suture tape through it. Now you can see the suture tape going through. Now it's an internal brace. It is only to act like a seat belt. It's not to augment your ACL in any way. Now the fibers are tied over the suture disc on top, and you can see how stable it is here. And I've been fortunate to do quite a few second look arthroscopies in these patients. So clinical examination immediately post fixation, you'd be quite satisfied in a AP direction. You can call me biased by taking this, but at 2 months, the MRI, you can see that the ACL looks quite anatomical in a T1 and T2 weighted image, sagittal sections. And look at the second look arthroscopy. I'm sure you'll all start doing ACL repair soon. So this is how it looked. I did this chap's second ACL on the other side after 4 months, and you can see how beautifully it has healed. Yes, you may say that this internal brace remains inside, but you can get rid of it. But you look at it at the end of it, once I take it off, you can't even make out that this patient has had a ACL repair rather than ACL reconstruction. Now you may have this kind of weird situation, and I've been fortunate enough to publish this also, where you have a bony avulsion of the femur. Now, bone-to-bone healing is great. That's why you like BTB. And Dr. Sandeep and Dr. Rajiv would agree with me. And you do exactly the same thing, just that I don't use an internal brace because I trust bone-to-bone healing. You can see how beautifully it sits here. Again, reduce it anatomically, take bites through the substance of the ACL with 2O fiber wire. I always prefer tapes because they're a little less corrosive on the substance of the ACL. And they are used to shuttle the suture tapes through the substance of the ACL. Again, my next 2 bites are almost near the bony portion of the avulsion, so that I get adequate length and the tension is maintained when I tie it over a suture disc on the lateral cortex of the femur. So very careful not to strangulate your ACL when you're doing this. So do this very carefully. Once this is done, you can see me pull it up onto the lateral cortex. It's nice in place, small incision tied over a button. And you can see how beautifully it heals. And I've been able to publish this. So what does current evidence say? Type 1, type 2 Sherman are the best to repair. Proximal ACL tear with a preserved ACL volume, it's best to repair as it's very vascular. It's best done in patients over 2 years of age, non-contact injuries, and type 1 tears. Static devices, there is a failure rate of about 6%, and dynamic devices about 11% as of now. So if I have an ACL tear, this is my algorithm. This may be useful. Repair plus internal bracing. Injury less than 3 months. Sherman's grade 1-2 with no locked bucket handle tear and a non-professional sportsman. When do I do a repair of the ACL plus a graft? Injury greater than 3 months, Sherman grade 1 and 2, and a sportsman. Stump preserving ACL reconstruction, Sherman grade 3, 4, wherever possible, because preserving the stump is of paramount importance for proprioception and otherwise. I add an LET wherever there's a grade 3 pivot in professional sportsmen and in all my revision ACLs. And tibial avulsions, small fragments, I use pull-out sutures, and larger fragments, a mini tightrope. Thank you.
Thank you. Any questions?
It is really appreciable that you showed us a very novel techniques, and repair is coming up now. I think probably we have to switch on. Diplis actually started all this. Diplis is all in USA is advocating about all the repairs. So now, would you like to even say something about like using the SEMITI as kind of a graft instead of the internal brace, something like that, and kind of a repair with maybe a kind of a swivel log, something like that into that?
Yeah,
Do you have
that's what I call a biological augmentation.
Biological.
Yeah. So there I use a SEMITI, and I completely agree with you.
Yeah.
Just to demystify this internal brace system, I think people think it's a substitute for a graft. It's not. It's only a seat belt.
Right.
It's only useful till the graft ligamentizes. After that, it has no use at all.
Absolutely.
And I agree with you. Biological is better, but ACL repairs as such are to preserve biology as much as possible so that the morbidity of a graft harvest is minimized. You could do exactly the same if you trust your repair without doing an internal brace. And that's how I initially started. And those results were as good as those with an internal brace.
You have any thought about the ALL and the LET? Because both are, little bit confusing to do in certain cases, like, talking about all the elite athletes.
Yes.
If your hand- your-
So
since your-
I have a firm belief that normally a patient never comes to you for AP instability for an ACL. He usually comes to you when he's rotationally unstable, especially in chronic tears, which a lot of us in India see. Rotational instability is a different ball game altogether, and most chronic tears are rotationally unstable. Just doing an ACL reconstruction alone is just the tip of the iceberg. That's why you have failure rate. So wherever the stakes are high, that means I say his amdani comes from playing a sport, you need something to support your ACL along with it and give you rotational stability. So any footballer, any basketball player, anyone that's worth his mettle in sport, adding an LET doesn't make you lose anything. Younger patients, younger than the age of 21, I add an LET invariably in all the cases that I
I've got, because I am really doing some work. Actually, some of my postgraduates are doing work also. I think LET is adding something to the lateral side. It's adding more of pressure, and there's a bit of pain complaining, a lot of pain complaining.
Yes.
So that's why, I started off, then I am reducing. Now it's kind of, it's a dilemma start.
Yeah,
it's
so I
majority
think-
of the patients,
I
it's a
think one
revision.
is to remember not to constrain it on the lateral side. It's only a support on the lateral side. So you never put it very tight. Like in ACL, we feel very nice when we see the ACL graft to be nice and solid. This is just to the contrary. It should just be there.
Neutral and valgus,
Neutral.
or neutral
No.
and valgus,
So I
or
do
only
it-
neutral?
yes, I do it in about 60 degrees of flexion.
Okay.
No internal rotation. The foot can be in external rotation. Don't do it in internal rotation. And without much force, I use a tenodesis anchor to put it in place.
Sir, my question is it always necessary to do centralization after root repair? Do you do it regularly, or in which situation you do centralization?
So this is a very, very controversial topic, centralization. It's because of a Japanese study that came out about 8 years ago. Now, it depends on why you're doing a root repair. Now, slowly I've moved away. I very rarely advise a patient for an isolated root repair. For me, as I told in one of my comments just now, root tears and radial tears, there's grossly some kind of a biomechanical problem that you're missing. So correcting biomechanics is the key. However, if you get a pristine knee, like how I showed you here, without any osteoarthritis, nothing, isolated would come to you very quickly. Usually such patients don't have much of an extrusion, but I do my ultrasounds, and I've published quite a bit on doing ultrasound during surgery on it in the Journal of Ultrasound. Now, when I do my ultrasound on my table and I find my extrusion to be quite a bit, 5-6 mm, I know with just pulling down my sutures, I'm not going to reduce that extrusion, because I'm of the firm belief all you're doing is putting that cushion under her butt so that she sits there and there's uniform distribution of force. So how can I make sure that there's uniform distribution of force? Maximum contact area is just behind the MCL in your joint. So that area is critical for me to have a cushion. Hence, adding this and adding the root repair together gives you double security. It's conceptual. It is not in any way proven to be done in all cases. So it's a space to watch out.
Yeah, Vikram. Extrusion is a dynamic phenomenon.
Yes.
When you wet bear, then you can assess the extrusion, and then you can take the decision whether to do it or not. But arbitrarily taking it as a 3 millimeter.
So I have an ultrasound in my clinic. So I do my own ultrasounds for my patients, and I do a standing weight bearing ultrasound and a patient lying down and doing an ultrasound to quantify the extrusion before he goes into the operation theater. What is the role of my ultrasound in the operation theater? That at 0.0 at the end of my operation, have I managed to reduce extrusion or not? So that gives you some kind of a security. There itself, you can measure the extrusion before you've done the operation and after you've done the operation, and you feel satisfied. Anything can happen later on. As I said, my belief in isolated root repairs is slowly going away. I'm not a firm believer. I would do a HTO along with it if I feel the patient is, in some way symptomatic in that way. Because giving them guarantees with these isolated root repairs, please tread it very carefully.
And do you anytime do a ramp, a lesion, create a ramp lesion to reduce your extrusion?
No. So I do a meniscotibial separation from below. That's like a grade 1 ramp or whatever, the type 1 kind of a thing. Never do I release the meniscocapsular junction on top. So I've seen a couple of people that have shown that, but don't do that. There's not much evidence about you're creating posteromedial instability along with it. Because as I said, ACLs are unstable not only because of the ACLs many times, it's because of these ramp lesions that have been missed. So rotational instability is something we need to be wary of and prevent from happening. So doing that can do that.
Okay.
Sorry?
You are doing a root repair along with H2O. In grade 1, grade 2 arthritis, old age 40, 45, we are doing H2O along with a root repair. At that time, do you need centralization?
Okay, number one, doing a root repair along with a HTO literature wise is rubbish as of now. You're anyway changing weight bearing to the opposite compartment or at least in the middle. So the root and you're basically making the meniscus redundant. So doing a root repair is cosmetic, and for you to feel nice that I did a secondary operation along with it and show off your arthroscopic skills. Otherwise, it's not indicated. Do a HTO, your patient will be happy at the end of it.
Either HTO or root repair with
Or root repair as of today.
Thank you, Dr. Bikram. Now, Dr. Paresh De, he will be talking on the ramp lesion of meniscus, how to manage.
Honorable Chairman, my seniors, my job is to speak on this ramp lesion. This ramp is there is the meniscocapsular ligament tear that everybody knows nowadays. The posterior horn of the medial meniscus. It is this ramp is defined as the tear of the posterior of the medial meniscus in the meniscocapsular junction. The term is coined by the Michael Strobel. Michael Strobel, I am very fortunate enough to work with him in his place, that is Straubing, Germany, in 2005. So ramp is the posterior horn of the medial meniscus tear, not in the respond to the lateral meniscus, and is classified by the Thanat. It may be missed by the MRI and also the arthroscopy sometime. That's why it's called the hidden lesion. During the ACL reconstruction, failure to identify and treat the ramp lesion leads to the residual instability, which ultimately increases the chance of the graft. The incidence is about 15 to 30%. Some mentioned, maybe sometime it mentioned is 10 to 20%. It is confusing. But in our scenario, I think in India, it is very, very less. As per me, I don't know the other people. It's more commonly seen in the male and aged less than 30 years. Risk factors as described by the Kim, which includes the bone contusion at the posteromedial tibia, chronic ACL injury and varus more than 3 degrees, and the slope. So mechanism of injury is the valgus force, internal rotation, and the axial loading force. Untreated ramp causes the accelerated degeneration of the cartilage. So clinical evaluation, there is no clinical sign or any symptoms for the ramp specific, but the radiologically now they are telling we are able to diagnose about 50-60% cases, and the sometimes they are going up to 90-95% also. The arthroscopy, if you have the suspicion, otherwise you can't. So arthroscopic posteromedial explorations is the gold standard. Now everybody, I think all arthroscopic surgeons admit these things, that at least during the ACL reconstruction, at least for the revision surgery or maybe chronic ACL injury, at least you should go into the posteromedial compartment and see the ramp. Now ramp region is classified by the Thanat by the 5 category. The type 1 is the capsulomaxillar junctions, the normal, and this is the capsulomaxillar. This is the partial superior lesion is the type 2, and the partial inferior lesion is the type 3, and through and through lesion is the type 4, and double lesion is the type 5. So zones also we have divided, that is 1, 2, 3, 4 capsule, red, white, and white zone. Now grip classification is almost the same. But in the type 3, it is B, that is a meniscocapical ligament attached to this. If there is another tear also or extent of the tear, maybe type 4B is also complete the through and through tear at the lateral border, and maybe along with this or maybe margin of the junction. So RAM 5 is the double tear. Now needle test is the most common after the when you are putting the telescope in the posteromedial compartment, then you put your needle for the posteromedial, telescope in the anterolateral portal and go slowly inside the Gilchrist maneuver, and then you put a needle and then try to prove it. Your needle should be used as a proof. Then only you can diagnose before putting the portal. So this is the 43 years patient, active male recreational player, injured the 2 weeks ago, the right knee, and then the ACL tear, ramp lesion, instability and inability to jog and the run, and full range of in movement, which goods the quadriceps control also. He has a good quadriceps control, Lachman 3, and drawer positive and grade 2 pivot. MRI is a complete ACL tear. So in case of the ACL tear, we routinely put the scoop in the posteromedial compartment. And this is the posteromedial compartment is entering by the Gilchrist maneuver. You can go into the triangle bounded by the PCL, medial femoral condyle and tibial spine. First, you give the little bit of valgus force in the flexion and then in extension, and the end little bit internal rotation. This is the most important thing, that maneuver in flexion, extension, and the end, the internal rotation. So this is the posteromedial at 90 degree of the flexion is the most important. 90 degree flexion, you put either the passport cannula or any ordinary cannula, that will help. So posteromedial portal is created at the level of the meniscus. 8 millimeter cannula is inserted and use the working portal. Ramp palpated by the proof and made it draw with the help of the saw blade, keeping suction off and rasp. First is passed to the 25 degrees lasso, that is called also the ramp lasso. They usually use the lasso is 45 degree, but here you are using the 25 degree lasso, that is otherwise called as the ramp lasso. So here is the proof. And then the saver should be, the suction should be off, otherwise it may injure. While injuring that is make the margins raw with the rasp again, first with the saver, then the rasp, and then take the bite with the 25 degree lasso with a good chunk of the capsule, and then the meniscus posterohorn. So first stitch tied and the second stitch. So this is a first stitch. Here I have used the single portal technique, that is the posteromedial inferior portal, not the superior. But most of the time, if there is a long lesion, then you need maybe the 2 portal technique. That is one for the viewing portal, that is the superior one, and the working portal is the inferior one at the level of the meniscus. So this is the second stitch. Now technique uses the single portal that we have already discussed. So drawback of the single portal may be viewing the long lesion in the posterior aspect will be difficult. So you need maybe double portal. Here it is the superior and the inferior. This is for viewing and this is for the surgery or the working portal. Now various surgical options that all inside repair with the implant devices like the lasso or maybe sometimes Scorpio, and single posteromedial portal or maybe double, maybe Solas technique. Solas technique is popularized by our Indian colleague, that Sheetal Gupta. Post-operative management, patient is kept in immobilization and not weight bearing for 4 weeks. Active and passive range allowed for 90 degree flexion and 6 weeks, strengthening at 10 weeks and jogging at 12 weeks. Full return to the sportsman 9 months is the same. So conclude this, both the intercondylar view as well as the posteromedial portal should be routine during the ACL reconstruction, particularly the delayed surgery or maybe revision surgery, while the MRI is the gold standard, good to identify, but the arthroscopy evaluation is the gold standard. Thank you.
Any questions? So if there is no questions, we have a little change in the program. Dr. Neha Godgate, she will be talking about the anatomical ACL reconstruction.
Yeah, Paris, before you leave, I think probably it's technically demanding. I mean, when you handle with a single portal and you pass the suture lasso and try to hold that, the suture lasso and try to bring it out. So how often do you think that the tissue that you're holding on the posterior side is adequate or not?
Now that's a visualization. If you are having the tight knee,
but looking
then
from
it's very difficult to visualize. That's why you need the 2 portal. That is a viewing the superior and inferior the operating one.
Looking from the posterior anterior portal and working from the posterior portal, that doesn't give you a kind of an impression of what is the tissue that you're holding. That's
Yeah.
my concern. I think I don't know how
That
you
is-
feel comfortable.
That is also a standard technique, that is single portal. Sometimes it needs the double portal because of this tight knee, or maybe if it is a long, maybe that tear pattern is extending to the posterior horn. Or maybe the little bit middle part, which is a long tear. Then only you need, otherwise for a small tear like this, maybe 2 bites is enough. For that, the so much not tight. And if sometimes it is more tight, then you have to have the 2 portals. Very difficult to do from the single portal.
Sir, one question. You have a long practice career in arthroscopy. Have you in your career seen this type of ramp lesion you have left? And do you find in follow-up any problem with that? Yeah,
See-
you always repair it.
Ramp lesion, that concept came this very recently.
Yeah.
So
So
though
before that-
I was the master that Professor Michael Strobel in 2005. He coined the term the ramp. I was working with him. I started my practice long back in 1996. But ramp lesion, nowadays we are observing that every case in ACL, even the fresh case also, we are putting the telescope. But once the ramp lesion, I have not marked any time before that concept that going to the posteromedial compartment every time to see the ramp lesion. Nowadays, once it is there, either I think 2 cases, I got a very small tear. I put the 360 degree all inside from anterior without putting the portal in the posterior also. That is also possible.
Can I add one point to this? I think many times actually we see a lot of laxity. The pivot shift is quite bit of more. So I think in those cases it is bit required just to go back and just see that are you not missing anything on the
Sure, definitely.
meniscus. I
Yes,
think
yes.
that's my observation.
But routinely also, if you are doing arthroscopy, you can put the telescope through that medial, the triangle. So and see that. Yeah, Ramana.
So, what about using this lasso? You use a 25-degree or 90-degree suture lasso?
No,
Lasso.
25.
25 degree.
Yeah.
And so sometimes it's very difficult to take bites from both the limb. So how do you manage that?
Yeah,
So-
that's why that's why I have recorded this one. And it was, I think that patient was not so bulky and the knee was not so tight. So I could manage to do this.
Indian ladies.
Maybe that is the.
Indian lady, I
So
think
normally
relax.
what I do, we take bite, then we pass it. So it's
Yeah,
very
maybe
difficult. Yes.
separate one. Maybe
Separate one.
take,
Yes,
yeah,
yes, yes.
capsule first, then you go to the meniscus. Yeah.
Sir, do you this all inside device or 70-degree scope for these ramp lesions?
70
Anytime.
degree scope, I don't think is required, but
Because
if you are
it
having
is-
any observation problem and viewing problem, then you put a separate portal in the superiorly
Superior.
and then
two
you
port-
put the telescope there.
Okay, or you are not using 70-degree scope?
Yeah, no.
to see the entire ramp.
No.
Number 2, all inside device just to repair the ramp without doing anything.
Yeah, if it's a small tear and you could manage to approach from the intermedial portal, you can have this 360 degree all or maybe whatever the all inside.
In those
can do it.
cases, are you able to hold this posterior capsule with the all inside?
Yes. If it is a capsular margin tear, definitely there is a tough capsule left behind. So you can take that bite.
Okay.
And it is a vertical mattress. Thank you.
Good afternoon, everyone. In the morning session, we had good to beautiful light surgeries of arthroscopic ACL reconstruction. And there is one more surgery of arthroscopic ACL reconstruction coming up. So between these two, I'll be taking you in a step-by-step manner for anatomic ACL reconstruction, just for a beginners level. So in last decade, we have seen there is exponential rise in number of arthroscopic ACL cases. So because of that, even we are seeing more and more of revision cases. And they have the studies have shown that the most common reason for ACL failure was the technical factor. So we need to have our technical techniques very clear before we embark on the arthroscopic ACL surgery. So once we clinico-radiologically diagnose the patient with ACL tear, so we take the patient to the OT. So this is, I cannot emphasize more about confirmation of the site, because this is the most important step before you start your surgery. And examination under anesthesia needs to be done in a stepwise manner so that you don't miss anything, any other ligament injuries simultaneously. And pivot shift test is generally is very good, is seen mainly in examination under anesthesia. So critical points in positioning is the patient after spinal anesthesia, the ipsilateral hip of the patient is at the edge of the table, foot is at the end of the table. The tourniquet is applied as high as possible. And then adhesive sticking is applied at the distal part of the tourniquet so that there is no spillage of any cleansing solution beneath the tourniquet. Then a lateral post is applied, and the foot post is applied such that the knee is flexed to 90 degrees. Water resistant drapes are meticulously applied, especially in arthroscopy cases. And then the arthroscopy unit is placed on the contralateral side. So after raising the tourniquet, we first portal is our weaving portal, which is anterolateral portal. It is palpated as a soft spot, which is a high anterolateral portal. Once we palpate it, we give a stab, we use a stab knife for making the portal. And then after making the stab incision, a cannula is inserted in the joint with knee in 90 degree of flexion. After that, knee is straightened, is extended, and simultaneously the cannula is advanced in the suprapatellar pouch. So with that, the cannula, the trocar is removed, and then the scope with light source is inserted in the cannula. So we have seen the diagnostic round, how the diagnostic round has to be done. It should be in a systematic way so that we don't miss any other injuries like meniscus injuries or posterolateral corner injuries like that. So important steps is first, after the diagnostic round, there is an empty femoral notch. So we know that the ACL is not there attached to the femoral condyle. So the next step is the adequate fat pad excision. It is important step because otherwise it will hinder later on when the knee is hyperflexed. Then once we diagnose arthroscopically ACL there is a ACL injury. So the next step is graft harvesting. Here I am showing you the hamstring harvest. Once we should free the tendon and release the accessory bands before we go on for graft retrieval. It is an important step. So here when we see that graft is free from its accessory bands, that means the graft is nicely, if we give a tuck, it comes out nicely, and there is a indentation on the backside of there is a tenting on the backside of the knee. So after you know that it is completely free, we put a tendon retriever, and then slowly with rotatory movement, the graft is retrieved. Then the important steps of suturing of the graft is done in such a fashion with a whip stitch. And once your graft is completely sutured, it looks like this tubular structure. So after your graft is ready, we go on with a femoral tunnel, making of femoral tunnel. So if you see, if the femoral tunnel is anterior, it will cause impingement of the graft in extension. If it is posterior, it will cause graft laxity in flexion. Or sometimes if the femoral tunnel is too posterior, it will cause tunnel blowout posteriorly. So what's ideal? So basically, ideal would be in the center of the native ACL. But in chronic cases, we don't see any native ACL. So we have to map this part. So we first palpate the posterior border of the femoral condyle. Then we palpate the intercondylar ridge, which is also called as residence ridge. And then once we map this area and we make a entry with our bead pin, and the bead pin is then advanced with knee in hyperflexion. So after this, the femoral tunnel, once the bead pin is advanced, then femoral tunnel is sequentially drilled with 4.5 and then 6, 7, and 8 drill bits. And the care should be taken not to scuff the medial femoral condyle cartilage while inserting the drill. Now, after this, the tunnel is made, a tibial tunnel is made. If again, if we err on a tibial tunnel side, there'll be, if it is anterior, there'll be impingement of the graft. If it is posterior, there'll be poor control of anterior translation. So what's the ideal tibial tunnel? We mark the posterior border of the anterior horn of lateral meniscus. Then we mark the medial tibial eminence, and the center of your native ACL would be the entry point. And generally, the angle is adjusted to 50 to 55 degrees so that the tunnel is around 4 centimeter from the joint line. So once both the tunnels are made, the next step is to pass the graft. So for passing the graft, we use a suspensory mechanism like adjustable loop on the femoral side. So the loop, adjustable loop with endo button is advanced, and this comes out to the through the lateral femoral cortex, and it sits nicely on the lateral femoral cortex. We toggle the endo button to see whether it has come over the lateral femoral cortex, and if the assistant gives counter traction, it doesn't toggle or the graft doesn't come out. So next step is cinching the graft in the femoral tunnel. So we pull out the adjustable loop so that the loop pulls out the graft in the femoral tunnel. And in cases of adjustable loop, it is very important because it takes the graft completely in the tunnel, unlike the closed loop tunnels. So this is the graft coming inside the femoral tunnel. We mark the tunnel length so that we know that graft is nicely sitting in the tunnel. Then let's see few cases. This is a 25-year-old BSF Shawan. He had instability of the left knee and he injured his ACL 3 months back. Arthroscopic ACL reconstruction was done with a hamstring graft. And this is his 10 months follow-up where he was able to do all his athletic activity. And recently he sent a photograph showing that he won a trophy in local kabaddi competition. This is second case, again a 20-year-old lad. He again injured his ACL 2 months back. His arthroscopic ACL reconstruction was done. And he's this is his 15 days follow-up, and this is his 2.5 months recent follow-up. He's able to do full knee bending, and he's able to sit nicely with cross-legged. This is third case, 24-year-old athlete with 2 years old ACL tear. He had so much instability that he had to stop playing. But ultimately he came to me and he got ready for surgery. So again, arthroscopic ACL reconstruction was done. And this is his 1-year follow-up. This patient is back to ground. He is doing all his athletic activity at the end of 1 year. So this is another case. 30-year-old male, 3 months old ACL, arthroscopic reconstruction was done. Preoperatively, there was positive anterior drawer. And at the end of 1 month follow-up, this is his recent follow-up, the anterior drawer, there is no anterior posterior laxity. He is able to bend the knee fully. So thank you.
Any question? No question. You can go.
Thank you, sir.
Next session.
Manning.
Next on, we are going to have a panel discussion on meniscus. For this session, I would like to invite Dr. Debashish Mishra sir to act as moderator. The panelists for this session would be Dr. PC Dey sir, Dr. Sandeep Birari sir, Dr. Rajiv Raman sir, Dr. Vikram Mashkar sir, Dr. Neha Gorgade ma'am, and Dr. Ranjit Panigrahi sir. I would like to request all the panelists to please be seated on the dais.
So we are getting all the stalwarts on the dais. Oh. Yeah, bilkul. I think it's a basically a meniscus session. So probably we have been listening the whole day on the meniscus. So now we've got a fair amount of knowledge. So I'll quickly go into the case. I'll not really go into the theoretical aspect. So this is all, I mean, about a bucket handle, as you can see here. Look at it carefully. The straight cut. So can I stop you and like to ask, I mean, if the first Vikram, we all agree that we should always, visualize the meniscus in chronic cases. I'm not be talking about the acute cases.
So I think we should try to preserve the meniscus in all cases wherever possible. Wherever possible comes with the caveat that it should be a tear conducive for repair biologically as well as vis-a-vis tissue quality at the end of the day.
So
time period for me is not an issue. Yeah.
Allow me to interrupt because I'm putting this session. So please, I mean, so for example, I mean, what do you mean by the quality of the tissue? So this is very, subjective. I may something say, I mean, he will differ. So what do you mean exactly? Because this is for the audience, I want to say.
So when suture passes through the tissue, ultimately, whether it is tying a knot or using an all-inside device,
so
what you're effectively doing is compressing. So when you're compressing, the tissue should not cut through like cheese grating effect.
It would not feel like a cord-like sort of things. You mean to say cord-like? I mean, when you try to touch it, it's not like a cord.
Pliable, yeah.
Yeah, it's not like a cord. So if it is something like, pliable tissue, you will feel something soft. You mean to say, I mean, that's what I'm trying to interpret. And when you touch it, you feel it is soft, then it is okay. When you feel it is a cord-like substance, you will differ.
No, if it's cord-like and it's reducible, let's say a vertical tear, like what you showed, then for me, the quality of the tissue for a cord-like structure is better. So the sutures will pass easily. I'm talking about friable tissue, like what Dr. Deepak Joshi has done the live surgery. The tissue quality
right.
was
I
better.
think probably I would still agree with you because it is still repairable. Your point is repairable. Yeah, I took that point. Yeah, Paris?
Yeah, but I think all cases nowadays for last 4 and 5 years.
But this was not there, Paris. I think when we all started our practice, probably it was all there.
Not there.
Chop
not
it off.
there.
It's
Not
like
there.
cutting
There
the
is a-
head.
When I was in the,
if you have got a head, no, if you have got a head,
initial
then you
phase
have
of
got a
my
problem.
practice, there is
So
a
cut the
zone
head.
specific cannula system was also there.
Yeah.
But it was not so effective and we are also that the device was not so available.
Correct.
Now last 4 and 5 years, I think we are trying to preserve all cases.
Agreed, I think. And I think Rajiv and Ranjit, you have any points to differ?
Yeah, you are telling about chronic cases only,
Yeah,
not
I'm
about
talking about
acute
chronic
cases.
cases, not the
Definitely acute cases, all are repairable.
All.
Or
I'll come to all your
90% of the
cases.
cases are repairable, so we'll
Yeah.
go for repair.
So
As far as
irrespective.
chronic cases are concerned,
Correct.
if the tissue is completely friable, like as Vikram has mentioned, not repairable. If it is cord-like and not reducible, it should not be repaired. Because
Cord means
if
it is
not
amount of.
coming with a reduction stitch, that
Yeah.
means it will not. hold.
May I allow to explain? I think probably cord, what I mean is the plasticity of the tissue is gone.
Yes.
So that means the tissue quality is bad. It's not really bad. It's not good. But still we take an attempt to repair. Is that what I mean, Rajiv?
Yes, and one more important thing is the age of the patient, because you should classify it according to the age, whether it's a degenerative or traumatic tear. The
Okay.
traumatic tear, yes, you have an option for repair, but degenerative tear, yes, we are more for balancing.
No, I'm talking about, I mean, young, less than say 45, 50, say still physiology is very active and he is going to work for another 10, 15 years, very hard work. Okay, agree? You want to say something different?
If it is repairable and if we feel that the biology is not so good, we can add a fibrin clot to the repair.
Yeah, correct. So you meant to say that we have to add something to that so as to help it in healing better. Got it. So I think probably the message should be clear that we should always make it an attempt to repair. And if I ask you what percentage of your practice that you encounter such kind of cases, Bikram? I mean, you are a sports, basically I'm talking about in relation to the sports people, because they are the people, those people, they end up in osteoarthritis. You're not the common ordinary people. Even they don't have the meniscus, they still very comfortably for 10, 15 years. They don't have any issues. You must have seen also. So they hardly come up any kind of issues. But it's only the sports clubbing people, I mean, those who have got sports enthusiasts, do a lot of work. They come back to you very early with some amount of the osteoarthritis. And it's very pitiable. Very pitiable. Particularly if you are handling a lateral meniscus, if you're not doing, then it's really, really bad.
So I just have one caveat here. So what percentage of my practice, acute cases, 99% I'd repair whatever the situation is as much as possible, unless, you know, the root is off and the meniscus is flying around like a flap tear kind of a thing. I'd remove that part, which is a flap part, but repair the rest back, whatever is conducive.
I agree.
Now, second thing is where you all should be wary, even in vertical tears, revision ACL cases. You have a bucket handle tear, footballer who's going to get into pivoting sports, be very careful on repairing these particular cases because biology is completely distorted there. Forces acting on the meniscus are different from an acute situation. Hence, one should be a little careful in repairing those tears. Otherwise, go ahead, repair whatever you can.
Yeah. So this is everything coming to the next point is whether do we really repair all those cases like, the red and red, we are all sure about that. We are really going to do that. What about the red and white? What is that? I mean, this is what the literature says. What is your impression to that? Rajit?
Yeah, so most of the red and red, it's yes for us. For red and white, again, it depends upon here lies the criteria for meniscus repair, depends upon the quality of tissues, age of the patient and duration of the tear. And once I put my scope inside, I decide, yes, I will go for repair or balancing.
But just to counter you, probably if you resect partly, I mean, the amount of resection again gives you a kind of quantification for the damage to be happening.
Definitely.
So that's also, we have to keep it in mind because if I remove that mat, patient will not really immediately develop, kind of osteoarthritis. So that you have to keep it in mind also. So what is your take? I mean, do you really go for a repair or you go for a partial meniscectomy in those kind of cases?
So if it's repairable, tissue quality is good, I always go for repair.
So current consensus probably will take it from here that I think everybody agrees that we should always repair.
Yeah, if it is purely white, you should resect part. So partial meniscectomy and then repair. But red, white, most of the cases you should preserve.
It's never a kind of a clean cut area. It's sometimes, if you see in the anterior part, it is in the white zone, but it goes when into the posterior, it almost to the touching to the root. So what do? You try to cut it or you want to preserve it like you did? I mean, we had a case, I think, today with Deepak was handling that case. I think I was bit, with my heavy heart, probably I was also thinking probably we could have. I mean, that is what I was kept on asking that we could have. See, that's not the point. His point is very valid. So the failure rates is very pretty high. So please.
I have one statement to make here. So most bucket handle tears, 99%, more often than not on the medial side, are associated with an ACL tear. Remember, the meniscus is a secondary stabilizer. If your ACL tear is done well, you have stability and you've repaired your meniscus with non-absorbable sutures, which have a mechanical stability of your repair. That's why a lot of meniscus tears appear non-healed on an MRI, but the patient is stable. He'll never complain of instability. So that ACL going well is testimony to the fact whether that patient comes back.
Yeah. I mean, the point to be taken here, then those who have been operated with the ACL, the meniscus do well. That's already been proven since long, probably about a decade back, people are telling. So we're also going with that same fact. But looking at the posterior part, when you try to exercise it, do you think sometimes feel that it should be preserved? By some means, maybe a couple of sutures, just try. Is it worth, Rajit? Or
definitely, I think just Neha was also telling. So why not to repair the red zone and balance the white zone tear? So that is the parts. That is partial balancing and partial repair. And
in the double bucket handle also, if you are the double bucket handle, the white zone you exercise, then the rest part you can repair.
Correct. So agreed. I think probably we have to take this point that we have to preserve as much as it is possible. Not all the time we should really chop it up. So this is again the same thing I was just highlighting about that. So the posterior horn, this is again a pocket handle. So now coming to our own scenario. Ranjit, I think probably it's an Indian scenario. We all face that day in, day out, we handle this kind of cases now. So how often do you feel that when putting the sutures, you hesitate to put that, keep it on the back? So we will use something else. So how do you manage those kind of conditions?
Yeah, most of the cases on the posterior part, all inside suture and the mid part inside out and outer side outside in. Anterior part. But when the patients, if you judge the patient's financial condition, most of the times we are tempted to do all inside sutures throughout the meniscus, because most of my cases also the bucket handle tear I have repaired inside out sutures. So to reduce the cost and we get a better stability. Some they claim we are having some amount of meniscal extrusion, but we don't find it.
That's my point here to make. I think it is not necessary or mandatory. I think all of my panelists had to come up to that agreement that whether it is okay that we can still manage with inside out with a suture needle, because that is cost effective. So can we manage the posterior medial? Because when we have already taken the semi-T as well as the gracilis, nothing is there on the medial side, excepting the semi-membranous is only things that is probably, that is only, and the other than this is the capsule. Just take care of the saphenous nerve and this part by putting some structures on that side and making a bit longer incision, we can manage that one. Any points to add?
Yeah, so I think we need to differ posterior horn of medial meniscus or lateral meniscus.
Medial.
So medial meniscus, as long as your cannulas are coming from the lateral side, right? And you're going in, there's no chance that you can go through the vessel at all, because the trajectory is coming out on the medial side. So you can repair the whole medial meniscus with inside out and outside in. You don't need, if you don't want. For convenience sake, we all use all inside devices. Lateral meniscus posterior horn is a dicey structure because there's not much capsule in the lateral portion at the back. So because there's not much capsule, you can't take a bite many times, even with an all inside device.
Is it possible that we can also do it on the lateral side?
You could. So on the lateral side, there are techniques which have been showing safety incision, but my personal suggestion to all of you all is don't venture on the lateral side with inside out sutures on the posterior horn. Body, anterior horn, do whatever you want, but beyond the popliteus tendon towards the center, try to use all inside or the alternative all inside. You can use the knee scorpion and do, take bites to the capsule, bites to the meniscus and tie them. That's a very, very cost effective and predictable technique of repairing the posterior horn of the lateral meniscus if affordability is an issue.
But I think a vertical suture by passing two needles is much more secure than taking with the scorpion. So would you agree?
Scorpion also vertical suture. So you take a bite through the capsule, holding the meniscus through all the way. It's the alternative all inside. I've published this in Arthroscopy.
Okay,
I'll share that on the group.
Yeah.
So you take a bite through the capsule, bite through the meniscus and tie a knot. The only problem is there's a knot towards the capsule, intra-articular.
One point I need to make in meniscal repair on the medial side, because we are going every time above the semimembranosus in that triangle. So most of the times are that spoon or retractor of wider diameter are not going through the triangle. So in the literature, it has been described, and personally I practice also. If you go sub-semimembranosus approach and put a retractor, then all your needles will hit because they come down. All your needles will hit that retractor, and you can safely retrieve your needles if you are going submembranous.
Excellent point to be taken. I think this is about Dr. Nair. I think this is what you are talking about. I think we should always add something to this just to enhance the healing. So we should keep it in mind every time we go in for some kind of things. I think PRP is common now. I think everywhere it is available now. I think you can do it in your own setup also. So it's not a big deal. Even the clot itself, making some amount of clot, drawing some, the iliac crest of the bone at bone marrow also, you can concentrate, you can infuse into that region. So this is, watch carefully about this. I mean, this is all about the definition. I think just stop it here. Sorry, I think this is a jumbled up of the. This is all about Dr. Paris there. I think, can you say something about your technique? I think how you do this?
Yeah, this making this multiple holes.
No, I'm talking about there's a tear. There's a tear on the posterior side. This is a ramp.
Yeah, there's a ramp.
So.
Yes, sir. So you use the saver without the suction. Suction should be off.
Okay.
And then you make it a raw
So-
area, both the side. Then you use the rasp.
Okay.
And sometimes there's multiple holes. And
Okay.
if there is the associated ACL injury, then it is fine. And you are going to reconstruct the ACL. Otherwise, you maybe have some holes in the lateral or medial, that non-attachment site, maybe that microfracture type, so that there will be some clot will come and heal will help better.
So look at this picture, please. So this is regarding a tear, a bucket handle, but this is again, there is some loss of the tissue on the posterior side. Tissue? What do you think? I think we are supposed to do? You want to, not clear?
Just
Okay.
repeat the video.
Is
Okay.
it a radial tear?
Sorry. No, not radial, ma'am. It's completely lost.
Yeah,
The
I
tissue
think,
is hardly, this is retracted almost.
Radial?
Radial.
This is a ramp, posteromedial meniscocapsular separation and loss of meniscus tissue towards the root. So if you look at this, if you place a liberator, you'll actually be able to pass it between the capsule and the tibia at the bottom. And of course, the white part you can see is the meniscus that's gone. In this situation, you can preserve it. Only thing, it's not an anatomical repair at the end of it. So you would have to do it as a root, but medialize the root tunnel if you want to. But it's beating a dead horse. This patient basically will have stability issues, and getting him a stable joint by repairing this capsule at the back to the tibia is the key. So putting a suture anchor onto the tibia and like a ramp, repairing this back to that is the key to success.
Any point on in situ fixation? Like where it is? I mean, no need to, bring it back to the area, because by creating that, you cannot really create a hoop stress, tension. So obviously the amount of tissue that is possible that can be brought, we cannot really bring it back to the area where it's supposed to be.
Sometimes when tear is away from the root, in those cases, you can go for in situ fixation also, because after releasing also, it's not possible to bring them to anatomical location. And overstretching is also not good, because what will ultimately your root repair is going to fail. So in such type of tear, I think in situ fixation or some in delayed cases, you see that whole of the tear is healed with the meniscocapsular ligament.
Okay.
In those cases, you can leave it like that if it is not coming inside.
Okay, it's still worthwhile to do that way. I think not to leave it as it is or try to chop it up again.
Yeah.
Is it agreeable to all?
Yeah.
So this is the long term. I mean, how do you, look at your long term study, because this is all there in the literature. So any comments to that?
About meniscus repair?
Meniscus repair.
Yes. So I think, see, failure rates are more high in athletic population, and as Vikram also told, whenever you do this repair in footballers or pivoting knee, those knees which are involved in sports, the failure rates are very high. So be cautious and very, I think, judicious in repairing those meniscus.
You're on a sports academy. I know that. Now the question is, you come across all these cases quite often as compared to us. So
definitely, yeah.
how do you handle those patients? Do sometimes suggest a meniscectomy is more preferable than a repair? Partial meniscectomy?
So for suppose a football player, if I see the tear is in between a white or red white zone, in those cases, I prefer go for balancing and ACL reconstruction rather than going for a repair in those patients.
Because they lose
So
some seasons
for
and they
me,
lose-
I think this is very good, because see, they can come back to sports in next 2 or 3 seasons.
So age and the sports, probably we have to look at those conditions probably where we have to agree that maybe sometimes, the partial meniscectomy and rebalancing is more ideal rather than the going for a straight ahead repair. Vikram, you want to agree on to this point or you want to differ?
I completely agree with you. Wherever return to sport and Amdani comes from sport quickly, you need to get them back on the ground, because they have 5-10 years of earning money. So you're better off getting them quicker, faster rehab and back on the field.
Correct.
Even, the compliance may not be that good. If we ask them that we need to repair it, they might want to go back to sports early. So they might not follow
If
what
you see
the
this, yeah,
instructions are.
very good. But
Yeah, if
Neha
you say-
pointed, you can see the failure rates are more in athletic population. Basketball player, your
They-
gymnastic player, failure rates are quite high.
The-
So better to go for balancing in those cases.
I mean, regarding the, I mean, it's a different question altogether. I mean, obviously the related to SCL, I mean, often, I mean, that's a choice of the, the ligament that you are going to, that's a donor side. Which one you prefer? I mean, the QT or like a bone patella or semi-T again? All agree that
I think
it should
hamstring,
be hamstring still is a preferred technique for both
Or
worlds?
revision or
No, primary.
primary semi-T.
Semi-T is still preferable. All of you? All of you agreed?
If the player is center forward, if the player is center forward,
You want to
then I
defer?
can go with the hamstring comfortably because he'll work with this quadriceps and patellar tendon, and so I can take the hamstring. But
No.
when it is come to the cutting activity, then I will avoid this hamstring and then I will go for quadriceps or PT.
Well, hamstrings is always a agonist. Okay, so we cannot really sacrifice an agonist. That's the whole concept of not doing the, the hamstrings. All those people are doing in a different technique. That's all because hamstrings are the agonists. So if you are damaging a agonist, the pivoting function, the quick turn and turn
Footballer, I think
difference, they
footballer
happen.
Mostly they prefer this everywhere in the world, that bone patella. And because of that, early healing and also early go to the field. That is also important factor.
Yeah, so they go back early. So I think we should keep it in mind that the options should always be open. If you are comfortable with some different kinds of, the choice of the graft, then probably we should opt for that. So this is a footballer, 23 years. He just came 3 years back, planned for surgery, but he just went away. I mean, how many from the audience still feel that they should be brought back and should be advised for surgery? All of you agree that should be brought back to surgery. I think they should not be left just like that. Because I'll show you something here. Okay, this is of course not the correct thing. Okay, he came back to me like this. Sorry for the poor quality, but this is a ramp. Anyhow. So again, coming to the question of different techniques, I think Paresh showed one of the technique that we should be familiar with. A 1990 last show, go for the posteromedial portal and try to approach maybe single portal or from the single or from the double. And that's as per your convenience, but we should be familiar with the technique. But there is another technique which now we are all doing. That's by, the all inside the sutures technique. So this is one of the technique that we can adopt. Okay, just quick. Now here the point. I mean, if I'm really using, I know Ranjit, you are doing this kind of technique. So hopefully you can tell me how many sutures you are going to put. Because this is pretty expensive. I know the kind of amount of the money that patient will be spending.
Definitely very expensive. If it is a small tear and I am in the posterior part is accessible of good quality tissue, then I will go for this all inside suture configuration.
Only one or two?
Two.
So that's again a cost, probably. Paresh,
Yeah,
I think you would
definitely.
not agree because you are doing it at a low cost. Yeah, Vikram.
So Peter Verdonk published on using these all inside devices for ramp tears. And he showed a very high failure rate because the stresses that act in the meniscocapsular junction, when you're, these typically work by pulling the suture, you're reducing the distance between the implants, and there's a cheese grating effect of these sutures on this capsule. So he has shown a series where he's actually published it and shown it that they cut out very easily. So revision cases for repair, meniscus repair are much higher in those
For me, I had a different issue.
Right.
I think the all sutures, if you get into the posterior capsule, if you don't have a good purchase, there is every chance of slipping.
Yeah. Most of the time it slips.
So if you slip one, because if you have not seen it carefully, I think
one
this is
angle.
all gone.
Yeah.
So I had to revise it. I had to revise it to go for in the reverse way. The first one, the posterior capsule, then I brought it back to here. So that is what I did. So now the question is, now how many sutures are going to really lose in that way? So it's really difficult. I think Paresh technique is what he showed is 1990 lasso. One should try to adopt. There is one more technique also which I am also doing. I'll show you. Sorry. Yeah, alternative techniques. Supposing if you have lost and then what you're going to do. This is the same one. Again, something, when it is dipping down, it's a chronic one. How do you handle? I mean, you cannot handle by this way. You have to lift up. by using a grasper and just try to lift it up from the posterior side, try to manage that suture. So this is just only one technique I wanted to say. And
the 90-90 suture also gives you that edge. So
Yeah,
you can
that's-
lift with that. So
Agreed,
that is very important.
agreed.
That
So
device
this-
should be
Yeah.
always there.
So
Yes,
this
yes,
is
yes,
the
correct,
device
correct.
that you have here. It's trying to lift it up and try to pass the sutures. Young footballer, I think, is aspired to become a professional with ACL tears 2 years back. He didn't do that, refused even a partial meniscectomy on table. So this is the literature, what he's telling. Just look at it. This is what I saw when I put my scope inside. This is the last one. He has not only on the medial side, also similarly on the lateral side also, this is the situation, but he's a young fellow, hardly 23 years, he's a footballer, he wants to become a professional also. On table, he refused. He said, no partial meniscectomy. Do whatever you want to do, just do it. He was all watching, no? They
Always,
are on spinal.
So for lateral meniscus, always try to preserve because arthritic changes develop
Yeah,
more if
you
you
can
go
see
for
there is a
lateral.
flap. There's a horizontal flap. The infra part is a bit mobile.
I think this flap,
yeah,
you
exercise.
should balance rather
Yeah.
than asking him on table, balance it and then show him, say this part I have balanced. This is better for patient.
This is already
If you show him,
No.
player will think
No, you
about,
can-
please save it, please save it.
Yeah. So now, this is what is the situation after repair.
So
Sorry.
at least you preserve the rim also, that is good enough. Huh?
No, in spite of preserving also, you can see there is some under the gap is still preserving. This is the technique I try to use. This is kind of a ripstop technique. Ripstop technique is kind putting two sutures vertically, then bridging them together by a crisscross. So that you can bring those two meniscus fragments into together and try to maintain the tension. Don't try to attempt to close it. You attempt to close it, you are going to damage. Maybe your healing will not be adequate. So do not do that. Probably that's what I wanted to say. And that probably finishes, but I don't know what's going to happen. I'm yet to see. It's only 2 months now. So reoperation rates, as I said, is very high. But if you compare with the meniscectomy, it is very less. So probably he was right. He will be right if he comes back. That he will be wrong probably if he comes back. But I'll be right if he doesn't. So thank you all. Thank you all the panelists for your patient, tolerance to me. And this is what we will be hosting. I think this is the 4th annual conference of the Odisha Arthroscopic Society from 24 to 26. This time we are targeting for the basic shoulder course because this is never happened in Odisha. So we'll be having a lot of eminent national as well as our state the faculties will be showing you and so teaching you how to do the basic of the shoulder, and we'll slowly move on with that. Thank you all. Thanks for all.
Thank you.
Thank you.
Sandeep. Hello, Sandeep. Sandeep.
Yes, Rajiv.
Yeah.
Well,
Can you increase the mic volume from hall?
sorry. Hello.
Who is moderating the session?
अरे माइक
yeah.
चालू हो गया है वो बंद हो गया राजीव
Yeah, Sandeep, you are audible.
yeah am I visible am I audible Rajiv am I audible अरे तुम दोस्त इधर आओ देखो excuse me ये नहीं चाहिए वो whatever you are showing तुम्हारा कैमरा है नो तुम्हारा कैमरा है वो नहीं चाहिए इधर चाहिए ओके all camera here not this zoom in okay this is important Am I audible? हमारा हमारा लक्ष्य रहा। अब हमारा आवाज आ रहा है?
Now we shall be moving to the third live surgery. For moderation, I request Dr. PC De, Dr. Asutosh Mahapatra, and Dr. Satya Naik sir to moderate the live surgery session.
रेडी करते हैं तो उस टाइम पे वो Sister, hold this. Hold this.
Hello,
Yes.
anybody from the OT?
Good evening, sir.
Hello.
Dr. Day.
Hello. Hello.
Hello. Yes.
We are not able to listen. Biraris, I am Dr. PC Day.
बोलो भाई क्या है आवाज नहीं जा रहा है?
Your voice is not clear here.
बोलो भाई. What is happening?
Hello, hello. OT.
Dr. Day.
Yes, yes.
Am I audible?
Yeah, little better, but I think you have to increase little more sound, little more sound.
Yeah. Now is it okay?
Yeah, fine. Very good.
Yes, sir. So this is 32-year gentleman. We have already done diagnostic arthroscopy. So he has got a stable lateral meniscus tear. So we have left it as it is. It is very stable. Only superior so articular it was communicating with medial. There was a flap which we have already resected, and we have stabilized the peripheral rim. We have made the peripheral rim stable.
We are not able to see the inside picture, only outside picture. Please focus the yeah. Now it is better.
So there is a
So do a PIP.
yes.
Outside picture also small one. So this is lateral meniscus, right?
No, this is medial meniscus now.
Medial meniscus. Okay.
There was a flap tear which we have resected, and
Okay.
there is a posterior horn tear. Actually, it is like a radial type of tear,
Yes.
but it is going up to the capsular. So I'm going to take a horizontal mattress here. Try and
Side stitch.
all
Yeah.
inside.
Vertical mattress. Right.
Yes.
So it is almost a extending up to the capsule.
Yes.
Yeah.
I'll stabilize this. That's what is the plan. Then after that, I'll be going. So we are planning to do here BTB.
Okay. Okay.
So I have taken this all inside device
All inside device, right?
from the biotech. Please hand me out. Where? Yeah. So trick here is to withdraw gradually because sometimes we get sudden give way and it gets pulled out. Fire. Done. Give me probe, please. One, pull the thread. Pull the thread, please. Gradually, gently. Yeah. Gently. Wait. Yeah. Okay, wait. 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 Yeah. Gently.
Say 20, 30.
Yeah. Then, again. Very good. Very good. Perfect. Fine. I'm going to put one more.
One more.
Yeah. Okay.
Okay.
Hold it. Hold it. Yeah. Please.
So this is almost at the capsular junction, I think.
Yes, sir.
Yeah. So you like to have another stitch?
Yes, one more anterior to this.
Okay.
I think two will be enough. Note करो. So, prematurely, we are going to recheck it with the pump only. Yeah. Okay. Second, Akira. You one more. Please. No, yeah. What? I'm going to reduce the same because it looks little elevated. Yeah. What? Probe in the Yes. Okay. You probe.
Right knee, na? Right. Left, right. Left knee.
Table. So I'm just going to put one more here to reduce.
It looks stable now. Huh? Sandeep?
Yeah, sir. It is stable.
Yeah, looks stable now. So like to have another
Yes, in the inferior portion,
same all inside?
all inside only. Okay. Of solid. I think we are going to go ahead now with the BTB harvest.
BTB, okay. So meniscus part is now stable.
Yes, sir, it is very much stable.
Yeah.
Outside picture. 1 second. Correct. Please focus here. Focus here. So, plan is here to BTB. So Biotech, they have got a good system where, you know, you can do only one top incision and one incision in the inferior and do pulmonary. But
Okay,
for the
so you plan to have the two separate incision, two tiny incision.
no, I'm planning to do with the conventional open technique.
Okay.
Yes. So I'm palpating the patella. I'll be taking incision over the center of the patella, that's tibial tuberosity. So it is going slightly on the medial aspect of the tibial tuberosity.
Okay.
And so it is like a not straight but little oblique type of incision.
Oblique type, okay.
Yes. Right angle, please. Observe. Mark. Right angle again. So I'm resecting the paratenon.
Yes. Knee in extension or flexion?
It is in extension, sir.
Okay.
I have left it in extension because I'll be taking cut. Now I have flexed the knee.
Yeah. Okay.
From lateral, please. So you come here. Sir, please come here. Okay. So that's paratenon. I'll be using to close this flap later on. Right angle ऊपर लगाओ. समझो where I am working. Now, next step is hold it. Hold on. So what I do here, I always use the reduction clamp to hold the or stabilize the patella. I put it on the superior pole. Hold this. Give me marker. One needle, please. So I always put the needle in the center. Marker. Or the pottery is okay.
You are taking the central third of tendon?
Sorry?
You are taking the central third of tendon?
Yes, central. So see, this is the patella.
Yeah.
Now I have kept it in the center. Give me the scale for osteotomy 10 mm. 10 mm. So that osteotome only I am putting there. That's going to be my cut. That's the inferior pole where exactly is the needle. So I will be taking around 20 to 25 from the inferior pole of the patella. Yeah, that's 25. So I don't touch full. So superior portion is almost. So this is going to be my over portion around 25 in the femur.
So patella, they will go to the femoral side. Okay.
Yes, yes, sir. So I have already marked my superior.
That Sarpo fibers, you have already given the mark with the knife, 15 number knife.
Yes. For tendon, I have not yet marked. First, I'll be completing first tibial cut. Sorry, patellar cut. So I always first start with the top.
Okay. Okay.
So I'm doing it little obliquely. And this saw, it has got a marking. So I know how much deep I'm going. So I don't want to go more than 8 mm deep.
Okay. But regularly we used to go to take out the graft from the tibial side first, then to last at the patella. But you are taking from the patella.
I do always, sir, from the patella side first.
Yeah.
So yeah, I have gone 8 mm. So now I'll be taking, sir, is stabilizing here. Now, the needle I'm going to remove.
Eight mm, yes. You're taking 8 mm, then thickness also 8 mm. and giving the oblique cuts. Oblique.
Yeah, I'm going very oblique.
Yeah. What I mark that. Yes.
I'm going to change. I'm going to come from the opposite side.
Yes. Easy to pass the tunnel.
So now 10 mm. So once I have completed the I'm not using mallet. I'm tapping with my fist only. Okay, so Cocker. This is completed. Can you see?
Yes. Yes. Very nice. Very nice.
Move this. Release. Leave this potato clamp now. Cocker. You cocker. Scissor. Just leave this picture. Double knife here. So there is a bend the knee. Bend the knee. So Biotech has got this parallel knife. It is being used. Can you see? Am I audible?
Yes, yes, yes.
Yes. So that double knife also, parallel knife also can be used to get the tendon
Yes, yes.
cut like this. So not going to use that. I'm going to rather use the spinning.
That also you have given the mark. Marking also given. Yes, yes.
Like this. But I feel it is more less than 9. So I'm using the steel here.
Using some instrument, I don't know what is that.
Steel sir.
No, he's just cutting it, the scissor.
That's a steel scissor.
Okay.
For the benefit of delegates, I have shown that.
Are you taking that bone tongue from the tibia?
That I am planning to do, sir. Let's see. The one Dr. Arumugam always shows in his presentation. So that's graft and that's bone patella. Now
Yeah, the length of the graft, the sub part is very long, then I think the tongue will help sometime.
yeah. Let it don't hold it. This is a knife. Coming now down. So, I always do this cut first.
Distal cut first.
So hold this. here, I'm going to start from detail. So key here is to always watch or look at your saw,
This is also oblique cut.
marking on the saw, yes. So we know for sure we are not going deep. I'm going to move.
This is also 8 mm. Tibial piece is also 8 mm.
Tom. Take this blade, please. Yeah. Okay, please. So that's the graft, and I think we have got little time. Is it-
Yeah. Yes, yes, yes.
Number one. Will you close this? Number four, so that- Come here, prepare. Light, either please. वो मत दिखा. So meanwhile, Dr. Tapan will close the defect and I will start preparing the graft. Come, jaldi.
Okay, okay.
Scissors, please.
So closing will be the layer by layer, even peritoneum also we are closing.
So we'll be closing the tendon and then peritoneum.
Correct. Okay.
Hold it.
Close the tendon, sir, or only peritoneum?
That layer you close and then peritoneum. Light though. This is please come here. Yeah, we'll hold this one both the side. Process please. Ulta. Nibbler. Process. You have third sleeve. Little sleeve. Hold. Hold. So, ulta, घुमा. Slide though someone please. Nibbler. So the one which I have taken from the patella is going into 10, but the tibial one is, I think it is 11. So I'm just reshape it so that we get proper diameter for the 10 diameter for the tibia as well.
So are you going to keep that bone pieces that you are trimming, putting in the defect on the patella side?
I might do that, yes.
Yeah. So 10 in the femoral side.
Yeah, the femoral side is 10, tibia is 11.
Okay.
I will need to trim it. Yeah. I think it should be okay. On both the side I'll do. Yeah. 6, 7, 8, 9, 10. Perfect. 10 is going perfect.
So both side 10 now.
10, yes. 10, you have 10 remarks.
As it is not pre-drilled, I think you are going to drill it now.
I'm going to drill now. Drill is ready. So I always drill with the K wire. I don't drill with the, take the poker. Hold. Yes. No, don't do that. Leave. Leave. Hold it back. Don't clamp.
So just hold, not to clamp.
Yes.
Not to cross.
Yes.
Yeah. Otherwise it may cross.
Yeah, it is done. One hole is done. I'll be doing second, but I'll be doing little oblique. Second also done.
2 mm K wire?
1.8 mm K wire. Where is
Okay.
the one? Array, I had kept needle holder here. I had already kept everything ready. Who removed it? Huh? Before surgery, I had kept everything. So it goes very well. Second, hold it. Remove the needle.
So this is Ethibond or
It is a fiber wire. They wanted me to use the fiber wire.
fiber wire? Okay.
They are very generous. Okay. Same thing now I'm going to do for the tibia. So though tibia, it is not that much, but I still want to do it. There was one more fiber wire.
So drilling obliquely also.
Yeah, I drilled obliquely.
Hmm.
So there is no, I mean, like, I don't want to drill in the same hole and I don't take drill bit.
So
Because I want to do it with the K wire. Yes.
Yeah. So to avoid the breakage.
Yes. Now because if you want needle is little thicker, so I took 1.8. If I would have known that I am going to use this, I would have taken 1.6 K wire. This needle is little thin. So our preparation is done. Okay. Is it visible?
Yeah, yeah, clear.
Hold it. Now
Very nice.
we are going to 6, 7, 8, 9, 10. We're going to check. Yeah, it's going very well. So I may need to drill the tibia later, but I don't think that is going to be required because I feel that tibia is little bigger there.
Yeah, little hammering may be required in the tibial side. Little tight, I think.
So no, tibial side that will be anyway will be protruding out. So whole length of the graft is around
Yeah,
100
right.
and 100.
Okay.
So we know it's around 1 or 2 wire will be out. So I think this much TPI is
So
only.
maybe 10 millimeter or 15 millimeter
Yes.
graft be outside the tunnel. Yeah.
Yeah, and Pia is femur patella, what I have taken is exactly 25. So I'm going to drill 30 in the femur. I'm going to push this 25 there.
Okay, nice.
So with the genta. Okay, done. Next, or 1 or 2 is okay. Give. Oh, sorry, middle. Middle. So closure will be doing later. I just now want to proceed ahead with the surgery.
Focus a bit.
Hold.
Cameraman, please focus a bit. Zoom in.
Cut. For the sake of sister here, please. So for the sake of time, we are going to. Take 1 or 2 steps.
So you're taking 1 or 2 stitches for
Yes.
the anatomical orientation.
I
Yeah.
just closed it fully, but
Ah.
now later on we'll do the closure. The percutaneous instrument from the biotic is also very good. So it takes little more time in my hand. Don't worry. We are going to remove sisters. Understood? Ready. Please. आ जाओ दो Prakash, how are we doing with the time? Okay. Day, sir?
Yes.
Yeah, what about the timing?
Timing. No issue. You carry on.
Where is the trocar?
You have plenty of time. No problem. We are here. Be comfortable.
Yeah, I'm comfortable, but they have just misplaced the trocar. Yeah. Left. Between, please. Close the. No offset. So give me pin directly. With 10 mm curve. There is humor on hand. 7. So it's still at 90 degrees. Give the foot switch. Don't worry. What about this? Extra super cut. Please do. Yeah. Don't puncture. I don't want that. Please don't do that. So what I do here, 10 mm trimmer. 10 mm. Now we need to, so I always use the reamer for my fish. But here, now I see I have gone posteriorly. So I go posteriorly, try and come little anteriorly. I don't want to take offset reamer. I'm not that comfortable with. And now I will ask them to flex. Yeah, don't worry. The tail is too big. So maybe hold this. Hold this. You can 10, please. Hold over here. Okay.
So Biraris,
Yeah.
hello.
Yes.
So as per the decision of the here the organizers, they want to keep your views or here in the site, and at the
Okay.
same time talk will go on.
Perfect.
At the end, when you will ask us to stop, we will just wait and then you show us
Perfect.
5 minutes
Then-
at the end. Okay.
Bye.
Yeah. Chalo. Thank you.
Okay. Go. Yeah. Yeah.
Now we'll be moving on to our session. For this session, I
Yes,
would
sir.
like to invite Dr. Atanu Mahanti sir and Dr. Binod Rao sir to act as chairperson.
Yeah. Perfect. Go. No, go. Yes, no problem. So we have got plenty. We have, hey, shut up. Charlie. Yes, go. Yeah. Yeah. Go. That's it. Hold it. Don't worry. Nobody do anything. Yeah, that's fine. Go. Go, please. Yeah. Yeah, yeah. Go.
So let me call Dr. Parthasarathi Das to give his talk on arthroscopic ACL bony avulsion fixation. Good afternoon, everybody. Thanks IAS One and Odisha Arthroscopy Association to give me an opportunity to talk over arthroscopic ACL avulsion fixation. So quickly going into classification, it is Mayer's and Macbeath's classification. Type 1 is non-displaced. Type 2 is superior displacement of anterior aspect with intact posterior hinge. Type 3 is completely displaced. It's 3A, ACL insertion only, and 3B, entire intercondylar eminence. And type 4, it is completely displaced, comminuted, and rotated. It is given by Jarisinji. It's modification of Mayer-Macbeath. So now comes to whether we do a operative fixation or we can do conservative. Type 1 and type 2, we can do conservative in extension cast. Type 3, type 4, sometimes type 2, type need surgery, and the need for surgery is high risk of meniscal entrapment if we are not doing surgery, risk of malunion, non-union, loss of extension, and instability. So when it comes to surgery, it's either arthroscopic or open, and arthroscopy has less morbidity, faster rehabilitation, and decreased pain. And when it comes to arthroscopy, it is again whether you do a screw fixation or a suture fixation. And suture fixation has advantage because in screw fixation you can do, because in combination you can do a screw fixation, and chance of iatrogenic ligament injury and posterior neurovascular injury are there, and potential need for hardware removal is there. So next comes how we do. So normally I do 3 portals, that is anterolateral portal, that is for viewing portal, and anteromedial portal, that is for working portal, and I always do a transpatellar portal for passing of sutures. So next we'll do surgery. This is a case of ACL bony avulsion. You can see I have debrided. First thing is you do a diagnostic arthroscopy and debride the base. And I have debrided the base. Now I am passing a suture passing device lasso. That is through the back of the ACL, to the posterior corner of ACL. Here you see there is some bony fragments are there. Initially, I tried with fast pass or that scorpion type of things, and that needle broke out. So when there is combination and bony fragment, never try with fast pass or scorpion, your needle will break out, it will be lost to you. So lasso is a better device, and you take a lasso suture passing device. Here I have used fiber tape, and I have put a sliding knot over it. I take 2 knots, 2 fiber wires, fiber tapes, and I put 2 knots over the bone and ligament junction. And these knots, one is remain medially and one remain lateral. So once we pass the knots, forward. Now you see the crater. In crater, you make 2 holes with a 2.5 mm or 2.7 of bead pin, one anterolaterally and one anteromedially. And once we make a crater, we pass the bead pin with suture and we pull these fiber tapes through this. And here is the problem, the intermeniscal ligament. It most of the times it comes in its way. So either you have to cut it, or sometimes you use your probe to retract it. Once you retract it, the fracture fragment will sit over it. Then you fix it over the tibia, over a endoverton or something. And while drilling in tibia over the anteromedial aspect, you should keep a gap of minimum 1 centimeter between 2 tunnels.
Don't worry.
This is the final. So what we do after surgery, see, it is a fracture, not a ligament reconstruction. So if it is a fracture, so post-operative rehabilitation is bit slower. Post-operative knee immobilization in a range of motion, knee press locked in 0 degree of extension. Passive range of motion exercise starts maximum 45 degree in first 2 weeks, then gradual to 130 degree over 6 weeks. Non-weight bearing for 2 weeks, followed by partial weight bearing till 8 weeks, then full weight bearing. This is the case which you have seen. This is the X-ray of that patient. He has a fracture of tibia condyle also. So I fixed the tibia condyle first. And this is the MRI, and MRI you can see that is ACL avulsion. And first I fixed the tibia condyle, then I did a ACL avulsion fixation. So this is my next case, and it is a similar type. And I have put 2 knots with one fiber tape and another is fiber wire. And this is the crater. And I fixed it. Here you see that is the cannulated 2.5 mm drill bit. This is a SC joint drill bit I have used, and it is nitinol wire that comes through it, and we can use it as a suture passing device. So I am forwarding it. And this is the post-op. This is the X-ray. This is the avulsion fragment pre-op X-ray, and this is the MRI. You can see, and this is the post-op. Sometimes I do double fixation when I am not confident that when it is button is fixed tightly, so I used the extra post to fix it. This is an interesting case. Here you see I am seeing some posteromedial portal. Here it is a PCL avulsion, and why I am showing in this case there is a PCL avulsion, and there is also a ACL avulsion, and there is also a meniscus root avulsion, medial meniscus root avulsion. These 3. This is ACL avulsion we are seeing, and there was PCL avulsion also, and this is the meniscus root, medial meniscus root avulsion. All 3 in same patient. So I have to fix it all. The PCL was a big chunk, so I used there a dog bone button. Forward one. This you see, this is the PCL. Now this is PCL is fixed. It is PCL is quite quietly fixed that bony part with the in the crater. This is the dog bone. And because the bone chunk is big, I use this button, or you have to do a suture pull out technique like that in ACL. What I have done here, understood? I have made the hold it. This is ACL, huh? And SPCL and ACL are tight. And now you'll see the meniscus root. This is the meniscus root. And this is quite tightly fixed. Now this is the X-ray of that same patient. See, PCL, VCL, and this is the MRI. In MRI, you can see this is PCL and there is ACL. So that is the check X-ray after 3 months. So take home message, identify the avulsion pattern, treat it as a fracture and fix it strongly, protect the fixation and rehabilitate slowly. Thank you. Thank you.
Any questions? Regarding the fracture fixation of ACL avulsion, is there any waiting period after injury, or you can directly proceed to fix for the beginners?
I treat it as a fracture. Do we wait for fracture? Do we wait for any fracture, or we do it as early as possible? Any fracture, a tibia fracture, you can do it within 2 to 3 days. Like that in ACL avulsion, I treat as a fracture. So I treat it as early as possible.
So any chance of stiffness or arthrofibrosis if you treat
You
it?
have to immobilize first 2 to 3 weeks because you have to fix it in extension to protect that fracture. So till now, I did not find any chance of arthrophyrosis in my cases.
So there is no waiting period. We can directly fix the ACL avulsion.
I wait 3 to 4 days, give maximum 5 days till the swelling of the knee goes down, then I do it.
Thank you.
I have one question. What is the time period after which period you tell I will not fix? I will reconstruct.
Sir, I have tried maximum up to 3 months.
After 3 months, you will not fix. You will
ACL
reconstruct
avulsion.
ACL avulsion.
I have not got also, sir, that type of cases.
Oh. Okay, thank you very much.
So one question,
Sir.
Dr. Partho.
Sir, I have not found in my case any compartment syndrome. Proximal tibia in that first case, sir.
He is asking.
Yeah, in that case. Yes, sir. Yes, sir.
He's asking what is the percentage of compartment syndrome if you do a fracture fixation as well as a ACL in the same sitting, because your fluid will leak and go inside the compartment.
After fixation of proximal tibia, I did not that in one sitting. I did it after 15 days.
What about the second case, the last case that you showed with all the?
Yeah. All that ACL, PCL and root avulsion.
Yeah.
Sir, six bottle of saline I have used.
Compartment.
No, I did not.
Nothing was there. Okay, good. Very nice, excellent.
One question, Dr. Partho. Yeah, sometimes what happens when you tie the ACL and pull through, the fragment lifts up. How do you manage?
Exactly. When we, sir is asking, when we tie the ACL, then when we pull, sometimes one part lifts up. That means the pressure in two suture pull out or one? One is always, that is the problem because of I always do 2 sutures. Force is equal in both sides, anteromedial, anterolateral. If we do it a 1 suture, most of the time one side lift up and one side down.
So anytime do you cross the sutures?
This is the cross. One comes, you can cross it or I put a sliding knot and then put different direction.
Thank you.
Thank you, Dr. Partha. Now I will request Dr. Ranjit Panigrahi to give his talk on ACL reconstruction with remnant preservation.
So, respected chairperson and delegates, so I'll be talking on all inside ACL reconstruction with remnant preservation. As all of us know, despite advances in surgical techniques and rehab protocols, the re-tear rates exceeding 5% are commonly reported following ACL reconstruction, and the percentage is even higher in younger athletes below 18 years. Partial tears of anterococcygeal ligament are common and represent 10 to 27% of the total ACLR. So what is remnant preservation? If you can see, it is the retention of some or all of the torn ACL stump in a single or double bundle ACL reconstruction, or retention of an intact AM or PL bundle in a partial ACL tear. So this is a partial ACL tear with the PL bundle tear and the AM bundle tear isolated. And when it comes to remnant, the Kane has classified the remnant into 4 types, depending on the scarring pattern. If it is scarred to PCL, it is type 1, to roof type 2, to wall type 3, and small amount of remnant is type 4. So why we will preserve the remnant? As the native ACL is both vascularized and contains stem or progenitor cells, so preserving the remnant facilitate graft remodeling through the contribution of these elements. ACL remnants have mechanoreceptors and which enhance the proprioception. And thirdly, it provides mechanical support when it comes to isolated bundle reconstruction. And the most important thing is reduction in the tunnel enlargement because of prevention of synovial fluid leakage and release of paracrine factors. So these are the potential benefits of the remnant preservation. And when it comes to all inside ACL reconstruction, the added advantage of ACL all inside technique we will have So what are the methods of remnant preservation? It may be selective bundle reconstruction in partial tears like AM or PL bundle, or in complete tear ACLR with remnant preservation. The remnant is reattached or retensioned. So benefits of all inside ACLR is further when you are using outside in femoral jigs, you are less likely to violate the ACL remnant. So this is a case history of a 28-year male with a history of twist injury 5 months back, presented with complaint of pain and instability of the knee. On examination was found to have Lachman positive, and there was no mediolateral instability with pivot shift grade 2 positive. And the MRI picture, it showed the ACL tear with probably some remnant intact. And when we went for arthroscopy, you can see it's a type 1 type of remnant where the ACL is attached to the PCL. So here we went for all inside ACL reconstruction with remnant preservation. So we took only semi-T graft and created a graft link for all inside ACL reconstruction. Then the femoral footprint is marked at the center of natural femoral stump, or you can go for your landmarks, and then all inside femoral jig is kept over the femoral footprint, and with the help of a flip cutter 3, a retrosocket is created. So flip cutter 3 is passed through the footprint from outside in, and then you rotate the wheel for the appropriate diameter of the flip cutter 3 to set it at the required diameter, and then you start creating your retrosocket. And once you start create your retrosocket, ideally it is 15 to 20 millimeter. Then you clear the debris and then take out the retro reamer and pass the bead pin with suture. And the suture is retrieved through the intramural portal with the help of suture retriever. And once it is packed, then we go for identification of the and marking of tibial footprint. In the line of posterior border of anterhorn of lateral meniscus, the tibial footprint is marked, and deflecting the ACL, the all inside tibial jig is kept. And similarly, the retro reamer or flip cutter 3 is passed, and the diameter is set up to the required diameter of the graft, which you have created the graft link. And once it is goes inside, then it is opened up, and the retrosocket is created up to the required depth. Usually 25 to 30 millimeter of the tibial retrosocket is created. Once the tibial retrosocket is created, the flip cutter is taken back, closed and taken outside. And then with the bead pin with suture is passed, and withdrawing the bead pin with the suture, we clear the mouth of this tibial socket. And then with the help of an anti-grade suture passing device through a passport cannula, we take bites of the remnant. So we take horizontal bites from in the distal part, and then gradually from distal to proximal, medial to lateral, and lateral to medial. So after taking these bites, both the ends of this remnant suture are parked in anteromedial portal. Once both the ends of this remnant suture is parked in the anteromedial portal, then we retrieve the femoral and tibial leading suture. And then the remnant suture is passed through the femoral retro button from distal to proximal direction, and all the sutures are loaded on the femoral leading suture. And then you pull all the suture into the femoral tunnel. First, you isolate your this bundle sutures, remnant sutures, and pull it up to the button. Then you keep this remnant suture aside, and then pull all the sutures of the graft link. Once you pull all the sutures of the graft link, it will go inside. Then under vision, you flip the button. The button is going under vision, and you flip the button, and then with cinching movement, the graft is taken inside. Once the graft is taken inside up to the required depth, then the tibial side remnant, so tibial side sutures are loaded on the tibial loading suture, and all the sutures are taken into the tibial tunnel. And once the button is out, then with the cinching movement, now you can see with the cinching movement, then you tension the graft. Once you tension the graft link, it will be of adequate tension. Then you take the remnant suture and tighten it and tension the remnant suture and put a nut and cut it. Now you can see how the remnant is tightened over the graft link without creating any the roof impingement or the PCL impingement or the notch impingement. And this is the final picture of the remnant preservation graft link. So what are the complications of this procedure? You may have Cyclops syndrome, you may have inaccurate tunnel placement, you may have impingement. So what are the controversies of this procedure? The volume of the remnant, qualifying the remnant is not sure. The influence of the patient age and the time from injury to the surgery is also controversial. So these are the literature support. So to conclude, based on the present literature, there is promising but insufficient evidence to support the superiority of ACLR with remnant preservation over the standard technique. However, future studies should better describe the ACL tear pattern, the remnant volume, the remnant quality, and the surgical technique. And studies of long-term outcomes after ACLR with remnant preservation are needed for better functional outcome. Thank you.
Any question? Any questions?
Without that, nobody will get questions.
Yes, there was.
So you had some skill in life. Okay. Sir.
Failure. I mean, whether your number has gone down, like say in my series, I found it's about close to 3 to 5%. Still, I see some of the failures, so it is there. So what about you? I mean, what is your observation as far the failure rate is concerned?
Yeah, in my series of remnant preservation, in cases where the remnant quality is good and the remnant volume is adequate, then I get a better functional outcome in the post-op period. But in case of only small amount of remnant, if you sacrifice or if you preserve, there is absolutely no difference, because one study I am presently I am doing by keeping the remnant and by sacrificing the remnant. If the remnant volume is less and the quality is not good, then there is absolutely no difference I am finding. But if the remnant quality is good and you can just tension the graft and you can envelope the remnant envelope technique, then the functional outcome maybe probably will be better. Then at the end of the study, we can come to a conclusion.
One more research.
Because you don't know, I mean, after certain days or years, maybe.
Researcher, please. Researcher, please.
All concept is about the, you know, the functionality of the mechanism, etc. So they might be contributing.
Then it's surgeon to surgeon, the personal experience varies with patient to patient also. Some patient, they come with a better functional outcome, and the sports person which I am doing also, they are having a good outcome as compared to the sports person which I am not doing remnant preservation. So from that, I am coming to a conclusion, probably if I am having a good remnant, then I should preserve it for a better functional outcome.
Any long-term studies, Ranjit? Any long-term
Sir, my study is right now for 2 years, maybe 3, 4 years or 5 years down the line, we can come to a conclusion.
Another question I want was what about this impingement and cyclops lesion? How problematic they are in remnant preservation?
Sir, in 5% of my cases, I get the cyclops lesion. But impingement, if you are careful enough while doing the remnant preservation, it is very less. But if you are doing overstuffing of your this ACL graft and the remnant, and if it is impinging on the roof on the day 0, then it will have impingement symptoms. But on day 0, if you are having no impingement, then I don't think there will be any difficulties in the impingement part.
Thank you.
Okay, thank you.
Sir, as we are keeping the remnant here, so can you decrease the diameter of the graft, or the graft should be intact? Since the
Still I am taking 8 millimeter of the graft, but if your your remnant volume is more. And if it, because ideally you can go up to more than 9 millimeter. Ideally is 9 millimeter. You should not come below 8 millimeter. So 8 millimeter plus 1 millimeter, if it is 9 millimeter plus also, you will not have impingement. If it is more than 10, then probably you will have impingement in those cases.
So if in case there is
Thank
more
you,
than
sir.
10, then you have to reduce the size of this.
The volume, remnant volume, sir. Or you can tension that remnant so that the size will decrease.
Okay.
Here, okay, Ranjit, one question. Here remnant you means the ACL stump or any intact bundle you mean? Either
There are two types of remnant, what I have described. The type one, in one category of patient, either isolated AM bundle tear or PL bundle tear, or you are having the remnant. Four types of remnant. Either you have 4 types of remnant according to Kane's classification, or you have isolated AM bundle tear and PL bundle tear.
Okay. But in all inside technique, you have to clean the tibial.
No, I have already shown. If you can deflect your remnant in the line of posterior border of anterior horn of lateral meniscus and just keep your footprint, you will have to erase little bit of your ACL footprint on the posterior aspect. Then you will not have non-isometric anatomical tunnel.
So if the posterolateral bundle is intact and anterior medial bundle is torn, then you can go with the same procedure or you have to change.
If the posterolateral, then I will go for a AM bundle reconstruction technique.
AM bundle
Yes.
reconstruction. Okay.
Thank
Thank
you.
you. Thank you, Ranjit.
Thank you, Ranjit. I think there is some message from Dr. Sandeep from OT. And you will.
Yeah, I think OT is ready to focus. Hello,
Yes, sir. So,
Sandeep,
yes, sir. I just want to show the final.
anybody from the OT? Are you able to listen us?
Am I audible?
Yeah.
Can you see?
So where you are now? Tell us.
Sir, yes. So we have completed the procedure.
Your voice is not clear. Volume.
Hello. Yeah. Am I audible now? Hello.
Still not.
AV.
Yes, now it is better.
Yes, sir. We have completed the procedure. So that's the inside picture.
Yeah, we are not able to. Yes, now it is.
Yeah.
So
that's
can I have the PIP also?
Please
Yes.
yeah.
Yes.
So that's the graft, and we have put peak. So what I do always, I pass my graft, then I put this pin and see how much able to this pin is going inside. So if sorry, not this pin, the trocar. If trocar to get adequate around 1.5 centimeter in, then I choose the same length. If it is not able to insert, then I go one size down. So here I have put 28 mm peak through. I got a very good fixation.
So interferential screw in the proximal side, it is around 9 or 10?
10, both are 10.
10. So equal to the hole. Okay.
Yes, it's equal to the hole.
Okay.
So the test here is put the probe, but put here the trocar and see how much trocar is going in. If able to insert the trocar and then put the same size. But if trocar is not going in, then I go one size lower. If in case of BTB. So that's the final picture of the graph. Good. Friends.
Very nice. Very nice.
And here we have almost closed, and whatever the extra here we showed in the tibia, whatever extra was there, we have put in the defect.
Can we have the outside picture larger? Yes.
So whatever extra bone we have put in the defect of tibial tuberosity.
Okay.
Yes. We have packed it in.
So already fixed the distal end also. This is tibial side also.
Yes. Okay.
So how much graft was outside? That bone piece?
Yeah, we can take out and show you the piece. So this much.
Oh, okay.
Around 1 centimeter or 8 mm.
10 millimeter or 15 millimeter maybe. Out of 100 millimeter length of the graft, I think 10 millimeter or 15 millimeter was outside.
So we have again put it in the place where it belongs to.
Okay.
Okay,
Yeah.
thank you.
So you are keeping that graft also in the defect and then closing.
Yes, it fits perfectly. So I'm going to just punch it in. I'm just going
Yeah.
to put it in.
Very nice. So anything else you like to say?
No, thank you.
Or we just switch over to the talks again?
Thank you, OOA, and STB Medical College and fantastic team of anesthesia and assistants. Thank you.
Thank you. Thank you.
Punch.
Very nice demonstration. I think you have already heard the applause from the floor, from the auditorium. Thank you, Biraris. Now we'll go to the next talk. Sir,
Our
please.
next speaker will be Dr. Deepak Joshi. He'll be talking on infected ACLR management protocol.
Thank you once again. So this is the one of the last talks, but very important talk when we do day-to-day orthopedic surgery. We know in orthopedics, the infection is the most dreaded complication. So what to do when we suspect an infection in an ACL after reconstructed ACL. So infection after cruciate ligament, it is there. It is uncommon, but it's there. One should always be suspicious of it. If present and you don't do anything, it can lead to you loss of your precious graft, arthrophosis, the loss of cartilage, arthritis, and all sorts of contractures and problems. Worldwide, the literature for the infection is reported up to 0.14 to 1 point. So it's approximately 2% to the maximum. So in our studies, we did at our center, the infection in single bundle was 0.8 and double bundle 2.5. So the problem with this thing is that if we classify it as an acute post ACLR or less than 2 weeks, we can have a subacute also. Patient just keep on coming with pain and some rhythm and something for weeks and weeks, and we may miss the infection. So most infections are due to the inoculation at the time of surgery, but it can be a superficial tunnel infection which can track down through the whole of the screw or the whole of the tunnel into the joint and further into the femur. So we all know that with our knowledge that cartilage loss occur whenever we have a septic arthritis. Within 7 days, we lose all the glycosaminoglycans, peptidoglycans, and so prompt treatment and suspicion is very important. Of the risk factors that we can control is probably the tobacco use and the diabetes and the steroid use. So these all things we can control. We have to ask the patient not to do this post-surgery. And a long operation time can also be a risk where we can do lots of washes and add another antibiotic. So the problem with this after ACL reconstruction is that we don't know whether it's an infection or just a pain. The patient just say that something is wrong, the pain is there, you see mild swelling in the knee joint. It can happen with a normal ACL also. For according to these studies, 60% of the time it is failure to appreciate the infection at first visit that lead to the catastrophes later on. Classical presentation can be just a small pains, limited range of motion. Other symptoms are low. One should always be suspicious is that look for increase in local erythema and warmth compared to the other knee. The swelling which was there, not there of post-surgery, post 1 or 2 days of surgery, and it has rapidly increased. The pain is excruciating and it is not controlled by the analgesics. Intermittent fever, patients say 99, 100, then 99 again. So you should have a very, very strong suspicion. Most of the time in our studies also and the worldwide also, staph aureus is the most common organism, but staph epidermidis, which is sometimes a commensal, it is also end-minded gram-negative bacteria also we have found in some of our cases up to 7%. So anything can be there. So all E. coli, if you get it, they are not contaminants, you should have a strong suspicion. Joint aspirate, you have a slightest doubt, do a joint aspirate. It is the gold standard. CRP and ESR blood tests are the next dependable test. So if you have a WBC count in the joints more than 1 lakh, 99% it is infection. If it is more than 50,000, 92% times it is infections. If it is more than 25,000, 73% chance that it's an infection. If you have a neutrophils count more than 90% in a joint aspirate, then it is 79%, quite high chance. And the synovial fluid glucose less than 1.5, again 85. So these markers tell you that, okay, there is. So aspirate and get these, because the culture always takes very, very long time. Other things, CRP, ESR, LDL, WBC, they have lesser specificity because they can increase even after normal surgery. Investigations, do a proper X-ray and MRI. Assess the status of cartilage, see where all the fluid is there, what all pockets are involved. Basic principle after acute reconstructed ACL is, the aim is to remove the infection and protect the ligament. It's a very important graft. So you have to do a extensive synovectomies, and you have to know all the accessory portals, posterolateral, posteromedial, supralateral, supromedial, all the portals have to be used for thorough cleaning. So as I said that CRP studies have shown CRP and these are not very good. The joint fluid analysis is very important. So this is a Roth et al. Gave a very good article where diagnostic criteria that it's a septic arthritis after ACL is a positive culture in gram, purulent aspirate. You see there are flakes in aspirate. PMR, the neutrophils are less than 90, more than 90%, and the cell count more than 1 lakh. So at our center, less than 10,000, we all it's non-infection. It is more than 20,000 or 25,000. Always we are suspicious. 50,000, we always take it as an infection. So even 25 to 50,000, we generally go very fast and do the lavage immediately. So one should be highly suspicious. The fluid is slightly turbid. The 90% PMR neutrophils are less than 75%, and the cell count is 20,000 to something 50%. So one should be suspicious that time. So once you have the lavage and everything has been done, so how you progress, the patient symptomatically will become better. Do a regular CRP and ESR. And if you think the markers are increasing again, don't hesitate to do a lavage again. So we have done up to 3 arthroscopic lavages also in some of the cases and save the ligament. But I think most of the times 2 are the maximum. When we go for 3rd or 4th, our aim should be that probably we won't be able to salvage, and we should counsel the patient to remove the hardware, graft and all the buttons. So another protocol people have used continuous irrigation. They are very painful and open irrigations to patients. So rarely we use it at our centers, but these are also the techniques available in the literature. So worldwide protocol is serial arthroscopic lavages, intravenous antibiotics, ceftazidime, vancomycin, gentamicin are very used empirically in the initial stage. Then as the culture come, which rarely come positive in these cases, early cases, then we go for the culture specific antibiotics if we get something culture. Average duration that the studies have shown, the antibiotic, IV antibiotic, they have given up to 6 weeks, and follow the oral antibiotics. So in a debridement, we should use all the portals, remove every necrotic tissue, near total synovectomy should be done. All the adhesions should be removed. If you think that this wound is, you are not able to close the wound, you can use a vac, and you can shoot a negative suction devices, and some people can say use a continuous irrigation also. So what we do, if we are suspicious, we again do the same thing, and whoever is confirmed post-mortem infection are subjected to hematologic investigation, ESR, CRP, and we use the gram-positive things, the teicoplanin, frequently because the staph aureus is the most important cause. Thorough lavage, synovial biopsy, standard time, antibiotics after the culture, till that the empirical cefuroxime, amigacin, and the teicoplanin or the vancomycin started. Patient is followed very far. ESR, CRP should return to normal within 3 weeks time, and uh, 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 basically that's how we follow them, these patients. So generally at our center, we give IV antibiotics for 2 weeks, followed by oral for 4 weeks, which may be continued further for few more weeks if we think the counts are not, the CRPS are not coming down. So studies have shown that regarding this intraoperative graft, I just have a word about that. If the graft is fallen or you think the graft isn't contaminated because of sterile technique, do a thorough lavage with a saline and use a chlorhexidine. Though it is potentially chondrotoxic, so soak it in it and wash it thoroughly after that, or use a triple antibiotic solution. Dip the graft in a triple antibiotic solution. Just using of IV antibiotics is not recommended. You just don't want to increase the number of antibiotics. So you have to do a thorough lavage. The graft can still be implanted because again, the autografts are very precious for patients. To conclude, various studies reported satisfactory follow-up. Most of the time, patient have good ACL. We are able to salvage as well as the function. Sometimes the patients do have, according to studies, some contractures, flexion deficit in many studies have been reported. But most of the time, if you diagnose early, you can really salvage the graft and the function to the fullest. At our center, the double bundle ACL, we thought that the infection, we couldn't find out what is the reason. Probably the time for maybe 10 minutes more time, or we are making 2 more tunnels. Probably that's why the infection was right, but couldn't find the cause. But again, they did very well with the adequate joint debridement, 2 weeks IV and the 4 weeks oral antibiotics. Thank you so much for the invitation and all the hospitality.
Thank you, Dr. Joshi. Any question from the floor? Any question? Dr. Joshi, I have got one question. Suppose you get you have spoken about the acute infections and immediate infections. But if suppose the patient comes with delayed infection.
Yeah.
Suppose say after 1.5 years.
1.5 years.
And the screw, the lower end, that is tibial screw, that is a titanium screw is migrating.
Yeah.
Then 1 year, 1.5 year, what to do?
It happens in our cases. So there are some company specific screws which used to do more. So what the problem occurred that when 1 to 1.5 years, the screw start breaking up. So when the screw start breaking up, the screw related reactions also we have seen in so many patients. But when we do a debridement and we just clean the tunnel and remove all the debris, generally they do well. So that's what I was there in the surgery. I was telling all the residents there that put the screw at least 4 to 5 millimeter inside the bone so that when it breaks, it doesn't cause that much of soft tissue reactions. But we have seen delayed reactions subacute after 2.5, 3 months, and the patient is lingering on. We have our patients where we have lost the functions, contractures and cartilage loss, which was not. So again, so if we are, the thing is that if we are slightly suspicious, we should treat all these patients as a septic arthritis, and we should not hesitate in immediate and early lavage of these patients. We should take them to OR as early as possible. There is no harm in overdoing it than underdoing it.
And another question is after how many months you can safely remove the titanium screw? Suppose it is migrating, mild infection, the graft is normal, there's no septic arthritis, but local infection.
Yeah, sometimes these patients come to us. So 6 months we give the target. We try somehow we can increase if the infection is very mild and it is not that much. It heals and it breaks down. It heals and it breaks down. So probably some screw related things. So if everything is fine, the joint is fine, then we try to salvage for at least 6 months or maybe towards 6 months once the graft is fine.
So after 6 months, you can safely remove this.
It is safe to remove.
Okay, thank you.
Sir, last question. Sir, here. Sir, say if in case of multiligamentous knee injury, you have done one ligament and you are planning for second ligament in the next setting. The thing is that if there is acute infection say, by around 1 month and you have done arthroscopic lavage once, then again there is septic arthritis. Then whether there is any role of open arthrotomy or again you have to go for arthroscopic lavage.
Yes. So once we are, say we have done the lavage, we have done the second lavage. Yeah. So we are planning, we have removed the screws and everything. Still the infection.
No, the graft is well intact. It's not that much of infected.
Graft is not infected.
yeah.
So see,
It's only 1 month, 1.5 months.
1.5
Yeah.
month, but you can, I think, do the lavages and everything.
Means
with the
lavage, how many
vessel.
times you can do lavage means, as per your, that protocol, I saw 2 times lavage, arthroscopy lavage, then after?
Then after, it is the removal of the implant. It
Removal of
means
the implant.
you cannot salvage. The bacteria has get its implantation, got implanted on the implant. It's very difficult. It is very difficult to salvage the graft also in such cases. So there are surgeons who have recommended that if any doubt, you should remove it. Do a classical arthrotomy.
Yeah, that is
remove
Open
all
arthrotomy.
suture, room each and every thread which is there in the joint, because preservation of joint is probably important, and the ligament can be reconstructed later on also.
Okay.
Thank you, Dr. Joshi.
Thank you, sir.
May I now call Dr. Tapan Kumar Das to speak on complications of ACL reconstruction. Dr. Tapan.
Good evening, everyone. I'll be talking regarding complications of ACL reconstruction. So far, we have learned regarding how to do a proper ACL reconstruction. We have done one, and you do a post-op X-ray. You think that everything has gone fine, but when you see properly, you see something is left behind in the knee. So now coming to the topic. So ACL reconstruction has a complication rate of around 1 to 15%. These complications, for discussion purpose, we can divide into complications related to clinical judgment, graft-related complications, post-op complications, and some miscellaneous ones. The graft-related complications can be divided into complications related to graft harvest, sizing, and graft basement and fixation. We know that whether we do the ACL reconstruction early or a delayed basis, the clinical outcomes are similar, but when you do it on a very delayed basis, it leads to more contral and meniscal damage. So it is advisable to do an ACL reconstruction when the knee is not angry looking and it has gained around 90 degrees of knee range of motion. Considering MRI, we should always get oblique sagittal images so that we see the ACL in profile. There are some hidden lesions like the root tear or the ramp tear. These has to be diagnosed by doing a proper diagnostic arthroscopy. Similarly, MCL, LCL tears or in the PCL tears should be diagnosed properly before doing an ACL reconstruction. Not only that, clinical examination under anesthesia is also important. If the patient has a high-grade pivot, as shown here, the patient needs an ALL reconstruction or an LET along with an ACL reconstruction for a good result. Other conditions where we need an ALL and LET are patients having young age, high tibial slope, and patients with a high-grade meniscal injuries. These kind of misdiagnoses lead to around 15% of case failure in ACL reconstruction. So the solution to all this problem is that we have to have a proper pre-op evaluation of the patient, a proper diagnostic arthroscopy, and we should be ready with all the armamentarium so that we can deal with different surprises we came across while doing an arthroscopy. Graft harvest related complication, coming to hamstring graft, premature amputation is a complication. How to avoid it? The only solution is that we have to cut the vancula before harvesting the hamstring graft. Patella related complications, when you harvest a BPTB or a quadriceps tendon graft, they can be, the solution for them is to take a proper central part of the patella, use mini drill devices and take a bullet shaped graft. Different type of appropriate instruments will also help you so that you don't have a fracture while preparing the graft. Coming to graft placement, it has been described that malposition tunnel is the most common cause of ACL revision, but considering this, femur is the most important between femur and tibia. Why? Because a malposition tibial tunnel usually causes impingement when it's placed more anteriorly. When it's placed posteriorly, it's also called PCL impingement. And when you place the femoral tunnel more posteriorly, the graft becomes lax in flexion and tightens during extension. And when you are not having the graft more posterior tunnel, it can lead to a blowout. How to do a femoral tunnel? You can use a femoral offset or a microfracture awl, but better you should use a microfracture awl to mark our point. Then come to the medial portal and see the point where you are planning to have your femoral tunnel. Then you drill over it for a proper tunnel. Posterior wall blowout is a complication. How to deal with it? Here, while drilling, we had a posterior wall blowout. We make one more tunnel, which is more inferior and more medial, so that we can direct to a more superior part of the femoral condyle, and then drill over it. So after drilling, what you will get is a view like this. One more tunnel, which is more superior, other one, which has a blowout tunnel. If you are doing a BPTB graft, you can, depending upon the size of the length of the bony part, you can take the graft more inside or more outside. That will solve the problem. Lateral wall blowout is a problem. If you have access, you can use an extender button, or you can always use a post device on the femoral side to come out at that situation. Similarly, if you have chosen one tunnel, but the tunnel seems to be more posterior, you can put your screw more on the posterior side to bring that graft more anteriorly, then vice versa. Always try to put your screw in line with the tunnel. Tunnel divergence of more than 15 degrees has been associated with complications. There are some cases where you are not satisfied with fixation. You can always use an additional fixation device. Here it is a staple. These are very common complications. What we come across, we have drilled whole of the femur. The button has come inside the femur. Otherwise, you can flip the button over the fossa. So how to avoid them? The best way to avoid them is that you flip the button under vision, so that you can see that the button is coming out of the fossa, and mark on the adjustable loop so that it doesn't come out of the fossa. Rare cases, you can use a C-arm also. The other thing is that you can toggle the leading and lag sutures over the femur, so to get the feel. There are some post-op complications like infection, as discussed before. If you are not able to keep the graft after after 1 or 2 episodes of debridement, you have to take out the graft. And the solution to this is vancomycin. Pre-soaking the graft in vancomycin has shown to decrease infection. There are some complications like which lead to a decreased range of motion, like arthropibrosis, cyclops lesion. Otherwise, somebody has put a screw more into the tibial side and gone into the joint. That also will cause impingement and loss of motion. Donor side morbidity, usually patient may complain some sensory loss along the tibial part. That can be, you have to counsel the patient that this will recover in 6 to 9 months. Venous thromboembolism is a rare complication. We do not advise thromboprophylaxis, but if you are doing an hastio along with an ACL, you have to give the patient some venous some prophylaxis. So to conclude, most of the complications are avoidable. Do not compromise in arthroscopy setup and instrumentation. Pre-op evaluation and planning, having a good diagnostic arthroscopy is mandatory, and always have a contingency plan. This plan may involve one more senior surgeon if you have landed up in a complication, so that we can come out of it. Thank you.
Thank you, Dr. Tapan, for a nice presentation. Any questions? Thank you. No question. Thank you. Thank you. Now we'll end this session, and next session will be on the panel discussion on ACL.
Sir, asantu. Yes. The mic. माइक दे दियो तो समझ माइक So let's start the panel discussion now. We have very nice panelist. We are very lucky that at this moment at the 5 o'clock also we have got the lot of delegates to listen us. Thank you very much. Now 25 years male state hockey player, twisting injury during the playing and the right knee, Lachman 3, pivot 2 and 6-week-old ACL tear plus that weakness. You can say the pivot shift, exclusive pivot shift. I don't know. I just wanted to know what is it. So let's start from the Sandeep.
Yes, sir. What is the question?
What type of pivot? Yeah, no question. I just wanted to, yes, it is a 2 or 3 exclusive pivot or a type pivot 2 or pivot exclusive.
I think it is more. I think it is more than 2.
More than 2.
Yes.
It looks like that. It's an exclusive pivot and he's a
Pivot
football
three.
and hockey player and he's 25 years, 6-week-old injury and he want to play. So this is the now management. So Sandeep, you starts with that.
Okay. So now he's a hockey player and 6 weeks old injury. So my choice will be ACL reconstruction plus LET. That's what I think I'm going to do for him. LET, why? Because he's a hockey player. If he would have not been, because the pivot at this point will not be my indication for LET. But LET indication in this case is only because he's a hockey player. That's the thing. Otherwise, ACLR.
You want to protect the ACL also at the
ACL,
playing time.
And then I'll assess again intraoperatively after my ACL. If I feel there is still pivot, then LET. But in this case, ACLR plus LET is my.
Deepak, you do this tenodesis, extraarticular tenodesis or ALL?
I always do the LET only. ALL, I think I don't do. I have never done that.
Okay, Devasis?
Before to examine the patient properly, just check for what is the rotational stability, whether it is anterolateral or posterolateral, or there is some other associated injury that are associated with it. Any meniscus, anything is.
Now this much, I think there is no, this side to side movement is almost normal. No, nothing. No, that was normal.
I think I would prefer express view. instead of, kind of set up a surgery, rather I would think about a stress view, just want to confirm any lateral laxity, because the corner laxity, if it is there, it is bound to, have this much of laxity. The corner laxity one has to be really, really much plus to each other. And if necessary, then probably AL. Obviously, if it
Okay.
is anterolateral, I would rather think about doing something on the lateral.
Ranjit?
In this case, is a hockey player, 5 years, high demand athletes. So, in case of when I am reconstructing my ACL, this kind of patient, they go to their play early, they start their rehab early. Even if you advise them also, because of their team pressure, they start their rehab early. So I want to protect my graft during the rehab period as well. So I will go for internal bracing of ACLR plus LET.
Okay.
Definitely.
Okay.
In all cases right now, probably hardly few cases are left out without any bracing also. No?
Bracing? No, 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 no.
No bracing.
On athletes?
No.
Hey, even
Athletes, non-athletes,
10%.
no bracing.
Bracing is always preserved for few cases. Till now, everywhere in the world. Bracing is only indication is very, very rare. Most of the people are not preferring the bracing, internal bracing. Sir, Atanu sir.
Yes, my option will be ACL reconstruction and LET.
Okay, so most of the panelists are preferring the LET and maybe the ALL or maybe the tenodesis. So what I did is ALL. I prefer to do ALL because it seems to be in my hand, it is very good. And that is the, I learned from the Strobel, maybe 2005. And that from that days, I prefer it is a two tiny incisions, looks like arthroscopic surgery. That's why I prefer that maybe, I don't know. So this is my, the two tunnel, both these tunnel at the medial aspect was just almost side by side or fixed with the one single suture wheel. The ALL is fixed with the adjustable loop and the ACL is fixed with the fixed loop. So next case is the 43 years male recreational badminton player, 43, mind it please. So while landing, that is twist the right knee. Want to be active again and play Lakshman 2-3, pivot 2, and no varus deformity, though 43 years, 4 weeks old, ACLR and ramp lesion. So this is the MRI picture. And this is the on probing is almost say 99% torn proximal side, but the whole of the graft is almost the Sermon type 1 or type 2. You can say it maybe type 1. Now from the Autonoi, what is will be your approach to this patient? 43 years, recreational player, 4 weeks old injury, and he wants to be active again.
Both ACL
There is no varus deformity.
No varus deformity.
But the almost the ACL is the proximal avulsion type.
Well, I will go for ACL reconstruction as well as a ramp repair.
Okay. Ranjit?
Remnant preservation ACLR with ramp repair.
So you want to fix the remnant preservation how?
No, I'll want to create a remnant envelope because
Okay.
it's not type 1, it looks type 2 kind of thing. So I will create a remnant envelope.
Envelope type.
Yeah.
Okay.
I do the same thing, excepting that he does with a pull-out suture, but I take a swivel lock and suture it just bit of anterior to that. I mean, instead of going more posterior, I just put it one more swivel lock.
Okay.
So straight away fixation.
And also,
And the all inside ACL with a suture into the stump and fix it with a swivel lock.
Right.
It's sort of a internal bracing, biological internal bracing.
Again, ramp repair and the ACL, classical ACL, remnant preserving.
Okay,
Preserve as
classical
much as
ACL and you want to preserve the remnant. Okay.
Same.
Same, correct. So most of the people are, there's a very, you can say tempting type. It looks so nice and bulky and nice and the tissue is very good. So it's a tempting time, though it is a 43 years male, still the preservation of the stump is always good. So activity modification that we have discussed. So remnant preservations, that is the better way. But I did also them same remnant preservation, ACL reconstruction and the ramp repair. Okay, so but I have not done this what that swivel lock or maybe, but I just do the ACL reconstruction, what the Deepak is telling and the Sandeep is telling. I don't think give a incision at the center, maybe intra. Then drill the TVL with the dancing type without injuring the much of the tissue. And then at the end, I just put a stitch here, maybe. Yeah, stitch here maybe at the end, at the top. That lasso stitch to the graft to the remnant. Okay, I think that was my technique. Okay, so another patient is 38 years male policeman, little tall, maybe around 6 or 5.10, left knee, and that is a 2 weeks old injury only. Then range of movement 5 to 100 degree of range of movement. Wants to take again because he's a policeman, and Lakshman 2 pivot shift 1 to 2. So adduction, abduction at 0 degree and 30 degree stable, but last one is I think 3 plus or 2 plus. Enter drawer. Pivot is also 2 or 2 plus maybe, like this. So this is the intra picture. Yes, see this.
Laxity score.
Lakshman is 3.
No, laxity score.
Laxicity is normal. No laxicity. No laxicity. So Ranjit, each will be classifications of this sermon, 2 or 1 or 2 or 3.
Three mid substance.
Yeah. So that will be, I think, sermon 3, it is around 33% or maybe 50% or 33% like this. So what will be the management? Maybe active modification, non-operative treatment, patient is a policeman, want to be active, and 2 weeks injury, there pivot positive and then enterodor positive. Conventional ACLR or double bundle ACLR or ACLR with ALL or LET. We'll start from the opposite side.
side.
Yeah.
Well, I think the pivot shift is grade 3.
Yeah, grade 2 to grade 3. It is more than grade 2.
So again, we'll go for the fourth one, ACL reconstruction and LET.
Yeah, fourth one, LED. Okay. Ranjit?
Same.
Same. Yeah. Yeah.
Another additional strain on the left side, make it more, tight knee and something like that.
He's a policeman, so.
Yeah, he's a policeman, but majority of the police, they are sitting down.
Yeah, he is very active policeman. Not like not like a lazy policeman. He's a active policeman and
Pot bellied policemen, they don't need anything to do. I think probably they just can manage with simple, all inside.
and he's also tall. He's around 5'10".
Weight. What is the weight? What is the athletic activity? Does he play any kind of sporting activities?
Yeah, not a regular activity, not a player, but he plays means up and down like
one more procedure.
recreational player like.
I would not prefer to do a tenodesis.
Yeah, Deepak.
Same.
Only ACL.
Only ACL in this patient.
Okay, and you are also same. Okay, remnant preservation is a must. Yeah, no analyty. Yeah. Okay. Okay. So what I did, let me see. This is a double bundle ACL. I think I operated this patient about 2 years before, 2021 during the corona time, and that was the 2 bundles ACL. Okay, So another patient is a 22 years male, all patients are male, and chronic right knee pain for a year without any trauma, mild instability, pain worsened by the extreme flexion and extension, mechanical locking, clicking, stiffness. And patient is a very young, he's working in Australia, and he is a, what is called, a photographer, animal photographer. So he used to go to the water, go to the land everywhere in the world, and he's a very active man. And now lobulated mass and the rounded mass on the arthroscopic mid intrasubstance intercruciate ligament mucinous cyst boundaries of the pseudomembrane. So this is the X-ray. X-ray is almost normal, and there is a cyst, and this is the MRI, and this is the intra picture. So what should be the management? Sandeep?
So now for him, I will debride the cyst and I'll check instability after cyst decompression. Like I'll go very generous, means not aggressive. I'll decompress and check. If
so,
it is
step by step,
Yes.
decompress and check under or
yes, and I feel
Okay.
too much ACL substance is being taken out,
Yeah.
and I'll straight away.
Suppose
do
the
ACL
substance is
reconstruction.
very good, and after decompressing, debulking, then you want to preserve that.
Yes, leave it as it is.
Oh, any Devasis? Yeah, Deepak.
The same thing, I think we start debriding and we see what is there inside. If it is more, entire ACL is gone, it is all degenerated.
Yeah.
Then we remove it and do a proper ACL. Else, I think debridement does very well in these patients.
Correct.
Almost same. I think probably it all depends how much you are left with the ACL. That depends. If you are taking out almost like 70%, obviously it's
So that
yes.
depends on the ligament that remnant how much.
Same, sir. Decompression of the cyst. If the
So that's
quality
a unanimous
remnant is, then reconstruction.
follow up that everybody is telling the same thing. So what I have done. So I did the arthroscopy, diagnostic arthroscopy, then went to the needle, then the gelatinous material came out. Meniscus was everything normal, cartilage was normal, and then put the 11 number blade, make a incisions around say 15 millimeter long incision. And then we try to fill the intra substance. So I put the saver inside and decompress all the gelatinous material, and then try to fill step by step, as Sandeep told, everything step by step. And then again, try to decompress, and then RF to burn any sheath of the tissue or the cyst, and then curate also. I was mentally prepared because patient was very young and very apprehensive, and then try to close that mouth. And that the remnant was that ACL tissue was almost good. But still in between the ACL and PCL, there is a huge cyst again. So it is almost a posterior to the ACL tissue, ACL ligament. There was a cyst all around, inside the ACL and around the ACL also. So that also removed, and at the end we found the tissue was good, so we just left it as such. At the end it was very good. So this is another patient, 53 years male, ACL reconstruction done in 2012 at Kolkata, and 5th July 2023, twist same side knee while playing the badminton. Presented to me on 12th September after 2 months of the injury of this month, the instability and Lachman +3 and the pivot +1 and no varus deformity, though he is 53 years. And this is the X-ray. That is the previous X-ray, at present X-ray, sorry, present X-ray. And this is the torn ACL after this almost 13 years of the surgery. He was very good, no complaint. This is second injury torn. And this is the X-ray and the MRI. So what is the cause of this tear? It is a trauma or it is a failure?
12 years duration, no?
Yeah. Probably a
It is
trauma, I think.
2012, almost 11 years after the surgery.
Probably a trauma only, I think.
Yeah, because this tunnel placement at femur and tibia, it looks now, I think good, not so bad. Though it is little bit maybe 50-50 in the posterior, maybe in the tibial side. So maybe the trauma is the cause. Okay. So what next? What should be the precautions we should take for this? How to remove the implant? You should remove the implant, and for the tunnel placement. As per the X-ray, there was no tunnel dilatation. So what should be the minimum tunnel dilatation so that it should be a two-stage procedure or single-stage procedure like this?
12 millimeter above 2 stage, less than 12 1 stage.
So 12 to 14 may be cut off diameter of the tunnel if it is a tunnel dilatation. Yes, Devasis?
He is 53.
Sorry?
He is 53. What's his activity? Is it pain, which for reason why he is here? Or it is because of the instability why he is here?
Instability.
If it is because of the instability, then definitely I would look at his, the HK axis. Even though there is a correction of 2 degree also, I would think about doing an HTO to that. Just to leave it just like that probably is not doing too good. Rather, I am adding some more injury to that because the compartment is already diminished on the medial side. If you can go back and just look at the X-ray also, it's diminished on the medial side.
There is no varus deformity, but I think no much of, yes, that is diminished, but it is not so much of like stage 2 osteoarthritis.
Yeah, if it is an osteoarthritic knee,
not but
definitely
much, yeah.
even a minor degree of correction, if it is required and is a single surgery, I can do it. I would rather prefer to do it
But
because
he has no complaint of the pain for the arthritis. He has only complaint of the instability after trauma, and that to 2 months old trauma.
on the scopy,
He
if
was
I
very
find,
happy after the surgery for
Even-
last 11 years.
even in the scopy also, if I find there is an arthritic changes on the medial side,
Yeah.
there are cartilage changes, outer bridge say about 3 on the medial side, on the weight bearing region. In a ACL normal, it will be more on the
For your
anterior,
information,
but
cartilage
if
was
ACL deficient, it will be on the post. If ACL deficient is mostly on the posterior. So
No,
I
you
would
can
rather
go for a
see-
scanogram.
cartilage was
calculate
not
the
so bad.
angles.
Cartilage was not so bad.
So I would rather look at all these features and to decide. Sometimes maybe I'll just cancel my OT, reschedule it with a HTO plan a later day. If I find all these problems.
Deepak?
I think, yeah, scanogram should be done in these patients, but as far as the surgery is concerned, post 50 years and this much of activity, we give it to the patient. So it is not the surgeon's decision, it's the patient decision whether he wants surgery, and that is the instability. And for instability, again, if the scanogram shows it's a varus, we should combine it with an HTO. And 14 millimeter is the stage 1, stage 2, where we should do in 2 stages, or 14 millimeter is the cutoff that we take.
Just a question to you, I think,
Just
because you are doing a
show you
revision.
the scanogram.
What graft do you use? I mean, the bone patellar?
Right. If it is a player, then I'll go for a bone patellar tendon. Otherwise, I'll go for Peroneus. We do lots of Peroneus for revisions in a normal recreational sort of patients.
Then if it is like you said.
This is the scanogram.
14 mm is the cutoff. So how much bone patellar tendon we can take from tip patella, no problem. But what about from tibia? I mean, how much broader we can go for?
I think I still go with a 10 millimeter, 10 millimeter. Yeah, I can manage with a screw size bit higher, maybe. I just want to confirm that whether my screw is size loose or something like that. So if it is about 14 on my CT, then obviously that's a problem. I think I cannot really go for the higher side of the screws.
Because again, if we go for the
So this patient
how much
scanogram.
screw we get. That is also question.
Scanogram also almost normal. Now you can see the scanogram, and the cartilage was not so bad, and the dilatations of that tunnel is not so bad. It is less than 12 or less than 10 also, and there was no dilatation. Patient was very happy for last 11 years. It is almost like a normal ACL torn.
Straight forward ACL.
So you prefer the quadriceps or the graft? Which will be the graft choice?
Do we have the dimension, sir, of the tunnel?
Yeah, you can assess eyeballing.
It's normal only.
CT scan. CT scan.
Can. I may choose BTB here.
Not
BTB
much.
BTB and LET.
Yeah, BTB with LED. Yeah, Deepak.
I'll take a Peroneus longus and we may do an LET along with it.
Yeah.
Same idea.
Maybe you want the robust graft like Peroneus longus. Yeah,
Peroneus LET.
correct. So this what I did is this. This is Raman technique, quadriceps. Just little bit lateral to the midline and only superficial part of the quad tendon. The graft was almost 300 millimeter and quadruple and reconstructed and fixed with the hybrid like underbutton and the interferential screw in the femoral side and tibial side suture wheel. Okay. Thank you very much.
Thank you.
Thank you. Thank you.
आज जाते वहां पे रुकते फिर
Sorry.